सुनता है ना? Good morning. Good morning. Hello.
Hello.
Good morning to one and all present here.
Hello.
Yes, I can hear you, sir. Hello.
Hello.
Hello. Hello.
Hello.
हॅलो. गोपाल घरे सर, इथे डॉक्टर प्रिया आहे. तिकडे आवाज ऐकू येतोय का इकडचा?
भी वो डिस्प्ले किसका दिया है? लैपटॉप का दिया है। मेरे को लगता है इधर से बेटर रहता है। आप यहाँ से कोई तो एक बैठेगा, आप वहाँ से बोल दीजिए, लेकिन सीवी यहाँ से प्रेजेंट करें।
हॅलो. हॅलो. हॅलो.
फिर उधर से ही करो।
हेलो।
करोगे ना आप?
Hello.
Hello. Are we
Dr.
audible?
Priya.
हाँ sir.
Am I audible? This is Dr. Gopal Gare.
Yes,
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 sir.
sir. You are audible. Am I audible there, sir?
Yes, very much.
Yeah. येते.
Okay, so I welcome all delegates for this second day of workshop, Endoscopy Masterclass. And in Theatre 1, we are ready with diagnostic histolaparoscopy. Here, I'll present this lady. She is 28-year-old, nulli gravida, married since 6 years. Case of primary infertility. Actually, she is unexplained infertility. Her ultrasound and clinical examination, everything is normal. Semen parameters are normal. So we have posted her for diagnostic histolaparoscopy or fertility enhancing surgery. Here we will be demonstrating histolaparoscopy as well as the tubal cannulation. So in this OT, we have Dr. Swapnil Dakne sir, who is the surgeon, and Dr. Pranali madam and Dr. Charvi will be assisting him. We have system here, complete system, histolaparoscopy unit of Pranav Medicare. So friends, we are looking forward for a wonderful demonstration of histolaparoscopy in this theater with Dr. Swapnil. So in few minutes, the laparoscopy, hysteroscopy videos will be relayed to you. Thank you.
A very good morning to one and all present here. Respected dignitaries, esteemed guests, and my dear friends. I am Nisha Kundar,
And I am Alisha Sheikh.
and we would like to welcome you to the Obstetrics and Gynecology Endoscopy Masterclass.
We are honored to have you join us for this groundbreaking event dedicated to exploring the cutting edge advancements in minimally invasive surgical techniques with our specialty. Throughout today's sessions, you will have the unique opportunity to witness live endoscopic surgeries conducted by renowned experts in the field.
These demonstrations will showcase the application of laparoscopy, hysteroscopy, and other innovative approaches in treating a wide range of gynecological conditions.
Each procedure will be accompanied by insightful commentary from the surgeons, offering valuable insights into surgical techniques, anatomical considerations, and patient outcomes.
In addition to live surgeries, our program features engaging lectures, panel discussions, interactive question and answer sessions designed to deepen your understanding and stimulate meaningful dialogue.
Whether you are a seasoned practitioner or a trainee, this conference promises to enrich your knowledge, expand your skill set, and inspire new approaches to enhancing patient care.
We thank you for your participation and look forward to a day filled with learning, collaboration and pursuit of excellence of OBGYN endoscopic surgery.
We hope today's lecture inspires you, enhances your surgical knowledge, and fosters a collaborative environment where learning thrives. Without further ado, let us begin with the next session. For this, may I call Dr. Priyanka to the dais.
So friends, here we are starting with very first case. Dr. Swapnil will be putting trocar by direct trocar method. So I request the cameraman to focus on the trocar entry. So this is direct trocar entry.
The case that is being shown is a 28-year-old nulli gravida with primary infertility. Her main complaint was inability to conceive since 3 years despite regular sexual intercourse. She is married since 3 years. Her menstrual history is regular cycles with normal flow and no dysmenorrhea. Her last menstrual period was 26th of June 2024. In the past, she has taken 2 cycles of ovulation induction with timed intercourse, and there is no significant medical or surgical history. The husband history is not significant. Coital history is with a frequency of 2 to 3 times per week with no dysmenorrhea or other complaints. On examination, everything was normal. The uterus was of normal size, anteverted, and nothing significant. Pap smear was NILM. Husband semen analysis is also normal. On ultrasonography, the entire scan is normal. So the plan for today is fertility enhancing laparohysteroscopy with tubal cannulation. Thank you.
What was just shown was a direct trocar entry. Ideally, we use a Veris needle, which gives us a safe platform whether we are inside the abdominal cavity or not. But then with experts, even direct trocar entry can be done as it is shown now.
So here we are inside the abdominal cavity. So after direct trocar entry, pneumoperitoneum is created. Now surgeons will be putting the side trocars or ancillary trocars. So again, this is whole system provided by Pranav Medicare. Everything on the trolley is by Pranav Medicare. So this is entry of the side port under vision, 5 port for hand instruments. So first port is inserted around 3 centimeter medial and above to the anterior superior iliac spine. And second is in between the main trocar and the first port. So step by step for fertility, we'll be exploring the pouch of Douglas, bilateral tubes ovaries, tube ovarian relationship, ovarian fossa, I hope this scopic picture is there visible in the auditorium.
Yes, sir.
So from laparoscopic view, everything appears normal. Both the tubes, both ovaries, uterine surface is normal. There is a very small, probably subserosal fibroid, which doesn't need anything. So now we'll go to the hysteroscopy part. So the head lobe which was given during laparoscopy, now it is corrected when he has gone to hysteroscopy end. So this is maybe conventional method of hysteroscopy. We are using same speculum, valsellum.
We are not able to visualize the hysteroscopic part.
We are yet to insert the hysteroscopes in the instruments are of different make and different places and cities. We are just orienting to attaching the instruments, assembling them. So just give few seconds.
First is then infertility, laparoscopy. So now just before doing the hysteroscopic visualization, we are doing the dilatation of the cervix. See the way he is holding the Higa's dilator, it has to be held in a pen hold fashion. You should have a proper grip on it so that it should not just go inside and perforate, so that the grip is most important in this. Before doing this dilatation, first we should be very sure regarding the position of the uterus. For that, upper vaginal examination should be thoroughly done so as to know whether it is an anteverted uterus or a retroverted uterus. Because while inserting the dilator, if you are putting it in the anteverted direction and the uterus is retroverted, what are you going to achieve? Perforation, right? So that's why before inserting the dilators, you should be aware what is the position of the uterus so that you can put on the dilators also according to the direction of the uterus. Here he was putting it in the anteverted direction. And see how gently he is doing it.
So here since we are using the conventional telescope, that is 4 mm hysteroscope with the sheath, so it becomes bigger actually, so we need dilatation. So here you will be actually seeing the histomat being used. We don't routinely use histomat, but today we are fortunate to have histomat from Pranav Medicare.
So now that we are entering, you have to follow that black hole. That is the one which will lead us to the uterine cavity.
So actually, we had some difficulty with the instrument. It was a larger outer operating sheath. Now we have changed to the diagnostic sheath. We are inside the uterine cavity. So this is one ostium.
ते बायोप्सीचं ग्रास्पर चांगलं आहेत का ग्रास्पर कुठला आहे दातवाला आहे दातवाला आहे का विचार आहे का विचार स्टोअर्स वाल्याला आणलं असेल चलो हाँ ये बस है. Focus start झाले का? Am I heard? In the auditorium? Then we can just show them this, no? उधर ऑन है, मैं सुन रहा हूँ. Yes, Dr. Vaishali madam, am I audible? नहीं तो करना.
Yes, sir. Yes, sir. You are audible.
Okay, can you see me?
No, sir. We cannot see your OT.
Okay, the screen, because I thought I'll explain you the.
Yes,
basic
yes, sir. Now we can see you,
instrumentation.
sir.
You can see my, yeah, इधर focus करो. Can you see the instrument?
Yes, sir.
So this is the 5 millimeter Betoki sheath, which is operative continuous flow, and with a 30-degree 2.9 millimeter telescope. This is the 2.9 millimeter 30-degree telescope. You insert it, there are markings and zero marking, which I'm sure all of you must have seen. Lock it so that it is stable in place. Now the one which is closer to the surgeon is the inflow. The one which is away is the outflow. And this is the operative channel, which is called 5 French or 2 millimeter. Means 2 millimeter instruments can go through this and carry out. Now today, hysteroscopic surgery has changed drastically. Almost 50 to 60% of surgeries can be done by this single instrument with the help of scissors or graspers or electrodes. So I will just demonstrate to you the basic way of doing hysteroscopy today. Now today one has to be very, very sure that you are not going to dilate the cervix at any cost. Dilatation of cervix and intrauterine surgery, we all have done, and that has been a biggest curse for gynecologists, for women in general, and we were the one who were doing it. Everything blindly. Can you tell me in medicine, any branch where they do surgery blindly? We all entered uterus blindly, we all operated inside blindly, and I don't have to explain the amount of complication which has occurred to women from our hands. Means that is today not acceptable. Everything is under vision. Entry into the uterine cavity, all procedure into the uterine cavity should be done without dilatation. So no blind entry. So today we are going to see how to enter the cervix and the uterine cavity without dilatation, but I will be also demonstrating to you at the same time without speculum, without valsellum. Even if you're used to using valsellum and speculum, fine, but don't dilate. You can hold the lip of the cervix and enter under vision. But you will start seeing that now today I find it much easier to enter without holding the valsellum. But as a beginner, even I was feeling that holding the valsellum and the speculum was easier to enter. But today, if somebody tells me hold it, I fumble. So I have learned this way, and I find this is much easier to enter. And that's what I'm just going to show you.
Yes, sir. So the case that is being shown here is a 47-year-old para 2 living to tubectomized woman with AUBA. She had complaints of heavy menstrual bleeding with passage of clots since 1 year. In her menstrual history, she was having irregular cycles coming every 40 days and lasting for 10 days with heavy flow and passage of clots. Her last menstrual period was on 22nd of June. In her obstetric history, she has both previous vaginal deliveries. There is no significant medical or surgical history. On examination, all her findings are normal. Uterus is normal size, antevertive, the bilateral fornix is free. Pap smear is NILM. And on ultrasonography, the uterus is of normal size. Endometrial thickness is 6 mm. And the myometrium is heterogeneous with possibility of adenomyosis. The plan for today is diagnostic hysteroscopy with endometrial sampling with IUD, LNG IUD insertion.
Okay, so you are going to insert LNG IUD. Fine. So now there is no diagnostic hysteroscopy these days or laparoscopy. We everything say therapeutic. So now one shouldn't put in a telescope or subject a patient to a surgery to diagnose something. Everything is now diagnosed by our imaging. Our imaging has become very strong. Now, how to enter? Can you focus on the external hand here? Now, this is the way you hold the whole system. You can see my palm supporting the head of the camera, which is the ABS part, the telescope, which is the most delicate part, and even the light cable. See, I'm holding everything in one palm without using the right hand. My right hand has to be free because I have to operate. Problem with hysteroscopic surgery is only one hand. So your dominant hand will be the one. So try to practice everything with your left hand entry into the uterine cavity. So this is how we also see. I would rotate the cable if I have to see the right side of the uterine cavity. With my finger only I will rotate. I won't use my right hand. Can you see how I do?
Yes,
This
sir.
is the way you should learn to use your phalanx. Every part of your finger, the terminal phalanx, you should be able to move it. See, this is how. So you don't have to do this, and other thing. So your right hand is all the time free, because when I'm operating with right hand, and if I have to do something on the right side of the cavity, I'll just quietly rotate my telescope here. As a beginner, of course, your assistant or your sister can hold it, but I am supporting it also, so I don't allow it to fall. Sometimes it will start falling every time. So this is how we support. See, it is very easy and very simple. Only our mind has to accept it. So we'll start off with the fluid. Now always make sure that the tubing is free of air bubbles, because the first and fatal complication with hysteroscope was always air embolism. Everybody was worried. So now air embolism cannot occur in a routine case. But if you don't take care, now you can see the posterior fornix very clearly. Can you see the posterior fornix of the vagina?
Yes, sir.
Then you see the smooth surface. Then you come back, you see the smooth cervix. Initially, you can pinch the vagina if you want to. This is the
Please show
cervix.
both the cameras, sir, the external vision and out the internal vision of this OT only. Krishna Kumar sir, the
Yeah.
internal vision which we are seeing here is from the other OT, so we are just trying to adjust that. So
Okay.
we get a fair idea, and we also see your hand movements at the same time. Yes. Yes, sir, we have got both the views of your OT. We can go ahead, sir.
So I'm entering the cervix now. Can you see? Now identify the anatomy in hysteroscopy starts from the vagina. You see the external os. Now she's got normal delivery, so her definitely os will be open. Now you can see the os already, external os opens up. Even in a nulliparous woman, there is no instance or requirement for the os to be dilated. So and then you follow the mucosal fold. And always keep it at 6 o'clock position. See that your hand has to go down. Now the internal os is almost close to 3 o'clock position. So I have to get it at 6 o'clock. So I have to take my hand down. My external hand moves down, but here, of course, unfortunately, the internal os is a little smaller, maybe cicatrized, you can say, but again, you have to learn how to enter there without, I will follow this. Hystromat is something which is giving a pumping effect. It is not giving a continuous flow. Gospies. Both leak hota hai. No, this washer is leaking tremendously. खूपच leak होतं. एवढं नाही leak होतं. Washer change करा. I didn't check. Now just keep on progressing at the point where the internal os is. See that it is opening up. Can you see?
Yes, sir.
Dilatation under vision.
Yes, sir.
Even if it is not allowing you to enter, I will enter only under vision. Can you see how beautifully we can dilate?
Yes, sir. Yes.
With that, otherwise blind dilatation, we all just put tuck and we enter wrong. Here, absolutely smooth. No debris, the cervix or the endometrium didn't get lifted. Can you see that?
Yes, sir. Wonderful.
Now go up. Absolutely no blood. So the virgin view is important. Virginity is important everywhere, and even if you dilate, you will lose the mucosal folds. You won't be able to identify the internal organ. Here I could see, but absolutely no blood. And the moment you dilate, you have so much blood and debris, and then you start washing it. And then you say it takes taking time. But if you have anything without blood, you are always very confident, exact pathology you diagnose. Otherwise, blood-stained areas. So this is the left ostia. Can you see?
Yes,
Once
sir.
you are entering into the uterine cavity, you always see the anterior wall. With a 30-degree vaginoscopy approach, the rain is from above. The water is from above, inflow. The light is from below, sun rises from below. And then you enter, you see the anterior wall. Just above the internal walls, you stand, rotate the cable. See, you can see I am rotating the cable with my left finger only.
Yes, sir.
And there you can see some posteriorly, there is a little vascular hyperemic area.
Yes.
Now I see the right ostia. I just turn the cable without turning the camera. I see the right ostia. But of course, now if I have to see the posterior wall, I will have to use my right hand to see the posterior wall because the cable has to be rotated. You can see this area looks a little more hyperemic, and maybe it's an endometriosis area where you can see a little dark tarry area. But otherwise, the cavity is okay. So any questions as far as entry technique is concerned? Do you all appreciate that how easy it is to enter? And if I have to take a biopsy, this is a right lateral. See how to take a biopsy. Open it up. This opens up to 6 millimeter. These two hands of
The
prongs of the
prongs.
instrument.
Yes, sir.
Now I will just dig it into the substance. I have taken a grasp. I will try to move it away. See, now I am pushing it on the other side. Now still the base is quite strong. So I will need to release it. This is a little broad-based polyp, if you can see. It's a local sessile polyp. Now move the hand to the opposite side. I am detaching it from the attachment. Can you see? My
Yes.
hand is moving to the opposite side of the uterine cavity. You can use scissor, but I am just showing you how to take a nice grasper and biopsy. See, we have almost taken the whole chunk now. Push it to the opposite side, and
Yes,
that's all.
sir. So we can make out you're pushing it to the opposite
Yeah,
side.
so that's
Yes.
how it comes out of the attachment.
Yes,
So
sir.
now I pull it. Now I'll just take a better grasper of it. Moment you leave it, the water is not allowing you to, catch it. So what you will do, you will try to corner it. Now it's partly attached to this, so it's become moving in. So what we will do is put it in a one corner. And this is a pumping stromat. So that is where it creates more trouble. The water is being pushed in small pumps, pressure. So it keeps on moving. So anyway, we'll just अबे तेरे के ठीक है थोड़ा सा फ्लो बंद कर माझा फ्लो बंद कर इकडनं हो बंद कर so that time you just stop the flow so that आता चालू करा आता नाही नाही परत एस्केप झाले पाणी बदला ना 3 लिटरचं आहे की तुमचा 1 लिटर ठेवलाय
3
ठीक
liters.
आहे नो प्रॉब्लेम वी विल जस्ट wait I'll take it out later I'll just take a biopsy from the posterior wall also थोड़ा सा क्लीन कर नाही नाही ते नाही काढायचं कशाला काढायचं दॅट इज नॉट टू बी रिमूव्ह नाही नाही हे कॅमेरा काढायचं क्लीन कर इकडे पाणी गेलं ना थोडं नको नको बंद कधी नाही करायचं बिकॉज द मोमेंट यू लूज द डिस्टेन्शन ते पण क्लीन कर द युट्राइन कॅव्हिटी विल स्टार्ट ओझिंग so water flow should be always continuous या पानी स्टार्ट करो पानी बंद किया है क्या बंद करो नका ये इंस्ट्रूमेंट This is not the right way to use an instrument. And your washer is also leaking like a tap from here. See this? Because the vision will become poor, I want to show how to take the biopsy from the posterior part. So you saw how to take a biopsy from the lateral wall. With what I said, the moment you have blood and things, your cavity or the vision becomes so bad.
Yes, sir.
So that's why always avoid bleeding. Focus तर आहेच. हा ठीक आहे. नो प्रॉब्लेम. आपण आता कुठे होतो ते दिसत होते ना आपलं.
पेपर पाहिजे. पेपर पाहिजे.
हा हा तर कालचा बघायचा मला.
पीछे वालों को भी
छोड़ो छोड़ो 1 मिनट.
क्वेश्चंस पूछे.
पाणी. अरे बाबा.
मेरे पास देने.
See again how to take a biopsy. You just hold the tissue, grasp it and start pushing it to the other side. There are of course different type of graspers available. The one with a little teeth is always a little better. This is a spoon grasper, no? Yeah, this is a spoon grasper. ये वॉशर देऊच नका मला. Change the washer of इसके बाद. Now hold it, don't pull it into the tissue, into the system. Just keep it out and take out the whole system out. पाणी बंद कर, पाणी बंद कर. And close the inflow. And you have the, can you see the tissue coming out?
Yes, sir.
Yeah. बंद करो. So you want to put the LNG ID? ये change करो. So any question as far as?
Yes, sir. The audience has one question here that
Yeah.
once we remove such polyps or take a biopsy like this, and if the bleeding starts, then what
No,
can
no,
we
no.
do
This,
to?
from these areas, the bleeding will be negligible. You don't have to worry about bleeding at all.
Okay.
You all are doing MTP.
Yes, sir.
And that is a vascular stage. Do you sit and cauterize? Have you ever seen inside the uterine cavity? No.
No, sir.
It will automatically stop.
Yes.
Pregnancy vascularity stops by your suction, curette. We do so many things inside. It doesn't bleed. Even vesicular mole. We
Yes, sir.
give all those oxytocics, but it doesn't bleed so much, and that way a non-pregnant uterus
Can we
taking
have
out a polyp is all absolutely safe.
Vaishali madam?
Yes, sir. Yes, sir.
Can we have this video picture of OT1? Actually, we surprisingly found a septum in this patient, infertility patient.
Okay.
And we have Dr. Anurag Bhate from Mumbai
Okay.
cutting the septum with scissors, coat
Okay.
scissors.
Okay.
So I request the operator to switch the.
Yes, we can see now your
So this is
septum.
the septum which wasn't diagnosed or anticipated. And this was a surprise.
She is
So
a
we could
Paris
diagnose
lady
and now
with
treat it
removing
as
vagina.
Krishna Kumar sir very well
She
said,
has
can
lot
never
of
put
cystic
a
seal, rectal
scope for
seal.
diagnosing things.
That's why the mucosal folds are so much.
This lady is actually day 10 of cycle, so she had abundance of endometrium, so there was some difficulty. But now we can see the septum, which can be easily cut. There is no
आता
bleeding.
आपल्याला
It's
हेच
plain
करायचं ना,
scissors.
direct.
Yes, we can see the one ostia, sir. So
Yeah.
this was a partial septum, right, sir?
Yeah, this is a partial septum.
Yes.
Blood. See the blood which is there once you are doing even a diagnostic or whatever it is, this blood
It's
will
always
obscure
better
your
to
vision.
undercut. Okay. One, always just refashion it and wait for some vascularity. That is the only reason why we are cutting it. Now you see a vessel there.
Yes, we can see the vessel. Dr. Anurag, your mic needs to be adjusted
No,
a bit.
I am not on the mic. I'm
Okay.
just speaking.
Okay.
Now
We can hear you, but the sound is little. Yes, we can see the vessel. Yes.
leaders.
Yes,
So I
yes.
think that is a full job. We have a good cavity now.
Yes.
I'll just in a second show you. Yeah.
So our audience would like to know that when exactly you stop.
See this. You see this ostia and this ostia now in line.
Yes.
Yeah, that is
हे
the point
तुमचं
where you stop.
posture आहे.
One.
Yes.
भयंकर
The
लीक आहे
vascularity on
वॉशर
this
सर्व
septum.
आपलं ते वॉशर काढा
You stop, you
next
don't
case
go
ला.
and cut the
हे
myometric.
नाही
That's
चालणार
it.
आउटफ्लो बंद ठेव आउटफ्लो
Now we
बंद
have a
ठेव
good cavity. Okay.
Okay, fine, fine.
Nice cavity. Good enough.
This is where we have taken the biopsy initially. मैं चाहता था this.
Is Krishna Kumar sir showing anything? If this scope is out, can we go to that OT? Krishna Kumar sir, we are with you now.
Yeah, we have just reintroduced to take another biopsy from that posterior part
Yes.
which we were seeing.
Yes, sir. So
So-
that was the part of the question, that if we have to take two biopsies or we have two polyps,
Yeah.
then suppose after removing the first polyp, if the bleeding starts, how to improve our vision was the
Nothing,
question.
you just see what you have to do is what I did. There was clot right in front of the internal os.
Yes,
So
sir.
what you have to do is bring out the telescope. The water flow will gush it out.
Yes, sir.
You don't have to do anything. Open the suction, but the clots usually are troublesome. So you'll have to just take out inside and come back, go inside and come back, like flushing. So the
Yes, sir.
moment saline goes in and comes out, the clot will follow the saline and come out. So if you are observing my movement that time and there was a big clot right in
Yes,
front of
sir.
the internal os,
Yes, sir.
I was doing the same thing and within a second I could enter the uterine cavity.
Yes, sir.
So appreciate the uterine anatomy to enter very safely. We all talk about laparoscopic anatomy, but vaginoscopic or hysteroscopic anatomy, always I like to highlight, which I did right now. Okay. Band kar, pani band kar. Yeah. So this patient, of course, there is no TCRE. I think you are just planned for a diagnostic scopy, biopsy, and a LNGID,
LNG.
right?
Yes, sir. Yes, sir.
Okay. So any more questions?
Sir, people would like to know more about Histromat because many of them don't have it. So
Right. Now,
kindly.
of course, we will focus on this particular instrument, but the main trick is what should be the inflow and what should be the outflow pressure,
Yes, sir.
right?
Yes, sir.
Now, uterine cavity is a closed structure. The muscles are strong, unlike the bladder which distends with the urine. Can I get this fixed? So, the pressure required to distend the cavity and see inside, what is the pressure? What is the pressure required to see the uterine cavity?
60 to 70 is the answer here.
Right. It is roughly about 45 to 60 is the intrauterine pressure, but there is no way to determine the intrauterine pressure. There are machines which had come. Sound hai kya? Otherwise, give me the mirror. Yeah. So intrauterine pressure is 60. At 70 intrauterine pressure, the tubal ostia starts opening up.
Okay,
So the
sir.
ostial opening pressure is 70. Means what? If your intrauterine pressure goes above 70, the fluid will go into the peritoneal cavity.
Yes, sir.
So this physiology is important in certain instances. Like if you are doing a patient with a suspected endometrial cancer,
Yes. Yes,
you
yes.
should not use very high pressure. Because if you're going to use very high pressure, you're going to push more cells into the peritoneal cavity.
Yes, sir.
So of course, there are theories which say that nothing happens, but then keep the cells spilling into the cavity much less by using lesser pressure. So in a postmenopausal lady, we use a lesser pressure, but roughly we just calculate 150, 120 to 150 should be the the instillation pressure or the inflow pressure. But the pressure is lost in the tube, pressure is lost in the leakages. So outflow pressure we maintain between 50 and 60, hoping that you are creating a pressure intrauterine up to 70.
Yes, sir.
Now, why this pressure and all this is important in gynecology is for the simple reason you have to know the mean arterial pressure and the venous pressure. The venous pressure is supposed to be 15 millimeter. The moment you are above 15 millimeter, your blood is fluid is going into the system. So that is where hysteroscopy fluid starts going into the system. And your arterial pressure mean we say between 70 to 90 or 85. And if you are doing a myoma resection and if small arterioles are opened up and if your pressure is above 70, it will go into the arterial system, and that is where pulmonary edema and fluid overload problem occurs in hysteroscopy. So you have to know three things, more things. One is what is the flow rate per minute in hysteroscopic surgery. We all talk about CO2, 5 liters, 8 liters, 20 liters, nothing happens. You are pushing carbon dioxide into the abdomen. But if you come with the same mentality here, it is not. Hysteroscopy, the inflow per minute rate is 50 to 100 ml per minute in diagnostic scopies. In operative, it is 200 to 250 ml per minute. Means if your 1 liter saline is getting over in 2 minutes, that means you're pushing the fluid too much into the body. So your 1 liter should last at least 5 to 7 minutes minimum. I mean more than that. If you're using more of saline, that means your vessels are opened up and either it is going into the abdomen and at the end of the surgery you will find our abdomen
Yes.
distended or you're pushed into the pulmonary edema.
Yes,
So
sir.
that is where we keep a count on the fluid which you are being using. So if you are using more than 6-7 liters, your outflow should be definitely measured. That is where the fluid deficit starts. So I'm sure yesterday somebody must have spoken about
Yes,
fluid
sir.
overload
Fluid-
and how to
yes.
manage it.
Yes.
Yes,
But
sir.
just in simple terms, flow rate is 50 to 100 ml in diagnostic, 200 ml in operative, and pressure is 45 to 60. Intrauterine pressure, we keep it by keeping it about 100, 120 and outflow at 50. But you should be able to see the adequate pressure should be what you should at least see the cavity properly. If there are leakages from the side of the canal, you will have lower distension. So just increase it. Certain surgeries, more pressure doesn't make any difference, like septum, Asherman's. It doesn't make any symptom because the vascularity is not much, the fluid intravasation is not much. But TCRE, myomectomy, the moment your pressure goes up, your opened up vessels, the fluid will go much faster.
Yes, sir.
So, thank you.
Thank you, sir.
Yeah.
First case was very nicely explained, and now they have a good idea about how to have the hysteroscope inside without dilatation, and how beautifully you showed us the vaginal mucosa and then the cervix opening up beautifully and the virgin plane of the cavity. We all could appreciate that. And also we could learn how to remove the polyp or take a biopsy. Beautifully, we could make out the hand movement, like once you caught the tissue, then you moved the scope on the opposite side, and that really helped. So we could appreciate that. Thank you for this demonstration, sir.
Vaishali
Thank you.
madam.
We'll be ready with the next case.
Yes, sir.
Just
Yeah,
give us 10,
we are
15
done with
minutes
this
here.
first case here. We are resection of this septum.
Yes, sir.
Bilateral tubes were patent. Here I would like to welcome Dr. Manish Machwe sir. He is with us in theater 1.
Yes.
So welcome Manish sir. Just say hi to the audience.
Hi,
Yes,
good
we
morning,
welcome
everyone.
Dr. Manish Machwe and Dr. Anurag Bhate, sir.
Hi, good morning, everybody.
Good morning.
Please ask a lot of questions. The best question will get a prize from Dr. Vaishali.
Yes, definitely.
And it will be iPhone 14. So please ask a lot of questions.
Yes, definitely. We will go ahead with it. And the first question to you is, you have the septum resection in your OT just now beautifully demonstrated. So what precautions you are taking or anything else we have to do after resection of the septum?
So I give mic to Dr. Anurag.
Yes.
Hi, good morning.
Good
See,
morning, sir.
This was a, maybe you can call it a partial septum. So in this case, you can just give 2 months estrogen progesterone. But if you find that the septum is big and there is too much bleeding post, you cut the septum with cold scissors. If you are using a resectoscope, obviously you will cauterize the bleeders. Then you can put a 8 number Foley's for 3 to 5 days and keep it in the uterine cavity. It will help to prevent the adhesions as well as the bleeding also will stop.
Okay, okay.
Dr. Anurag Bhate, or anyone, Manish? This is again a question because there are postgraduates in the audience. Even if you see a septum, like it happened right now with this case, it was not diagnosed before. We were doing a fertility enhancing laparohistro. So, which septums would you necessarily resect, or do you resect any septum that you see in an infertility patient?
Good question. Initially when we decided, we just saw a septum. So actually, if a patient has any previous history of miscarriages, and then you put up for a scopy, so then in such cases, then it is ideal. If you find a septum, then it is ideal to resect a septum. In primary infertility with no history of any previous losses or anything, you find a very small septum, you have to judge if the septum has vascularity.
Okay.
Many times there are fundal adhesions which look like septum.
Yes.
So you have to really distinguish between those fibrotic bands. If there is vascularity, you can leave it. The pregnancy will happen and it would continue.
Right.
But you find that the vascularity is not there and they are white, tough bands, then it's always better to give cut.
Right, because of the implantation failure is 100% if these avascular things are
Yeah,
left over there.
ideally, if you put a laparoscope and you see the shape of the uterus and you find a fundus to be flat,
Mm-hmm.
mostly then you will be needing to cut that fibers. So,
Okay.
then you get a good cavity inside also.
All right. Thank you.
So for this first case, I
Anybody in
thank,
the
Dr.
audience have more
Swapnil, Dr.
questions?
Anurag, Dr. Pranali, and Dr.
I would
Manish for
really
just
encourage
supervising
the
us.
audience to please ask
So we'll be
questions.
shifting this lady. She'll be extubated soon, and then he'll take another case. Thank you.
So while the surgeons are free, you can also take that opportunity to ask any general questions which may not be
So here,
case
all
related.
4 surgeons are free. All 4 guest surgeons are free. Rather, Dr. Krishna Kumar sir is also there. So I give mic to Krishna Kumar sir.
Of course, good morning, everybody. I forgot to
Good morning.
thank the MIMER team led by Dr. Vaishali, Dr. Sharma, and others for having me here. This is like a pilgrimage to me, annual. This is the 4th time I'm here in July at the MIMER Center, and it has become absolutely like homecoming. Of course, there are many reasons to that, and I enjoy coming here every time. And the staff and others also are very cooperative. And of course, the basic idea is to teach you all. Till last year, it was only hysteroscopy, and this time an additional flavor is added with laparoscopy, with 2 of our close friends, master laparoscopic surgeon, Dr. Anurag Bhate and Dr. Manish Machwe. You all must be knowing them. They are giants in their field. They are also there. I'm sure yesterday they must have given excellent lectures, and today they are going to demonstrate some excellent cases.
Yes, sir.
Now,
It
coming
was
back to hysteroscopy, of course, laparoscopy is something totally, the approach is different in hysteroscopy. Hysteroscopy is a very small cavity, intrauterine cavity. You have only one hand, whereas laparoscopy, you have 3 ports. You have at least, you can additional ports you can put, means almost there can be 5, 6 hands helping each other. So the limitation of the openness has been now mitigated by multiple hands inside the uterine cavity. But hysteroscopy is still the same problem. You have only one hand to operate inside. The cavity size is small, but basically, if you have only one hand, everybody was using resectoscope for everything. But today, there are additional gadgets which have come. And as I just mentioned in my presentation, that we were all doing only one intrauterine surgery, we were all doing is only DNC. And we were calling ourselves qualified doctors. Can you imagine anybody doing blind surgery today? how can it be even answered that I entered your uterine cavity and I entered into a wrong plane and I've damaged your bowel, I've cauterized your bowel. So thus those excuses today are not, we can remember all our past days when so many women have unnecessarily undergone exploration for bowel injuries, vascular injuries. So today, no gynecologist can be called a gynecologist if he or she doesn't know to do hysteroscopy. So that message has to be first conveyed. Now gynecologists are now talking of, I'm not interested in obstetrics, I'm not going to do laparoscopic surgery, I want to do only infertility. But even in infertility, your hysteroscopy will be after you. You cannot have no knowledge of hysteroscopy. Laparoscopy, of course, we have great mobile surgeons all over the city moving in. But hysteroscopy, you should be able to do it yourself. You can give so many answers. So learn hysteroscopy, and learning hysteroscopy is very simple. The reason why people were hesitating. Now in the last 10 years, we are seeing so many people really learning hysteroscopy. But till before 2010, anybody who wants to start endoscopic surgery will buy a laparoscopy set and will start drilling the ovaries and ectopic. But hysteroscopy, nobody will buy. Today, workshop conferences are held. Hysteroscopy will be hardly maybe 2 or 3 surgeries in that full 12 hours of surgery. There only 3-4 surgeries will be shown, and that too the screen time will be hardly 5 minutes, 2 minutes. They will immediately shift. So such workshops where focused hysteroscopy training is going on, I always enjoy coming because you can explain better. Everybody understands the importance of hysteroscopy. But as I said, to learn hysteroscopy, first remove that dilator from your trolley. Trolley should not have dilator at any cost. No, you can have speculum, you can have valsalum, but no dilator, because no blind entry. Enter under vision. Always, because if you can follow the anatomy, the canal opens up, the internal opens up, and there is hardly any chance of false passage, perforation, and absolutely the surgery becomes more enjoyable, more faster, and much simpler and less traumatic. So this is where I would, of course, keep on telling you the various tips and tricks of doing proper hysteroscopy. You saw a partial septum here, no? So I think that OT we are starting with a septoplasty only again.
Yes, sir.
Now again, one question you were asking, I think Anurag, where to end or whether to cut a septum if you see.
Yes.
Now today, as I said, the whole dictum of diagnostic scope is gone. Your septum should be seen in your sonography. In your whatever 2D or 3D, you can diagnose septum preoperatively. It should not be a surprise in camera inside the operation theater. But unfortunately, if you still find a septum, whether to cut or not, that will be the debate. Now, if it is a septum, means if it is something 1 centimeter and above, I would feel that you should cut it and incise it and leave it. And of course, you have to do it with scissors. If you're doing with scissors, it is less traumatic, less dangerous. You don't have to put that resectoscope. So if you're able to cut with scissors, go ahead and cut it. That should be the principle. Of course, there are various papers now coming up whether septum causes abortion, it should not be left. But I don't think that argument stands valid as of today. The incidence reported with about abortion is almost 85%, and we all have incised the septum in so many cases, and everybody has done much, much better. And in Indian scenario, you can't tell the patient that evidence doesn't say you become pregnant after 2 abortions, I will come and remove the septum. Our Indian patients are not going to accept it, agree to it for various reasons. So let's not argue on that. I would incise a septum even if in a patient with primary infertility, it is anything more than 1 centimeter, I would incise it. And where to end is, again, I'm sure Anurag did mention about it. The cornea should be always a little deeper than the fundus of the septum, uterine cavity. You don't create an umbrella, whereas you create only a arc. This should be the ostia and this should be the fundus. So that's where you stop.
Yes, sir. Yes. Thank you so much,
Anything
sir.
Anurag would want to add?
No, I think sir has beautifully summarized it. The
Yes.
concept of diagnostic hysteroscopy is not actually nowadays, it's always an operative hysteroscopy. You put a hysteroscope, you finish the job completely and come out. Only thing in this case, when we wanted to do a cannulation or a dye test, the only advice is you do a dye test or a cannulation if needed first and then cut the septum, because after that there will be entire thing will be intravesical and you will get a false result.
Yes. Thank you for such beautiful insight. We would like to thank RB Systems, which was used with Krishna Kumar sir's OT. And in the other OT, we have Pranav Medicare Distributor Om Surgical System, which was used in the other diagnostic scopy OT. We thank our sponsors, and we also would like to thank the Department of Anesthesia for being so cooperative. Dr. Shilpa Gurav heads the department, and there are other anesthetists like Dr. Anita and her team beautifully supporting this workshop. Yes, Dr. Manish.
Hi, so just one point, because sir brought it up that, if you find something when you're doing a hysto or laparoscopy, you need to resect or you need to remove that. So this I always say in my medical legal talks, stop using the word diagnostic histolaparoscopy. It is fertility enhancing endoscopic surgery. So your consent should mention fertility enhancing endoscopic surgery, so that septum, polyp, lateral metroplasty, ovarian cyst, drainage, endometriotic cyst, adhesiolysis, cannulation, everything can be put inside that, because that comes under fertility enhancing endoscopic surgery. So please stop using the word DHL and use FES.
Yes,
Sir,
and
when sir was president at IIG, I remember sir had this had very good discussion. So that is the correct consent that we need to take nowadays, so that all the procedures can be. Otherwise, if you just write diagnostic histolaparoscopy, and then you are unable to perform anything else other than diagnosis. So that is one take home, I think, for all of us.
yes, absolutely agree with you, Dr. Manish. And your presence here every year, our all residents have started writing OT lists like this, and we write fertility enhancing surgery, and that's a really our audience is also taking this message home. Thank you.
This theater one, we thank Dr. Uma, Dr. Anita, Dr. Lina madam for smoothly intubating, and now almost patient is extubated. We'll be shifting them out. So thank you, team anesthesia in both the theaters. Thank you.
So should we inform the audience the next cases which we are going to take? Dr. Priyanka, would you tell us the other case, hysteroscopy septal resection, I think?
Show you the maybe the resectoscope part. If
Yes,
the
sir.
case
Yes,
is not
sir.
started, I'll
Yes,
just
sir.
try
We
and
would
see
like
if
to
I
see
can
that.
organize, yeah.
Yes, sir. Please switch the camera to the other OT where Krishna Kumar sir is there.
The next case that we are taking in this OT is a 29-year-old para 1 living 1 abortion 2 with previous 1 cesarean section with secondary infertility. She came with complaints of inability to conceive since 1.5 years despite regular sexual intercourse. Her menstrual history is regular cycles lasting 4 to 5 days with normal flow. Her last menstrual period was on 12th of June. In her obstetric history, the first conception was a spontaneous abortion at 1.5 months of gestation, which was followed by a dilatation and evacuation. The second conception was also a spontaneous abortion at 2.5 months of gestation, followed by a dilatation and evacuation procedure. And the third time she conceived, she underwent a emergency cesarean section, which was preterm at 36 weeks in view of breech presentation. She delivered a female child, which is now well. In the past, she has undergone 3 cycles of ovulation induction with timed intercourse in the past 1 year, and there is no other medical or significant surgical history. On examination, all findings are normal. The uterus is of normal size, retroverted, and bilateral fornices are free. In the reports, her husband's semen analysis is normal, pap smear is NILM, and on ultrasonography, we found that the uterus is retroverted with a partial septate belonging to Escherichia class U2B C0, which is a partial septate uterus. The right horn of the uterus, the endometrial thickness was 13 mm. On the left side, the endometrial thickness was 21 mm. The left horn also showed a small lesion of 11 by 4 mm size in the fundal part, which had possibility of osseous metaplasia. Rest all fallopian tube and the ovaries were normal. So the plan for today is fertility enhancing laparohysteroscopy with septum resection. Thank you.
Thank you, Dr. Priyanka. Krishna Kumar sir, if you are free, there is a request from audience that can you please show us the histomat settings?
पण आता हिचं जे आहे ना हे सेप्टम वगैरे आहे यांचं करून डॉक्टर सर्विस म्हणून आहेत आमच्याकडे ते करतात मग त्यांचं आम्ही 3D करून व्यवस्थित मॅपिंग करून घेतो की कुठे सेप्टम आहे.
Priyanka, in your PPT, do you have that 3D picture of this patient? If
Yes,
you
ma'am.
can show that to the audience. Can we show the PPT here? Yeah, that's great. Yeah, so this is a 3D sonography of this picture, and you can see the septum very clearly. And also in one horn,
The left horn.
her
yes.
left and right horns are not equal, they are unequal. And in one horn, in left horn, there is one osseous metaplasia, the bright white spot which is seen. Maybe it is because of she has history of 2 MTPs done before. We don't know because this is not a registered case with us. She has her obstetric career outside. We don't know clearly, but this time she has come to our place, and this is what the ultrasound is showing. And we are planning to do septal resection and also try to deal with the osseous metaplasia. As Dr. Priyanka had said, she has first LACS for breech presentation, and septum is the reason for breech, very obviously. Can we get connected to the OT, please? Can Krishna Kumar sir hear us?
Can you hear me?
Yes, sir. But
Yeah.
we can't see you.
Right. The audio visual team, please switch on the camera system from here. Now, of course, today we have different type of resectoscope. Now, again, of course, I'll just touch upon every
Please,
gynecologist would want to know what should I buy in the initial.
sir. Yes, sir. Now the camera is on you. Yes, sir.
Yeah. So what to buy as a beginner is the question in hysteroscopy.
Yes, sir.
I'm sure yesterday instrumentation must have been told.
Yes,
If you are
sir.
buying one telescope, it should be a 2.9 millimeter 30 degree with a 5 millimeter operative sheath. Betoki model, continuous flow, inflow and outflow, like the one which we used. So 2.9 millimeter 30 degree with 5 millimeter sheath is one thing which you cannot miss. You have to use it because that doesn't require dilatation. Now 4 millimeter telescope which we are using, it will take in a 7 millimeter sheath. But the internal os is 4 millimeter only. So you will need dilatation. Again, blind dilatation. So don't buy that at the beginning. Buy this. And if you want resectoscope, then what to buy? We were all using the 9 millimeter, which required dilatation up to 9. Again, the same problem. But today, the resectoscope also has changed tremendously. 22 French is available. Then came 18 French. Now today we have 15.5 with stores, a true bipolar. If I get a chance, I would definitely show it to you how to use a 15 French or a 5 millimeter resectoscope. So again, that avoids dilatation and avoids all that blind entry, and you can use energy inside the uterine cavity like we used it within a virgin view. So the parts of the resectoscope, I will just show you. This smaller diameter, they have kept one on the trolley, 18 millimeter. Just इथे focus करो, नहीं नहीं, ये काट, ये wire cut. इथे focus कर. So you can see the inner sheath and the outer sheath. Are you able to see?
Yes, sir.
Yeah, again, the outer sheath has inflow and outflow. So this is the inflow, this is the outflow. There is again a mild difference. The one which is closer to the surgeon is the inflow, one which is away is the outflow. Now this is the outer sheath and the inner sheath will get locked into it. This is the working element of a resectoscope. Now smaller diameter telescopes or the resectoscope have no tubing here, no channel for the telescope, just to reduce the diameter. You can put it, once I'm fixing it, I'll show you, but this is the passive working element. We gynecologists use the passive one. The neurosurgeon uses similar resectoscope, but their resectoscope is small. They use the active one.
Active one.
Mean the electrode will be always outside the sheath. Uterine cavity is small, so you can't use that resectoscope because the electrode will touch the fundus when you are at the internal os.
Yes,
So
sir.
it will damage. So that is why we use the passive working element. And this is how, once we are showing a resectoscopic, maybe TCRE, I will demonstrate to you how to do resection, how to move your finger. But again, practice what I am showing you. Try to do everything with your terminal phalanx. Don't put your finger totally and struggle like this.
Yes, sir.
You should be able to do with just the tip of the phalanx for you to do a very comfortable and nice surgery. So I'll just show you some of the electrodes. Yeah, this is, can you see here?
Yes,
This
sir.
is a loop of this 18 millimeter resectoscope. Now this is the channel for the telescope to come out. This is where the 2.9 millimeter telescope will go through this. So I'm not assembling that because we may not be using it here, but this is a bipolar, this is an electrode, this is I think monopolar, bipolar. This is hybrid electrode which they have devised. This is from the new company, I think, Arbe. But we all have been using only because only stores had the whole set of hysteroscopic equipment till today. I'm first time using the hysteroscopic set from Arbe. Of course, Arbe is a long friend of ours. More than 20 years, I'm using their Arbe cautery, Arbe Vaio, which is a wonderful cautery, but first time they are coming into the market in hysteroscopy. But stores as a complete gamut, and we are all been so much accustomed to stores equipments in all diagnostic, in other operative sheets, in the resectoscope. It has always been stores. वॉशर चेंज केलं का आपला गॅप कुठे Yes. So again, just to show you
Yes, sir.
the oval shape of the Betoki model. Can you see this? This corresponds to the shape of the internal os. Flat, the internal os is not round. It is actually flat in a non-gravid uterus. A woman who has never delivered or conceived. So this is the flat which allows you to go into the uterine cavity without dilatation. If it was round, you would need dilatation. Again, this is the operative channel, this is the inflow, this is the outflow. And for vaginoscopy, water comes from above, light comes from below, sun rises from below. So we'll just go ahead, and this patient has a septate uterus and they're suspecting some osseous metaplasia, means maybe a previous product which has remained inside
Yes,
and
sir.
become ossified.
Yes, sir.
Scissors कुठला आहे? Sharp. Again, of course, just to show the instrument which we are using, you saw the grasper. हे scissor नको, pointed scissor पाहिजे. pointed scissor there. Can you see the scissor movement? One blade is fixed, the other moves.
Yes, sir.
When this scissor is opened up, the maximum width is only 2 to 3 millimeter. Whereas in that grasper I showed you, if you open it up, it is about 6 millimeter. So this is how the scissor moves. One blade only moves.
Yes, sir.
And for most of the cases, I prefer a scissor which is pointed. In assurements, everything, it becomes much easier than this rounded scissors. Now, these are all very nice scissors. Again, I think this is Stores.
This is toes, sir.
Yeah.
Yes.
So I'll just show you how to use it. And Stores has designed it in such a way. Can you see? The scissor will always open horizontal. Means when you're cutting the septum in the between, your hand is like this. See, you start cutting like this. You don't do it like this and cut, because you'll be hitting the head of the camera.
Yes.
And this is pointed towards the ostia, and you start moving it.
Yes, sir.
Pointed scissor अलग. ये टाकून ठेवायचं. विसरलो आज मी फोन बाहेर ठेवायला. चलो. So we are just going to use the same camera system which we saw, the Arbe one. And again, you can see the scissor is already in place. So the trolley you can see here, trolley dikao. See, a hysteroscopic trolley today is absolutely containing only hysteroscopy equipment.
Yes.
No speculum, no valsalum, no dilators, excepting a sponge holder. You don't need anything.
Yes, sir. We would like to thank Stores for providing all the hysteroscopy unit
Yeah, yeah.
for
They have
some.
even brought the 5 millimeter
Yes, sir.
bipolar resectoscope,
Yes.
a wonderful instrument. If any patient is there for that, I will definitely like to use it.
Yes, sir. We have, we will get the chance to use that also.
That becomes wonderful in postmenopausal women, or even in virgin women, in unmarried young girls who require some resectoscopic surgery. It becomes so easy to enter without any damage to the hymen. We call it as transhymenal hysteroscopy.
Wonderful, sir.
I'll be showing in my video presentation choosing the right tool today.
Yes, sir. We
So
are looking forward to it.
We start the inflow. Allow the bubbles to go. So today, now we are using the Hystromat from Stores. It is the Hamo Hystromat, I think, yeah. Let the fluid start going in. Of course, in vaginoscopic technique, the fluid most of the time will be wasted in the vagina, and that time the air bubbles also, get.
We would like to see, yes. So picture in picture, both the views, if you can show us. Yes, thank you so
You can
much.
see now.
Yes, sir.
We will be tracing the cervix. Raise your hand to go to the posterior fornix. And there you can see the cervix is coming up. Can you see?
Yes,
the
sir.
anatomy of hysteroscopy? Focus. Now the focus is better. You can see the mucosa. Now the os already opens up. So these are all multiparous women. That's why the external os looks almost like a mouth of a whale. Now keep everything under 6 o'clock. Now if I enter now here, see I'm hitting the posterior part of the
Yes.
canal. Can you
Yes,
see?
sir. Yes, sir.
So what I will do is I lower my hand. Can you see?
Yes, sir.
The moment I lowered, I am keeping that at the 6 o'clock position. The internal os and the mucosal folds should be kept at 6 o'clock position. Now it is still high, so I again go down. Can you see my hand?
Yes, sir.
I move down. There is no obstruction to my movement. I can enter very easily under vision. No fear of entering anywhere. You can see the movement. You have to appreciate that.
Yes, sir.
Canal is opening up.
Yes.
I am gradually going there, gradually. Don't be in a hurry. Don't lift the mucosa or the endometrium. It will come in your way and obstruct your view. There is a little bit of mucus in her case. So I think our LMP is almost 15 days back, right?
Yes, sir.
Now, where is the septum is the question. So you have to see. Section करता हूँ मैं. That looks like a deep ostia. How to identify a septum is, I forgot to tell you the cavity anatomy. See, there is a broad septum here. This is the right side of the cavity or adhesions. It could be even an adhesion, intrauterine adhesion. Can you see? This
Yes,
looks like
sir.
an adhesion to me, not a septum. See,
Okay.
there is the ostia. Can you see that deep?
Yes, sir. Deep inside.
Deep inside. So
Yes.
these are all endometrial adhesions, not septum. This ostia is again deep. We will just go through one side and just show you. So you can see the membranous part of the endometrium there.
Yes, sir.
There you see the ostia deep. So these are deep ostia is usually septum or the central adhesion. Just now Anurag was, I think, trying to highlight how to differentiate septum and adhesion. Now again, if you had dilated this, you would have missed it.
Yes,
Because
sir.
you would have gone,
Yes.
the dilator would have gone and just made it like this opening, and
Yes.
you
Bec-
wouldn't have seen this beautiful virgin
Yeah,
view.
yeah. Requesting audience to also look at the other camera view. Sir's hands movements are
See how
most
I am
crucial.
operating the scissors here?
Yes, sir. So we get so fascinated with the inside view.
No,
But,
you
yes.
when you are in a workshop or
Yes.
inside the OT, don't see the monitor.
Yes, sir.
Monitor, so you can see tomorrow also. It is
Yes.
recorded.
Yes.
But what is there with the surgeon's trick, you are not going to get it tomorrow.
Yes.
So you can see how to cut it.
Yes, sir.
So these are central adhesions or intrauterine adhesions. Why? Who is the responsible for intrauterine adhesions?
We are the ones. sir.
We, gynecologists.
Yes, sir.
So we are all iatrogenists.
Yes. Sir.
So today, stop doing blind DNC. So in my talk, you will see some wonderful videos of total visual termination. So now come back. Don't keep going in one direction. Come back and see, this is how you keep cutting. Now I'm seeing the right side of the cavity. So I will move the cable slightly to the left of the patient. Did you appreciate it, Dr.
Yes, sir.
Vaishali?
Yes, sir. Yes, sir.
Vaishali madam is the professor, so she will learn faster. She will know the tricks, how to master.
So you are the professor here and we are learning from you last 4 or 5 years. And yes, definitely, sir, all of us in our department, we are doing now good
Yeah.
hysteroscopy cases.
Yeah, I don't think you should now dilate.
Yes,
And if
sir.
you're telling me that you're not
No, sir, we
dilating,
are not.
I will stop coming from next year.
No. No, sir, we are so scared of that. And now we have totally stopped dilating.
Yeah, don't dilate
Yes,
at all.
sir. Yes, sir.
Don't allow your residents to dilate at all.
Yes, sir. We promise you we don't dilate at all.
And of course, when there's a distension loss right now. What are the reasons for sudden distension loss?
Perforation.
Yes, but perforation, I shouldn't do. You shouldn't tell me that reason.
Yes, sir.
I can get angry
Yes.
because you're doing under vision. So how can you perforate?
Yes, sir, totally agree. But it
yes,
was-
sudden loss is perforation or somewhere the fluid is going out or it is coming out of the canal
yes,
or
sir.
there is a tubal kink, troubleshooting. So you have to see whether the tube is being kinked, whether the pressure has gone less or the fluid in the saline bottle is over.
Yes, yes, sir.
So these are some of the reasons. Now you can see this is adhesion. She must have undergone termination.
Two terminations, sir. Two
So
individuals
that
she
is
had.
why. So
Yes, sir.
termination is definitely there.
Yes, sir.
Blindly, you can say that 100% somebody has entered the uterus to do a DNC. And that is where the osseous metaplasia is also there. So there we can see the ostia much more clearly now. So this is an old adhesion, but lucky because some anatomy is maintained. So intrauterine adhesions, if you see the anatomy, the ostia and things, you are very comfortable. You can do the surgery better. You can see the ostia now very clearly.
Yes, sir.
So
Clearly.
this is a pure intrauterine adhesion, and this must be at least a year or 2 year old at least.
Yes, sir.
They were flimsy initially, but as you go up, the adhesions are more stronger. So sometimes you have to be lucky to get good cases, because I was wondering when Dr. Vaishali had sent the list, I said no Asherman is there.
Yeah.
And I like to do Asherman.
Yes, sir.
So I was going to comment, why
Yes.
didn't you keep
Why?
an
Why
Asherman?
didn't? Yes, sir.
And
So,
what she made me was, as soon as I entered the campus, she said, enter the temple and pray. So there maybe I prayed, I want an Asherman, and I got it.
yes, sir.
So that was a beautiful temple inside the campus. Now, other thing is, if you can see the Caesar movement, it is better.
Yes, sir.
If you see a blind movement, then it becomes very difficult to. So you should see the other blade cutting the tissues.
Yes, sir. Sir, and we can also appreciate the way you're moving your scope from here to there.
And of course, I always ask for a stool which has wheels.
Yes, sir.
Because I can dance inside these two legs of the patient.
Yes, sir.
Because you have to move from one end to the other. In hysteroscopic surgery, we want the legs up, and you should be able to move easily from one corner to the other. Though, of course, the caster is not very effective, but at least it is not a fixed tool.
Yes.
So we will need little bit of Asher cutting inside here in the. Now this patient will need a Foley's catheter, number 8 or 10, pediatric Foley catheter.
Pediatric Foley's,
Because
yes.
it's a central adhesion,
Yes.
and that bulb will prevent it.
Yes.
See, pediatric Foley's catheter, the bulb will distend in the middle of the cavity, so it will help prevent re-adhesion formation.
Yes.
If there were lateral wall adhesion, it wouldn't prevent, because the cavity is again going to be collapsed there, and the bulb is going to occupy only the center.
Sir, just a minute, sir. Please, the other mic, please stop the conversation or the mic, please.
Yeah, some noise is coming.
Yes, a
some
lot of
whistling-
noise is coming, lot of background noise
whistling
is coming.
That is from where?
From the other
Camera
mic.
is making noise. Why should?
No, from the other mic, sir, from the other OT probably.
Acha, they are telling me the camera is making noise.
No,
So,
no.
the
Camera
monitor.
Camera
I don't know why it should make noise.
Yeah. It is from the other OT. Dr. Jaya, Dr.
Yeah.
Gopal Ghare, sir,
Thoda
please.
pressure zyada do.
Sir, one question. Laterally, the cornues are guiding us, but how to remain in the plane, like vertically, how we decide, like.
Correct. The ostia should be always in the midline. Your Caesar should be pointing towards the ostia.
Yes, sir.
So you saw that the blade was pointing towards the ostia, then I will be in the midline.
Yes.
Because I am cutting in the midline to reach the ostia.
Yes.
You cannot cut it like this. You have to, that's why the store's design you saw.
Yes.
The blades are absolutely pointing towards the ostia.
Yes.
And towards the right side, I will take the cable to the left side.
Yes.
To see the right
Opposite.
ostia. See, that is the right ostia. Now, this patient is around the 14th, 15th day, and there is where there is endometrial hyperplasia, and you can appreciate the ostia is there.
Yes,
That is
sir.
the ostia. Can you see?
Yes, sir.
So that because the endometrium is not flat, you're not seeing it clearly, but you should know where to stop. Now you can see the ostia is almost in line here. So I wouldn't. So this part is a little low. I can cut this fibers here. But you will wonder this bleeder, which is, coming up, it will stop. Even if you want to cauterize that bleeder, there are needles available which are again 5 French or 2 millimeter. Can you see the vessel here?
Yes, sir.
Opened up. It
Yes.
will stop if I have a bipolar needle.
Uh-huh.
Stores, have you brought a needle? Golden like bipolar needle hai? So please show them, because then I'll see how to cauterize this. Somebody
Yes.
was worried if bleeding occurs, what to do?
Yes,
So the
sir.
cream operative sheath of 5 millimeter, you can just pinpoint here and just cauterize this vessel. That's all.
Yes.
That vessel mouth opening is also seen, if you can see.
Yes, sir.
If I
Beautifully seen.
reduce the pressure, it will bleed more.
Yes.
But
yes.
we will not do that. Let the cautery cable come fast, because we don't want to push the fluid. Now you appreciate that from where we started cutting,
Yes.
it is from here. See this. I'm showing you it's almost from the lower middle third of the uterine cavity. The adhesions were there, and I can't see any osseous metaplasia anywhere. Only the endometrium is slightly hypertrophied. Now I'll just show you how to do lateral metroplasty. So if I have to do the left lateral, my hand will go towards the right side of the patient. I will fix this fixed blade into the wall and only move this. Can you see this?
Yes, sir.
That's how lateral metroplasty is done. See that I've cut. But here I'm cutting only the endometrium because there is a fluffy endometrium. You go to the other side, fix this. The fluffiness of the endometrium is obscuring the view. Anyway, the cautery is being ready now, needle. So we'll put a balloon catheter. If you want to see how it is being put, also we can show it to you.
So there was a question from audience that in lateral metroplasty, how do we decide how deep we
Yes,
have to go?
there are definite criteria when to do lateral metroplasty. You have to have a 3D sonography, and there are 3 rules. The line joining the ostia to the internal os, lateral to that, it should be at least more than 7 millimeter of the muscle seen in the 3D sonography. The indentation angle joining the internal os to the ostia and the fundus should be less than 40 degree. So it is there in my talk today,
Okay, sir.
how to diagnose lateral metroplasty is required or not. Band kara abhi. So we are removing the scissors.
Scissors. And
We'll just show you the electrode which is there. Can you see this is the electrode which I am passing through the same 2 millimeter per minute sheath. Yeah.
Yes, sir.
Operative channel. It goes inside. See, this tension I didn't want to lose because then the bleeder will obscure everything and you cannot really see exactly where it was
Yes,
bleeding.
sir. Yes,
So
sir.
now my needle will come. Can you see the needle?
Yes, sir. Yes, sir.
So I have to just let the foot switch come here. Foot switch. We are using the Arbe wires. You have to just cauterize it. That's all. The same thing. This needle also can be used to cut the septum.
Yes.
Hey, chalu nahi hua. I can cut the septum also with this needle or any adhesion. But we avoid using energy today. We use it with all scissors only in a patient who is infertile. So the teaching is avoid energy damage to the endometrium. Ready? See that cautery is over.
Yes,
Can
sir.
you see?
Yes,
So
wonderful.
that upper vessel is there.
Yes, sir.
Cautery is over. Bleeding stopped. So isn't it wonderful?
Yes, sir.
Don't
Wonderful.
worry
it is.
about bleeders.
Yes.
If you want to cauterize here, there is
Yes.
again a small bleeder. Just cauterize it.
Yes.
So it's wonderful. You can cut it like this. I'll just show you. See that? I can cut. Can you see? But cutting becomes a little difficult because the needle is very flimsy.
Hmm.
So you have to move the whole sheet, not the needle. Can you see my hand? I am moving the whole sheet
Whole,
to go
yes.
from one side to the other.
Yes, sir.
Can you
Yes.
appreciate?
Yes,
But
sir.
energy always, we don't know what I'll do. If I perforate now, I'm worried whether I'm going to touch the intestine. So avoid using scissors, avoid using any energy as far as possible. So we have completed the whole procedure. Did you appreciate? Thank
Yes,
you.
sir.
I'll just put in the Foley's balloon.
Yes, sir. Sir, steady.
So this is the needle. Can you see? Yeah.
Yes, sir, we can see the needle.
Yes. बंद कर, सर्व बंद कर. के नंतर लागेल if they want to see the bulb.
So
Yeah,
the
we-
audience is asking for the osseous metaplasia.
That
And-
I couldn't see anything.
Yeah,
Only
we
see-
couldn't see anything. So
Yeah.
we are not going to do anything about it. And sir is inserting the
Now
balloon.
this is the police catheter. For demonstration purposes, I'll just inflate the bulb, 3 cc saline, please. You have to cut the tip of the catheter just above the bulb because you want the bulb to occupy the center of the cavity. Otherwise, this will occupy almost 1.5 centimeter and the bulb will be in the lower half
In the
of
lower
uterine
part of the cavity. Yes, sir.
So I'll just distend.
Yes, sir is distending the balloon. And then the upper part he will cut.
Yeah, you can see the bulb is distended. I'll just cut a little part of the catheter tip.
Yes, sir.
That's all. Don't cut it very close, otherwise again it will lose
Yes.
that, it will break.
Yes, sir.
So you have to
Now
remove the
again-
fluid again.
Yes.
Either you use the 8 or 10. 8 or 10 will allow only 3 ml. 3 ml आहेत का बघायचं आता. It won't take like 10 ml and 20 ml like an adult 14 or 16 number catheter. Now these are very flimsy, so you might need an artery sometimes to direct it. Push it, see it's gone. Can you see it's going?
Yes, sir.
I can show you the distended bulb also with that hysteroscope later if you are interested. Now, once I am inside, I will just remove the stillet which is there with this, and that's out. Press करून ठेव, catheter आतमध्ये. Push कर, yeah. So we have distended it. Now
Yes,
it
sir.
won't come out. Would you like to see the balloon inside the uterine cavity?
Yes, sir.
Or no, then we can go for the next case. You want to see?
Some of the audience want to see.
No, even your audience inside the OT want to see. They are not satisfied with the bulb outside. They say, even if you all don't want to see, show it to us.
Yeah. The
Can you see the catheter going there?
yes, sir. Yes,
So I have
sir.
to now find space. See, the bulb will be seen very soon. See, the catheter is little bent. I
Little
have to
bent
just
here. Yeah.
sort of pull kar, because my instrument is pushing it. So I cannot force it because the catheter might break with the instrument. So now थोड़ा straight कर. ऐसा. So it gives me some space. So can you see the bulb now?
Yes, sir.
You are seeing the bulb. You don't get your space is lost because this is about 4 millimeters already occupied by this
By the catheter.
catheter.
Yes, sir.
So, I have
So,
to
but
be
we
very
can
strong.
appreciate the balloon and it's in place.
Yeah, you
We
can see it's exactly
Yes.
where the adhesions were.
Yes, sir.
Can you see I'm close?
Yes, sir. Yes, sir. Very close. Wonderful, sir. Wonderful.
So 3 days you keep, 5 days you keep,
Yeah. Yeah.
and that's it.
So
Thank
very
you.
nice demonstration. All are very happy here, giving you a big round of applause.
Thank you, thank you. We'll just reduce the catheter, projecting out of the vulva by tying the knot very close to the external os.
Yes, sir.
Can you see the knot?
A little light is reflecting. We can't see the knot.
Arteria.
Yes, now it is better.
See, you can see the
Yes, sir.
knot very close to the external os.
Yes.
So
we
hold
can
it here and then pull it. tighten.
shut off the lights.
Yeah, shut off the light. See, that's all. I have tightened it.
Yes, sir.
Now it won't leak. Scissors. I'll cut the rest. The catheter is now in the vagina, so she won't be bothered. When you want to remove it, go above the knot and cut it.
Yes, sir.
The fluid will come out.
Yes, sir.
Thank you.
Thank you so much, sir. Wonderful case and wonderful demonstration. The tea is waiting outside if you want to have a cup of tea and come back. Meanwhile, the other case would be ready. The audience. Everybody is awestruck. Can we give a big round of applause to sir? Krishna Kumar, sir, we are clapping for you. Thank you so much.
Thank
We
you,
are
thank
all
you.
very happy here.
Thank you so much for being with me and giving me the motivation and the support. And I must pray to Lord Shiva every time when I enter the OT for getting some lucky cases or lucky surprises in camera. Thank you.
Sir, I am thanking to Lord Shiva that good we got one assurance.
Yeah, we have to give her 3 cycles.
Thank you, sir.
15 days.
3 to 5 days. 3 to 5 days. Acha. Sir, audience is wanting to know when to remove the catheter and any
Catheter,
antibiotics needed.
Generally 5 days, maximum 7 days. You can remove after 5 days. By that time, we see that the raw surface we feel, or the what we have learned is the epithelialization starts. So the raw surface will not be really raw. The blood will not be there because the blood and serum is the one which causes adhesions. So 5 days is enough, maximum 7 days. And of course, this patient will require estrogen and progesterone. Of course, in this patient, she is already having a child.
Yes.
A patient, Asherman without kid, you want the endometrium to grow faster.
Yes.
So you will give 2 cycles at least of cyclical estrogen progesterone. Don't give oral contraceptive pills.
Yes, sir.
That is not the way. You want estrogen proliferation.
Yes.
So you have to give at least 6 milligram of estradiol valerate for 15 days, followed by 5 days of medroxyprogesterone. And on day 5, if you start, give it for 20 days and give 5 days. But of course, the literature states that if you have done it in the immediate post-menstrual phase, body estrogen is already there. So endogenous estrogen is enough. Your outside estrogen is not required. But if we always maybe little overdo something, we give estrogen because estrogen we know is the only hormone which can proliferate the endometrium, and we don't want the adhesion to redevelop. And at any cost, we want it at least for 1 cycle you should give, and then monitor in sonography after the 3rd cycle whether the lining is growing well.
Yes, sir. Definitely. Sir, any antibiotics she need?
Of course, antibiotic, we will give the routine antibiotic.
Yes, sir.
In our center, we just give ceftriaxone and 1 dose or 2 doses and then follow it with any of the cefuroxime tablets.
Yes, sir. Definitely.
Thank you.
Sir को चाय पिलाओ कोई? निशिता?
Yes, madam. उधर स्टार्ट किया क्या रेडी है?
So Shroth, am I audible?
Hello, am I audible?
Sir.
Anybody from Sushruth?
Yes, sir. You are audible, sir.
Okay, and our video picture is seen there.
Yes, sir.
Okay. So this lady, 47, like, can Priyanka present the case
Yes,
there
sir.
for the audience? Yeah,
Yes,
Yes, she'll be presenting, sir.
The case that is being showed here is a 49-year-old para 2 living 2 tubectomized with AUBAE with right ovarian cyst. She had complaints of heavy menstrual bleeding since 3 months. Her cycles are regular with heavy flow. Last menstrual period was on 12th of June. She is a para 2 living 2 with previous both vaginal deliveries. No medical or surgical history. On examination, the uterus per vaginally was of 6-week size, anteverted. Pap smear is NILM. Previously, she has undergone DNC, where the report was a secretory endometrium with benign endometrial polyp. CA 125 is 11, which is normal. On ultrasonography, the uterus is bulky, anteverted. The endometrial thickness is 14 mm. The myometrium is heterogeneous, showing possibility of adenomyosis. There are two small fibroids, one of 1.5 centimeter in the anterior wall intramural fibroid and another 2.6 centimeter posterior wall fibroid. Also, the right ovary is showing a large loculated cystic lesion of 4 by 3 centimeter size with a thick septate and calcific lesion within it, which is likely to be a dermoid cyst. All findings here are suggestive of adenomyosis with endometriosis with endometrial hyperplasia and right ovarian dermoid cyst. The plan for this patient is a total laparoscopic hysterectomy. Thank you.
प्रेशर किती ठेवलंय?
Here we can see that the cavity has been entered. Although everything is suggestive of adenomyosis, however, endometriosis is not being seen there, probably.
मॅडम हे ना याला काहीच करायला लागलं. असं बस that's
There are few adhesions in the pouch of
Cool.
Douglas, I think.
plain grasp. Okay, so now we have entered it's plain grasp. Direct trocar technique. I don't put varies. We have put a supraumbilical 10 mm port. I am presently not seeing any cyst, but there is some collection here, which might be reported as a cyst, probably a fallopian tube hydrosalpinx at the terminal end. You can see here?
Yes, sir.
Yeah. So, I'll give you. So probably more of adhesions. We are using a simple Hulka type, simple V-shape manipulator, which I have designed it myself. It's just a simple modification of Dr. Sanpal, what he used to use. It's a very handy manipulator. We will show you at the end of the procedure, but presently we have put it inside. This is one ovary, which looks good. This side are the adhesions. Once we'll dissect this, then we'll come on the other side. Okay, the first thing you do once you enter into the abdominal cavity is inspect.
Yes, sir.
Everything is fine. Your entry is okay. We have gone a centimeter above the umbilicus. That's a usual port entry for lap hysterectomy. मला ते शेअरर देता शेअरर. We will be using both sharer as well as simple bipolar to demonstrate for one who are the beginners. एक घेणार आहे. किती ठेवला bipolar? 35 वर ठेवा ना. BSO पण आहे. Yeah, okay. So we'll do the BSO part later. बघा होतंय का? Bipolar नाही होतं जरा बघा. ते आपला केबल द्या ना. मग कसं चालेल मी ही लावली याच्यात. एक मिनिट. Okay, so we are using a bipolar shearer. You can see this instrument. Ha, bas, this is still. Okay. Footpad. नाही तू नाही. हा तो इकडे करू. इथं ठेवून दे. बस. ठीक. बस. So the technique is very simple. First, once after the full inspection, the most important thing, the person who is sitting in the vaginal end, the stretch. He or she is the one who is actually doing the hysterectomy. If that stretch is less or she has some khunnas, then she will not. So first thing is simple cauterization of the uterovarian ligament. The shearer is a good instrument. It coagulates and cuts. You have to, basic principle never changes. Coagulate more, cut less. But you have to be careful. First thing is just simply cauterize. Dr. Gopal Gare sir is helping me. Yeah, like this, that's it. ठीक है, मैं कर, ठीक है, वो तो across होता सर. Okay, so whatever you are cutting, you should have a clear vision. Since I was not having a good look at that, now I'm using a second port and just simply you have to do nothing. This is the tube. The tube and the ovary have already got adhered and formed a tube mass. So first thing I'll do is try to separate this from the uterus and make the uterus free. The cornua is, this side is gone. You see, with this
Yes,
we'll
sir.
separate later. We can cut it now also, but this keeps on falling. So I just lateralize it and then move ahead. This is the round ligament. Principle is same. 1, 2, 3. Simple coagulation. Simple. I am using ekdam basic. nahi, nahi, bas.
So the audience here wants to know about the diathermy settings that are being
Yeah,
used
okay.
now.
So this is a sharer which has a coagulation of 35 with a cut mode at 40. It's a standard setting. They have 40-40, sorry, 40-40. And bipolar, we are using a separate dedicated bipolar, which is, so one thing about this shearer is you are seeing it is coagulating very nicely and cutting, but this is over a period of time we have realized the way to use it. Otherwise, it will cut very sharply and you have lots of bleeding. First thing is always create a good plane. Now, since here you can see some adhesions. Okay. So, this is the anatomy. Bas, that's it. That's it. Now, this is the posterior peritoneum. Use just small coagulating bits and cut it. The moment you cut the posterior peritoneum and go towards the uterosacral, you are separating or you are mobilizing the ureter at least 2 centimeters away. The ureter must be running somewhere here. So I am just mobilizing. The first thing is posterior peritoneum. If you are doing an open surgery, then it will be like skeletonizing the uterines. That's the word we use. In laparoscopy, it is better. See this. This is the window. I create window. I just push it. This is the posterior cervix. So the idea is to expose the anterior and posterior surface. The only thing, madam, sir, the only thing which lies in between these two structures is the uterine. Now just gently lift this is the UV fold. Now you will see why I am using a simple manipulator, the magic of that manipulator. This is the uterine. Now you just reverse the manipulator, the way madam is holding, I have just reversed it. Reversing the manipulator, it was already reversed. Reversing the manipulator, you see, the ischemic region is suddenly popped up. So this region, the manipulator has a groove. When you reverse it, the ischemic region falls up and the bladder goes down by nearly 1 centimeter and 2 centimeter and you get a margin to cut. Now this is the white line. The bladder is behind that. Just simply push it, push it, push it. This is the cervix. Always remember the stretch. The most important thing is the stretch. Madam, thoda sa, bas, zala. Whenever you dissect the bladder, you might find some odd bleeding. Leave it there, don't worry about it. You have to see and get close to this loose areolar tissue. This is the plane. Now you see a cervix. This is the cervix. And I am just gently pushing the bladder down. That's it.
Beautiful dissection, sir. It is appearing so easy for us from here. But I know you being the legend, you
No,
can do
madam,
it.
it is just the plane. You have to just find the plane and see, gently push. Don't do anything. See, the bladder just follows you. The principle is same what we do for open surgery. Madam is helping with the stretch. I am pulling and I am just pushing the folds behind. If you are in the plane, hardly they bleed. The idea is to reach the round ligament this side, which I have already reached. So I just have to create a window later here.
Sir, the same bipolar current is coagulating and cutting. So what is the trick which you are using?
That is how you use the instrument. So if you press both the prongs of the instrument tightly, it will cut. See, I'll show you. I'll not show it on the uterine. I'll show you on the. See, this I am just coagulating. I am not doing anything else. So once I coagulate, if I hold this very tightly, and it will cut. That is how the instrument is made. It's the make of that instrument is only like that. So I was a very staunch harmonic user at one time. I still use, but probably when there is grade 4 endometriosis or I have to do a bowel dissection. For all rest, I am very happy using a bipolar shearer. Now, from the anatomy point of view, bas madam, we'll have to. You change केलं ना परत? बस madam असं धरता. Okay. असं बस. Now we have already dissected one cornwall. There are some adhesions, but this is the posterior cervix. Madam's manipulator can feel my instrument. Okay. This is the anterior cervix. Now the only structure right now here in between will be a uterine. So first just coagulate. The problem with this is if I coagulate more, it will cut. So this is the only place where I use my bipolar. हे गेला बा 35 whatever. Sorry, we're just connecting the bipolar. And you can see I am using only one instrument at a time. I don't use both. I can use both in one hand. A lot of expert laparoscopic surgeon use two instruments, one shearer and one bipolar, and both they keep on, the speed becomes fire. This since being a teaching surgery, I am going a little slow. And I am cauterizing a little up above the isthmus also, so that the backflow is little less. Whenever there is backflow, the field gets disturbed. Once the field becomes red, now you become panic. Now the advantage or disadvantage with laparoscopy is, except operating surgeon, everybody is seeing what am I doing. Means I am also seeing, but everybody is seeing. And everybody is opinionated what we are doing. In open surgery, except surgeon and assistant, nobody knows what is going on. So this is the uterine.
You can see the lumen. Yeah.
You can see beautifully the uterine. This is the cervix. Now we have skeletonized it. We have to just put it down. We go, we cauterize. All gentle movements. We don't have to do anything fancy. The only thing is, if it bleeds, don't panic. Wait. Just wait and watch from where is the oozer, and then cauterize the oozer. Don't just arbitrarily keep on cauterizing. Because the moment you keep arbitrary cauterizing, you will reach the ureter, because ureter is somewhere here. So anything down here, no. Whatever you want to do is do medially. What we do in open surgery. I am just doubly shoring by cauterizing it. You will later put a vaginal tube and then delineate on that tube. So one side is done, we shift to the other side. Same thing. The only difference is we just shift the manipulator direction. Everything is done by madam there down. So here you find adhesions. You see, this is the ovary, this is the tube, but that we'll see later. This is the utero-ovarian ligament. Same funda, 3 strokes. Nobody is asking any question. I don't think so. I am doing something right or.
No, sir. Everybody is so much awestruck that they're just visualizing the thing that you are doing. Yes, they are saying that they're mesmerized.
Now you see there was a bleeder. So whenever you are close here, this is a very important point to remember. The first mistake when you make, when you start doing lap hysterectomy is there is a vessel which is at the corneal region supplying it. Thank you. So don't be very close to the uterus. Keep a half a centimeter margin, because once that vessel bleeds, then again you will waste your time, energy in cauterizing that vessel. It is somewhere here which is supplying the tubal and the round ligament structure. Infection, a fluid.
The lower adhesions also appear to be more inflammatory rather than
Looks as-
endometriotic.
So first thing is, now that's the round ligament. That's the window which I had made. So as you see in open surgery, this is that vessel I was talking about.
Yes.
So as we do in open surgery, create a window, put a clamp, create a window, put a clamp. Same we do in lab. This is you don't need to create a window, but I create. So one side corneal is done. We have already pushed the bladder down this side. Now same process, the posterior peritoneum. Let's push the posterior peritoneum down. So this is the adhesion, so you will find little fibrotic bands there. Gently, gently push, coagulate, cut, coagulate, cut. That's it. See, the moment you push this peritoneum down, you have gained a margin of 2 to 3 centimeters. The ureter is here somewhere now. Rather here, because there is adhesion, we'll see that later. That's the uterine. Just, you can still go, and better you want. But just don't directly go and jump to cutting. Now, that's the uterine. Again, same principle. I will bipolar it first. Change the direction of my scope. See whether there is only uterine, no bladder tissue anywhere. Doesn't look like. Madam. Yeah, so here, sorry. If you find there is some bladder tissue or some fibers, bladder pillar, you can just push it down. But here, this is quite down. See, this is the cervix. This is the uterine. Hold it, madam. And now I am bipolar cauterizing the word cauterizing we don't use, we use desiccation. So we are desiccating, this is the uterine. You will always find one of the uterines will be much bulkier than the other, because that one is the one which is supplying majorly. The problem is not the artery, the problem is the vein. The Y-shaped vein which covers the uterine artery. The moment you cut that vein and it bleeds, it retracts. And once it retracts, it is very difficult for the vein to again cauterize, because it goes down. And that is the point where we land up with complications. Because then we go down and down and down laterally. See, now I didn't want
Here
to
also
cut
we
it, but
can
it has
see,
got cut. This is the only problem with dissector. If you go really, really want to hurry up, you should not do with that. So I wanted to coagulate here first. Since I pressured that instrument more, it just cutted the tissue. So it takes some time. That instrument has a learning curve. So one thing in endoscopy which is always to be remembered is, it's the man behind the machine. So you need to first know your instruments. You should know your hardware. So now if this has a little loose, don't cut it. Because once you cut, this will retract here. And then again, you will be having issues searching the bleeder.
Anurag sir, audience wants to know about the clips which can
Which
be
clips?
used. vascular clips.
You can use the vascular clips. You can use. They are a good thing to use. Yeah.
So any advantages, disadvantages they would like to know from you?
See, advantage is if the clip is loose, and second, they are usually we use those vascular clips in larger vessels or for the origin uterines at the origin where we want to know we can either later on remove them or we just leave it there. At uterines, see, once you coagulate the vessel, the problem happens is the vessels, the overall volume shrinks, and once the overall volume shrinks, your vascular clips will slip away or it
Yes.
will be loose. They are all good. The same thing happens sometimes suture with suture also.
Yes.
Once you put a suture and then you coagulate, desiccate and cut, the suture becomes loose. Now you see the uterine vein here has a little bleed and it will stop, but I am not bothering that much. I'll take it in the stitch when I'll be stitching the vault.
Yes.
थोडासा नाही नाही असंच पूर्ण घेऊन हा, बस मॅडम थोडा बस like this. That's it. Now I can see the नाही नाही मीच एवढं केलंय ते. Fine. I think both sides, this will come in the both sides. Good. I'll just remove the manipulator and put a vaginal tube. मला betadine द्या. Light द्या जरा. मला monopolar hook लागेल madam.
So still sir puts the manipulator. We also would like to thank our sponsor for this case, Pranav Medicare, that is Om Surgical. They have prepared this OT and offered their trolley and instruments for us. Sir, audience would like to know more about the manipulator, how you select it and how you use it.
I will show.
Yes.
काढून घेते. बस. असंच ते जरा. You have to push the tube. You have to just hold this up and direct it. This is for the direction. This is for the placement. The tube is placed at the fornix. You can see.
Yes, we
That's
can see.
That's done. Baki me kar. It's very simple. No mara-mari, nothing. Now we have put a vaginal colpotomizer, which is, you can see at the fornicial region. You can see here.
Yes, we can make out.
That's the vaginal tube. There is a simple bulldog forceps which is kept inside the uterus for the direction. Rest everything is done by the tube. Zara clean करायला देता please. Makes it. Zara दाखव. Now you see the bladder is nearly 2 centimeters away from the vaginal fornix. This is, yeah. X. Bas. Bowel asa. Good enough. Bas. Straight. Ila ऐसा push कर. Bas. That's it. Now using a simple change color. Simple monopolar hook. Color change. Just open the vault. बस थोड़ा this is a very simple technique. Everybody can use and follow it. You don't need expert assistants. No, I have today. Sorry, not that way, but
Yes, भावना पोचल्या.
when you're operating at chota nursing home setting levels.
Yes.
Now, if you see, if I do a monopolar here, I'll be in trouble because there is a bleeder. Madam, you can see there is a bleeder there.
Yes.
So wait for 5 minutes. We have learned from our mistakes. Coagulate this area. The monopolar is a pure cut current. It will just cut it.
Yes.
And then once the vessel bleeds, it bleeds like anything. Because descending cervical is some, see now, there is a bleeder there at the vault.
Yes.
So these bleeders, when they come up, you will have a hell of a time. So always better take 2 minutes. It hardly takes 30 seconds. Just cauterize it and then you move ahead.
We also would like to know the cautery settings
I will
which you're
just tell
using
you.
after you are
Same
whenever
cutting
you are
40, I
comfortable.
think cutting is same 40.
Okay.
We are using a pure cut 40 current. And in between, we are just having a little burst of coag. Spread of coag is more, but I am quite comfortable now using little coag. He is to just follow the tube, nothing else. Like this. Now you see we have a good margin. You can
Yes.
see Dattatreya sir is just pushing the bowel behind. You can see the vault. I can see all my instruments very clearly. I can see the vault clearly. Don't do any maramari. There is a vessel, we just coagulate it. Because her cervix is, see, this is the main thing. Now, you see, moment I push the tube more, yeah. Because her cervix is very fibrosed and once, because of normal deliveries, it is sheared from one end.
Sir, can you explain us if bipolar vessel sealer has
Yes.
advantage for using for the uterine vessels? Because here you used bipolar shearer for major pedicles.
I have used bipolar shearer only at the cornuals and while dissecting the bladder, but not at the uterines. At the uterines, I have still used a
Can see
simple
क्या
plain.
here?
See, this instrument, what I am using is a simple plain bipolar forceps. You can see?
Yes.
Yeah. Now, if I cut here with a monopolar hook, it will bleed. Because we have dissected, but the vessels have not been completely dissected down. So I'll first bipolar cauterize it so that it doesn't bleed. We'll just check. See, you see the cervix hanging there. That is because it was, just madam, hold like this. The tube. Main is the tube. Bas. Again,
Right.
inspect everything. Just simply, since I have the very hard portion, there will be a cervical portion there.
नाही ते टेर सारखं दिसतं ना.
That is why I cauterized it first. Now the uterus is separated. We just push this entire thing out. Madam, you want to service this?
पॉलिप काहीतरी बाहेर येतं.
ओढून घ्या.
See the polyp is. Can they hear my voice? नाही ना.
Sir, we can hear you.
Yeah. No, I'm just showing you because we are entering and there is something like a polypoidal projection coming out. Can you
Bus,
see?
bus, तिथेच
The
ठेव.
endometrium is
It
13
acts as a block
millimeter as
also.
far as the
Bus,
sonography is
बस,
concerned.
झालं.
So we are trying to
We are good.
negotiate and see where the polyp is and where the.
We are a
ox is.
view of the laparoscopic OT, the only that view we
Where
have.
it is. It's a
आता सगळं.
polyp coming from the
Second.
anterior wall, maybe
ठीक आहे.
below the internal oxygen.
Console, can we have other OT view as well?
Yeah, it's a cervical polyp.
We are just having
We have
TLH
just
view.
taken the uterus out. You can see the vault.
Yes.
We will do the DSO part first. Excellent. I'll just finish the DSO.
See that, how can enter
Kappa.
under vision.
The case that is shown in this OT is a 53-year-old para-2 living 2 tubectomized with previous LSCS with AUBE with
आहे.
left hydrosalpinx.
ठीक है.
She complains of heavy
side se
menstrual
first start.
bleeding since 2 months with irregular cycles coming every 15 days and lasting for around 20 days. Last menstrual period was 15th of May. She's para-2 living with previous 1 LSCS and tubal ligation done. No significant medical or surgical history. Rest all findings are normal. On ultrasonography, the endometrial thickness is 13 mm. There is a 3.5 by 1.7 centimeter wide tubular cystic structure noted in the left adnexa, suggestive of left hydrosalpinx. The plan here is diagnostic hysteroscopy with TCRA.
Yeah, good morning, but this is little hyperplastic endometrium.
Yes, sir.
Whenever we are doing a TCRE, ideally we have to keep the endometrium to 5 millimeter.
Yes.
Then the TCRE procedure is faster. What happens is, if you keep the endometrium at 13 millimeter, you have to resect 5 times or 3 times in the same place.
Yes.
So the loop is a depth of 3 millimeter.
Yes.
The fluid is going very fast somewhere. It is. Wait. क्या pressure पे है? Okay, 300 ml per minute. Okay. दो कर. See, the flow rate is kept at 3 liters per minute. You can see it flowing there. Can you see the difference?
Yes, sir.
The fluid flowing. So you're seeing a lot of bubbles suddenly. So that is the pressure of the fluid. Anyway, you saw how we entered. There was a polyp-like growth in the external part. The hyperplastic. Give me a grasper. Grasper there. They want a sampling. We can, of course, TCRE we are doing. We will be getting the endometrium also, but we'll just show you. Yeah. Please. So here I'm using the new camera system. Morning, I had the pleasure of using the new camera system from Arbe, who are new to this market. Of course, they are very known in. See, this is the grasper which you saw. This is the
Yes.
toothed grasper. So for holding polyps, small fibroid, you can hold it. Morning, we use the spoon grasper. See, this opens up to 6 millimeter inside the uterine cavity. You saw that? So that
Yes.
means if you have to measure something, you measure it like this. This is 6 centimeters.
This is 6 millimeters.
But this will give a, because of the teeth, it is giving a good grip, but the tissue will be smaller. So I will just lift it gradually at 2-3 places.
So any reasons for this bubbles which are there?
This bubble, that's what I'm wondering, whether bubble is not coming from the tube. That is, we have seen, but maybe the. Usually in bipolar, when we are cutting, bubbles are formed because of the tissues, tissue burning. What is bubble? It will come out. Allow it to come out. Yeah, that
Yeah,
bubble was
yeah.
disturbing. So you have to
Yes.
just come out a little.
Yes.
Pani start karo. Pani start karo वापस. Come back.
So for this case, we have Aquino system, Weber.
Yeah, we are using the Aquino. I was
Yeah.
trying to tell that morning we used the Arbe, and
We
now
are
I'm
using
using the
Aquino.
Aquino, which is a local Pune company.
And we have Weber's Histromat and Store's
This Tomat
instruments.
is also from
Weber's.
Weber's. Acha. So this camera system is a good camera system. We have used it in the last year also, I think.
Yes, sir.
This grasper is good for after the polyp is cut. For biopsy, a spoon or a little more wider claw-like cut substitute that gives you a better tissue.
This grasper is from Stores, sir.
I didn't, let me see, it is stores.
Yeah.
See, I've taken out the biopsy, I'm bringing it out. Can you see?
Yes, sir.
So under vision, there's the polyp which I was telling you
Yes, yes.
at the canal.
Yes.
Yeah, water band karo. So now we will go ahead with the TCRE. So can you see this
Yes, we can.
design? It has, the center one is for fixing it.
Yes.
Can you see? So it's good for fibroids and large polyps. You fix it, hold it and pull it. So this is again a wonderful instrument from Stores. Stores has a complete gamut of hysteroscopic instrumentation. Others are now entering the market. We'll just assemble the resectoscope. I'm going to use the 18 French, rather not 18, 22 French TCRE resectoscope here. We'll see whether I can pass it without dilatation.
Can we just have a glimpse of the other OT? Probably.
Yeah, you can see
Yeah.
the loop is attached here.
Yes, sir.
The 22 French is white color. The 26 French is green color. Can you see this? Or rather yellow color, sorry, yellow.
Yellow
The
color.
smaller
Yes.
one, 15 millimeter, is green color. So this is how you can see the loop coming out of the sheath to about 2.5 centimeter. So I have to know the depth where I have to go length. The loop depth is about 3 millimeter. I start cutting, halfway through I bring the whole sheath outside to the internal os.
Yes.
So we'll just use it now. 0 degree, no? So this 22 French resectoscope requires a 0 degree telescope or a 12 degree. 12 degree चाहिए. 12 degree पाइएगा. 12 degree है. 0 degree the vision becomes narrow. They generally give a 12 degree for this resectoscope. Your 26 French, we use the 4 mm 30 degree. Hysteroscopy, the standard one is of course 30 degree because you get a little easier vision. This vision is, 1 minute. Asabi. No. Electrode. Now, can you see the external here? I am putting the electrode attached it. Suction this, suction this. Suction tube लागेल. तोपर्यंत speculum दे, valsalum दे. We will enter under vision. ये पकड़ो सिस्टर, डॉक्टर. अरे एक कुठलाही सेक्शन द्या, नाही तर आपला रूम हे पण चालेल. घे ना, हे घे. ते घे. ते काढून टाक समोरचे. कुठे अटॅच करणार कुठे? हा नाही हे बघ कुठला बसतंय बघ तिथे. हा बसतोय नाही
Can we have other OTs endosuturing meanwhile?
Same है, same as that. Okay. ठीक है.
Yes, thank you. We can see that. Dr. Anurag, we are with you.
Yes, welcome back.
Is there
We are finished with the hysterectomy. We are finished with the salpingo-oophorectomy. The vault has little loose, which is expected because we are doing a salpingo-oophorectomy. There were some addition. Suction on kara, please. Suction. बघा लूज आहे का कुठे? नाही 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 ते दे, हे देऊन दे ना टीआर सेट. हे घे. चलो जरा सक्शनचं बघा ना प्लीज. थोडं आलं आता. चला. सो वी विल डू द मॅडम थोडं युट्रस बाहेर घ्या. हा थोडस अजून. जस्ट पुल इट लिटिल आउट. बस. I usually don't prefer to use a saline until unless really there is some big ooze or something. इथे वॉटला थोडीशी ooze आहे. In the end, which we cut it with the monopolar, but that will come in our stitch.
Yes, sir.
So, needle. Important thing is, मला दुसरे needle holder द्या ना. तो पण हेच ना. तूच आमचं आपला आहे ना. हा दे मग चल. दे. Clean करू. Okay. So to hold the needle, say I did nothing. I just put it, it's still hanging up. So you don't have to struggle anything. Just hold. The needle guides you. And I am in the position. I go in, I hold. If I see a bleeding, the needle is a very good thing. I can just clean the blood with the needle like this. I take the uterosacral, I take the vault. Then again I hold it. I go take the posterior vaginal edge. I hold the anterior vaginal edge and my needle comes out there. That's it. That's it. Then, sir, it's bus. Bus. Just keep it there. One loop, second loop, go, hold the thread, push the thread, push it guides itself and not. Square. No hurry, nothing. It is just simple suture. Scissor. हा नंतर काढतो. काढून उधर. The cyst reported was finally removed by Dr. Dattatreya sir.
Okay.
Now I'll just say sir to follow me and we'll do a continuous interlocking suture. I don't do intermittent, just hold like this. Tight, tight. Bas, tight. Pull karte thread. That's it. I prefer to do continuous interlocking. I have my own reasons. I find the bleeding post hysterectomy from the vaginal wall quite less when you do continuous interlocking. When you do intermittent, they come up. I used to feel they come up regularly, kisi ko bleeding hai, and then I started doing this and I'm very happy with that. I don't put the needle through and through. I take the posterior. See, this was the adhesion of the tube. So I just wanted to be a little behind. Otherwise, I'll pull the ureter up. Now, where is the anterior? Okay, that's the anterior one. So, thoda उड़ता का thread. पूरा हाथ गेला है. एक
ऐसा लग रहा है ना?
एक. No. Now it will not help. It helps when the uterus is too big or something. Once we remove the uterus, it's just a blocker. पाठी येतं, sir? लॉक नाही झालं. एक सेकंड. आत जातं? नाही, एक सेकंड. आता लॉक होईल. होल्ड डाऊन. क्लीन करतो जरा. पिक्चर क्लिअर आहे का तिकडे? इज द पिक्चर क्लिअर? Am I audible also or not? I don't.
Yes, we can see clearly.
Okay. Fine. There's nothing, so I was thinking whether it is clear or not.
Yeah, it's very clear. We appreciate all your movements. And if the talk going on here is how simple it looks when you are doing it and how difficult it becomes when we try to do it.
No, it is the same.
The audience were wondering that usually when the tube is removed, it collapses everything, the air pressure. And just because you have kept the uterus there and very nicely you're maintaining the pressure and you could close the vault.
We usually use a blocker near
Yes.
times.
Yes.
But abhi यहाँ पे again I'll have to make with the gloves and put gauze piece in it. It's better. Uterus is a very good blocker.
Yes. And that is working wonderfully in your case. That's what we were
No, it
discussing
works
here.
wonderfully in all cases. Not mine.
No, very, very commonly when we remove it, suddenly the pressure goes off and yeah, we are helpless again.
थोडं हे टिश्यू घेतलंय. थोडं पाठी. This tissue now I'll have to separate it. That's a bladder tissue. See, with this stage,
Yeah,
we just saw there is a little bladder
little bladder tissue is there.
Ah.
Yeah.
The problem is not that, it has nothing to do. But if with every stitch it will keep coming up more.
So you are just like,
So I am
yes.
just
Yes.
taking it behind. Now this is clean vault.
Yes.
Only thing is, see, these are finally, they have standardized steps which we have devised, which is like, how I do it.
Yes.
I don't need to change my instruments. I know my assistants, I have trained them. Although means they are non-technical people, but now one of them is trained. In fact, two of them are trained to do. So they assist me.
Yes.
Yeah, leap. Good. Recatch. I think 5 more minutes. Looks good. I have taken. No, I'll take. I'm coming there. No, you can do that, but then again, one extra suture you'll have to put, cut it, hold it.
What is the discussion, sir?
Sir is asking why didn't I take that side angle first?
Okay.
Fuck the thread. And then started from this side, how we do in open. So my answer was ki the idea is to take the angle, which we'll take anyway. But if I take that side angle first, then again I'll have to take a stitch, cut it, keep it, which there is no need. The posterior part here in this case especially was too much adhered. Adhered means
Yes.
she had some inflammation
Yes.
and probably it got adhered. Now you see, I can see the vault angle very clearly. I am just taking the vault right now. I'll come to the angle part in 2 minutes. Two important things is first, your suturing should be good. If endoscopy somebody is doing an endoscopy, the first important thing is he should know how to suture. The reason I am telling you, if you have a bleeder somewhere, you can anytime suture.
Yes.
Instead of cautery, suture is always better because that's how we have been learned in open surgeries.
Yes.
But during laparoscopy, what happens? Whenever the bleeding happens, we start inadvertently cauterizing.
Yes.
That is the point where we make a mistake.
And thermal
And see now, I go here. I'll go beyond also. See, I have taken the angle here. Okay. Now, don't. Now with the same thing, I'll go the anterior part. Now their angle is taken already. सोडू नको आता. धरून ठेव. Yeah, very good. Now, again, 1, 2, leave. So, hold it, push it, square knot, pull it.
Look, Priyanka.
Done. 1, 2, you can take as much throws as possible. For myomectomy, usually I take 3. So 2, 3, the movement is like this. Now the only thing is I am not cutting this now. I'll just pick it up and hold it up. And you see a little redness or wetness on the angle side.
Yes.
Yeah. So what I do is I'll just cauter it so that later on I don't want that cut of ooze.
So by holding and lifting your.
Yeah, I am making it away from the ureter.
Yes.
The moment I cut this, it will go down.
Yes.
Now the important thing is nothing to be done here.
Absolutely.
Whatever you have to do has to be done medially.
Yes.
If you have to do here anything, take a stitch.
Take a stitch.
The urine clear है क्या बघा ना. Clear है? एक half Lasix देना madam. Needle out, sister, needle out. Always shout, needle out, needle out, needle out.
Yes, that's mandatory. In medical colleges, तो ये तो और ज़्यादा important बन जाता.
We'll just check the hemostasis. Otherwise, most of the things look fine. Vault is sutured. BSO done. I don't think there was much ooze also. Throughout the surgery, it looked fine.
Yes.
अनिकेत त्यांना सेक्शनचं जरा बघ रे बाबा. होतंय पण ते काहीतरी. He is my assistant. Aniket, he is like my right hand savior.
Yes. I think all laparoscopic surgeons need right hand and left hand.
Yeah.
Yeah.
We have only 2.
Yes. And
So
they are
this is the corneal region of this side, vault, and this side corneal region. Most of it looks okay. There is the line is clear. Madam, make 1 gram pause. Mandatory, I give 1 gram tranexamic acid.
Okay.
All major surgeries.
Okay.
And after hysterectomy, just for the safety to see, 10 milligram Lasix. That's the ureter.
Yes. We
This is the
appreciate.
pelvic brim.
Yes.
For the anatomy, I'll just explain if students are watching.
Yes, yes.
Yeah. Sacral promontory.
Yes, sir.
Yeah, you will see the middle sacral vessel. Okay, the ureter, this is the pelvic brim. This is the external iliac. The internal iliac goes down. You will see a common iliac, aorta, common iliac, this is the right, this is the left common iliac. Now here, this is the ureter crossing.
Very clearly seen.
Yeah, we'll just wait to see peristalsis. Okay.
Yes.
Dattatreya sir will be happy. So this side seems to be good. Let's go to the other side is always little difficult
Yeah.
because there is a sigmoid.
Sigmoid there.
Yes. If you are, no, we don't need to. Mandatorily, see, in most of the TLH, many surgeons first separate the bowel. I feel there is no need. You can, since we did, we will need to do anything. Would be somewhere here. Okay, we'll see it later, aram se. I think we can transmission.
Anurag sir, audience wants to know any particular bowel preparation is your favorite?
I keep one day full liquid diet, morning light breakfast, and then whole day liquid diet. No milk or milk products and no aerated drinks. Only water, coconut water, juice, some clear soup. In the evening, I get Exelite solution between 4 to 5 or before 6. That's it. इधर तो एक से. Okay, we are good.
Yeah, we are good.
Any questions?
We want to know and see your ports.
Sports, just a second.
Yes.
Can we have an external picture?
And any bolster has been kept.
Nothing. Excellent. काय swelling आहे. Bowel आहे ते.
Yes.
ते bowel आहे ना, ते adhered होतं. हे ना?
Hello?
Hello?
Hello, auditorium?
Yes, sir. Yes, sir.
Yeah, we are said there was some problem with the two pottery machines, so we are using the bipolar, but which is an hybrid model.
Okay,
This-
sir.
This beautiful rescue act came from Aquino. We are using the 18 French.
Okay, sir. We can
Bipolar
see.
resectoscope, you can see how we'll just show you first. See, this is. Now you start at the fundus. You start current, cutting my hand up. I come to the internal os.
Yes.
Okay, this is the full length you have to cut. You can mark where you want to stop. This is the level where we want to stop by marking like this.
Yes.
So I would start from here. My hand will go up because I'm going into the posterior. So if I put it like this, I'm going to resect at least 6 millimeter. And now halfway through, I'm moving the whole system. Can you see the
Yes, sir.
distance between the loop and my telescope is now constant?
Yes.
Whereas I'm moving
Yes.
my external hand and the whole system out, and to come out, I will just lift it like this.
Yes.
So that's how you can see the full length.
Yes.
From here to here, it is definitely 3 centimeter.
Yes, sir. Camera requesting you to please have closer look with sir's hand than the
Now
cavity.
again, I do the posterior wall first because the
Yes.
tissues will fall down, and then if you do the anterior wall first, the tissues will obscure your vision.
Yes, sir.
Can you see? We have done, though it's a 18 millimeter, rather 18 French. So the surface area is less, but the cautery is working wonderfully now. We are using the autocon from stores. See, the thickness of the endometrium ideally for TCR is 5 to 6 millimeter, because at one stroke you can finish one layer. But can you see the endometrial gland
Yes.
still there?
Yes.
So this is a 13 millimeter. So I like to do multiple times. So then you expose the patient for intravasation. You're taking more time.
Yes.
So I will just try to be fast. So if you have any questions, you can keep asking me. Because of course, there, see, you can see the endometrial glands opened
Yes,
up.
sir. Yes, sir.
The endometrium is so much fluffy. Anybody just keep a watch on the fluid deficit and tell me if it is going above 1.5 liters. but the principle of TCRE you have understood.
Yes, sir,
Okay,
definitely.
so even if we do half, if the patient is going into fluid overload, excuse me, because we wasted some time in adjusting the cautery. And again, we just got a smaller diameter. Ideal would be the 26 French,
Yes,
because you want to do it the job faster.
yes,
Any intrauterine surgery in hysteroscopy is the 20-30 minute surgery, not 45 minutes, 1 hour.
yes, sir. So now your hand is,
Now I'm doing the right lateral wall.
yes, sir.
See the hand, the direction of the working element.
Yes,
So I'm going towards the opposite side when I have to do the right lateral wall. See my hand, it is touching the patient's leg
yes,
for doing a good job. Now I have finished the right side. There is in the anterior bubble थोड़ा आएगा बाबा, bipolar में आएगा. हाँ, fluid में bubble नहीं, अंदर intrauterine bubble can come. See, when you're using bipolar energy na, the tissues, when they are
Yes,
getting
yes.
evaporated, that these are tissue bubbles,
yes, sir.
the vaporizing bubbles of the tissue. So don't get confused with the regular air bubble. So now there will be crowding of the endometrium tissues. See, these are very, very hyperplastic endometrium.
Yes, sir.
I'll do first full wall, and then we will see if we have time, we will do the second quadri resection.
So a small question from the student learning
Yeah.
in this workshop, sir. What
Yeah,
would
yeah.
be the
What is-
points in if we should tell the patient while counseling her in the, for TCRE? So as a postgraduate resident,
Yeah.
what would
No,
they?
TCRE, first of all, explain what the procedure is. Now, today, we are a little lucky. If you do incomplete TCRE also, it's fine, because you can put the LNG IOD and the patient will get similar effect.
Right,
So
sir.
that is the one. But patients who are not willing for hysterectomy, this is an excellent procedure. Only thing, it became bad repute because of the fluid overload, and those days bipolar was not available and people were using monopolar with glycine. I'm sure yesterday you would have understood the difference between glycine and ringer saline.
Yes, sir.
The
we did.
glycine is electrolyte free. So not only you are pushing the patient into pulmonary edema, you are causing hyponatremia. 1000 ml of loss of glycine into the system will reduce the serum sodium by 10.
Yes.
And our human physiology, we are all walking, talking and healthy because the inside physiology is good. The
Yes, sir.
cell temperature 37, pH between 7.4 and serum sodium up to 135, potassium less than 6.
Hello,
So these are
Vaishali
the
madam,
things which
can
if you
we have
change,
outer picture
you
of
have it.
51?
So in
So we can
hysteroscopy, the
just
surgery, the
show the
problem
port
is
placement
it
and
was
then we are
changing the
done.
body
Yes, sir.
physiology.
Yes,
So
sir.
that is where we were getting morbidity. So in 20 minutes, you are not only pushing the patient into hyponatremia, pulmonary edema, and ammonia toxicity. Glycine was metabolized as ammonia, and ammonia toxicity causes encephalopathy. Patient goes into coma. It causes optic nerve damage. Transmission becomes less. So patient becomes blind for 48 hours. So you can't go and explain that आता डोळे दिसणार नाही 2 दिवसांनी दिसेल patient ठीक होईल.
Very
So,
basics
Minutes
of
in
things, I
OT1,
think.
Yeah,
so
huh?
we'll be finishing this.
I think we'll just go for a few minutes to the other OT, sir. They're
Yeah,
showing us
please
the
go.
ports.
We are almost
We'll come back, sir.
we have
Talk
almost
Thank you.
about the port
completed the
placement.
anterior wall now. क्या बाहर?
Yes,
हाँ,
Gopal
करें.
Kare, sir. We
Yeah.
can see you.
Yeah, so thank you, Dr. Vaishali. We are back. See, you can see the port placements. This is the supraumbilical port. These
Yes,
are
we
two left
can.
side accessory 5mm ports and one on the right side. If you see, mine is this is 2 fingers lateral to the anterior superior
Yes.
iliac spine. It has to form a C. So if I make a C from here to here, my 2 ports should be on the C. That's the most ergonomic position. One is here, and the third is as per the size of the uterus. This is for the assistant port. I hardly use it. So these are the main ports. And manipulator, what we are using is This is a simple manipulator. You can see it just goes inside
Yes,
the
we can
uterus
see.
and you can open it. It's a V shaped and you
Right.
can entire uterus can just manipulate with this. This
Okay.
is what we had put inside the uterus. And then once this is in the anteversion position, when you want to dissect the bladder, just turn it around. The moment you turn it around, the
Yes, we
prongs
can.
make the uterus retroverted
Yes.
and this middle shaft region pushes the isthmus up. So now the shape of the uterus, the bladder is falling here, the isthmus is here, and the uterus goes here. So the bladder dissection, especially in previous LSS, this gives a big margin of separation.
Mm,
At least a centimeter you get to dissect. The
right.
bladder is down, you get in this, the bladder somewhere is here, but this gives that additional 1.5 centimeters and it helps a lot.
Thank you. Again, stresses the importance of knowing the details of your own instruments and
This is a simple tube. Everybody uses this vaginal colponizer, but we don't hold cervix or anything. We just put a bulldog forceps inside the uterus. Now this gives the direction to the uterus and the tube is at the fornix and you can see I had just opened with the monopolar hook.
right.
It's a simple So thank you everybody.
Okay, thank you.
Dr. Vaishali, Dr. Dattatreya and the entire MIMR team. Krishna Kumar
Thank you.
sir,
I
here.
think you can
Thank
hear
sir.
the round of applause. That's for you.
Thank you.
And thank you for coming over
Okay,
as
yes,
our
yes, yes, thank
faculty. We'll
Okay,
see you
ठीक
soon.
है, my last saline wash देना है तो मेरे-
Can we
Thank
go
you.
back to Dr. Krishna Kumar, please? So we are back.
Yeah, see, I have pushed the endometrium, all this debris to the other side. How to work by pushing, and now you can see some endometrium is left. So
Yes,
here
sir.
you can now make it complete. Are you appreciating the electrode
Yes, sir. Absolutely.
movement? It should be under vision ideally. If you're under vision, you know, okay, I'm not.
So how does one know the exact depth at which to keep this
Yeah, see the
electrode is the
circular
very
muscle
basic
fiber, that
question.
open endometrial glands will not be seen.
Right, sir.
Can you see these muscle fibers here?
Right, sir.
So I'm ending here. So that is where, so here I can see some more endometrium. So I'll cut. See this fiber muscle. See, you can see the
Yes, sir.
difference.
We can
Endometrium,
appreciate. Yes, sir.
muscle.
Yes.
Endometrium, muscle. So these are few glands which are left.
So does this kind of resectoscope still have a place in modern hysteroscopy with the
Definitely it has.
newer
Definitely it has.
ablative systems which are now
The ablative systems have come
coming.
and gone. Now we don't get ablative system that easily in India.
No.
What ablative system was available from Ethicon, that balloon.
Right, sir.
Now it is not available. In India, it is still not available.
I think they're introducing some newer versions, the triangular flange
they're
ones.
introducing, but that's, if because of glycine and fluid overload complication, this became disrepute.
That's
If you
right,
finish
sir.
in 15 minutes and today with bipolar and saline, you're not going to have all those complications of glycine. Now glycine had so many complications, so they said it is not worth it. Understood?
Also, of course, there are very few papers like that, but there was a very small concern about some of them coming back as malignancy.
Yeah, malignancy. So that is where endometrium malignancy can occur in a patient who has undergone TCRA.
Right,
So
sir.
whereas Marina or your thing that prevents that. So generally today, patients who don't desire hysterectomy, we tell them we'll do TCRE but put in a Mirena, LNG. That is always better.
I think that would be the most advisable
Yeah,
combination.
that we do. And especially adenomyosis patient,
Yes, sir.
So I think we are more or less complete. So we will stop here and take the next case.
Excellent, sir. Looks very safe in your hands. It's almost like slicing cheese,
Yeah.
if I may
Fine.
say so.
Thank you.
I hope TCRE gets its repute back because, like you said, it's an excellent surgery for
डाल सकते हैं अभी, मैं तो
women who don't want the
हो,
hysterectomy.
खाली पड़े भरपूर इधर सर्व इकडे मिलता है तो डालेंगे, आपको बाद में डालना है तो बाद में.
So my postgraduate resident has a question: how to remove that whole lot of debris that is
I will
crowding?
show you. Just show this.
Yes.
See what has happened here. Can you see? इथे दाखव, कपडेला दाखव.
It all, I think, cascades out, if I'm not mistaken.
See, there's so much of already has come out.
Yes, sir.
Can you see the worms here? See the
Yes,
worms.
I like mice.
It's all here in the, most of the time, it will fall off on its own. See this. I'll collect.
What
the
I would like
outside one.
people to appreciate is the beautiful ribbons which sir has drawn out of the endometrium. Absolute book picture TCRE we got to see today. Otherwise, many people just take out small bits. The beautiful ribbons as the book says one should do. Thank you so much, sir, for this
Yes,
demonstration.
yes. So learn resectoscopy.
Yes, we should. Thank you, sir. Audience, any questions for sir?
Yeah, ये पकड़ ले, speculum पकड़. क्या देता है? Curate, ovum, forceps, दे, जो भी दे.
देखो प्रियंका.
अबे कितनी लांब है, मस्त है. चलो, curate दे. Okay. Curate छोटा देगा. मोटा पाहिजे. त्याला 2 सायकल रजिस्ट्रन द्यायला सांगतो ना. हा, आता पहिले कारण ते LNG चं ऍक्शन यायला थोडा टाइम जातील ना. सो गिव्हर ऍटलीस्ट 1 or 2 सायकल. आता एक 15 दिवसासाठी BD या 10 mg BD. And then next cycle, one more from the day 5 for 20 days, and then you leave her.
So what about the post-op management? Again, for the PG students,
For this hysteroscopy,
the TCRE patients, sir?
nothing. Post-op management is same, say 4 to 6 hours NBM. You first watch out the fluid deficit. See
Right,
for
sir.
other signs of pulmonary edema. If there is nothing,
Right,
just like a regular patient, you give her antibiotic, and in this case, we will give her progesterone for at
Yes,
least
sir.
2 more cycles
Yes, sir.
because of the hyperplastic
Very
endometrium.
fluffy. Yes, sir.
Let it come down so that her menorrhagia has to be relieved.
Yes, sir.
And if she is willing, go ahead and put the LNG ID.
Yes,
And
sir.
of course, I would have been happy if the endometrium was 5 millimeter. Your TCRE would have been absolutely complete.
Yes, sir.
Of course, the area where TCRE loop becomes difficult is the fundus area
Yes, sir.
and the corneal area. Corneal area, you're
Corneal,
not
the
supposed
two
to,
patches, I
you're
think.
not supposed to resect, you're just supposed to cauterize superficially.
Yeah.
But basically, if you raise your hand, you get more depth.
Right, sir.
If you just do this, you'll be superficial. So the loop has to dig and you should raise this hand. So it will
Right,
go.
sir.
And in the anterior wall, you do this and you depress your hand.
Right, sir. So these are the, I think, the learning
So
points.
the fundus, it goes behind. So
Right,
if
sir.
you dip your hand, resectoscope, it will go more.
Right,
If
sir.
you keep it like this, it will resect only the superficial part.
Superficial. Right, sir.
So these are some of the tricks which you have to do. For anyway, any myoma resection, this TCRE, you have to do that external trick.
Thank you, sir.
Thank you.
Sir, if you are free, can you show us the details of Histromat? Audience is
Yeah,
really
yeah, yeah.
keen about it.
Yeah, Histromat, इथे दाखव. आलेत का मेरे ना? कधी नंतर टाका, कधी तुम्ही नंतर म्हणजे आफ्टर ना. ओपीडीत, हा तुमचं नो प्रॉब्लेम. ओपीडीत पण टाकू शकता when she comes on day 5. That is always a little better. Expulsion chances कमी असतात. Yeah. So this is the Istromat,
Yes, sir.
Hamu Istromat from stores. So this is connected. You can see the tube. Okay, working. So this is the Hamu Istromat. You can see the on this side the pressure for suction and pressure for inflow, and this is the flow rate. Can you see? You can adjust, and as I was telling, 0.100 ml, 200 ml, 300 ml, 400 ml, 500 ml. You can set the flow rate, and this is for the inflow pressure. So this Hamu Endomat has both inflow and outflow pressure management from the same system. All the system may not have, but this is the pressure. You keep at 50, 100, 125, 150. So we were working around 140 here.
Okay,
And
sir.
200 is the maximum. It doesn't allow you to raise the pressure above 200.
Okay, sir.
And this is from where it gets connected to the fluid. This is the outflow. The inflow is connected to the saline here. Can you see this?
Yes, sir.
So this comes here into this part, and then the pump pushes it and brings it out of this outflow, which is attached to our sheath, resectoscope sheath.
Yes, sir.
Indian companies have come out with other models. This is again, it is from Weber. That is,
Yes,
I think,
that is the
imported or
Weber.
Indian? Imported, eh?
Yes, it's important.
It's imported. This is another endomat, which is, I think, called Weber. Can you see here?
Yes, sir.
So this again, 200 ml flow rate.
Yes.
This is the pressure. Now, since we have removed it, it is not functioning, but this is where the pressure is. But this has inflow pressure, this is volume. There is no suction pressure seen in this. Okay, this has both.
Yes.
But if you cannot buy this right now, we would say buy a Medex bag, 2 Medex bags, and use a TUR set.
Yes.
Use a TUR set, and 2 Medex bags should be there. So if one bottle is empty, you immediately close it, open the other one, and of course the pressure is a little average, we can say. We have to just see that you again see the adequate distension between 120 and 150. Don't try to pump too much, and always never put any needle from above.
Yes, sir.
Never put any needle from above, and somebody should be standing here by the side to see one bottle is empty, immediately change it, the other one is started, and by the time that gets empty, this should be started. So that is also a very good way of working if you can't buy an endomat right now.
Yes, sir. So that is one solution if we can't have histomat, and that works perfectly fine.
Yeah, no
Yes.
BP cuff, no BP bulb to
Yes,
be
sir.
put above and then just push. Those things are wrong.
Yes, sir. Thank you so much, sir. It
Thank
was
you.
nice demonstration. Thank you. The audience is very happy here. A big round of applause for sir.
Thank you.
Yeah.
ये दोनों system बंद हो गया ना?
Can we
दोनों-
go to the other OT if Dr. Anurag is free? We want to see the cautery settings there in the other OT. Dr. Anurag, can you hear us?
Hello.
Haan, sir.
Madam, in other OT, patient is being extubated now.
Okay.
So
Sir,
are
can
just
we just
needing
have a
to
look
check
at the
for
cautery?
this.
The audience was interested in seeing the Om Surgical's cautery.
Hello.
Hello. If we
Hello.
can show them the cautery which you used, the Pranav's cautery.
Hello?
Hello.
Hello, can you hear us?
Gopal Gare, sir.
Vaishali madam?
Yes, sir.
Yeah, this first theater, we are extubating the lady who has undergone TLH.
Yes, sir.
We are cleaning the theater and will be getting ready for next case, which will be done by Dr. Machwe sir.
Yes, sir.
So just give us some time, and maybe before starting that case, we will give some time to Machwe sir, or right now you want something, sir is there.
Sir, we audience wants to see the cautery which you used for the last case. The Pranav's
Okay.
Om Surgical's cautery and the settings.
Just 1 minute. They have
Yes, sir.
packed everything. I'll give it to Manish sir, 1 minute.
Yes, Dr. Manish.
Can you hear me, Vaishali?
Yes, yes.
I think they have used the COVIDian cautery for the last case. So your own cautery was used and bipolar
Okay.
and shearer. So you saw bipolar, you saw shearer being used on that.
Yes.
Let's see what cautery we're gonna. That is your cautery only, your own cautery.
Okay, okay. COVIDian is ours. Yes.
That's good, very good cautery. We could
Yes.
see the effect, no? It's a very good cautery. So there are two settings, important settings which Anurag used. One is for bipolar shearer. For shearer cut, you require a little higher setting. So maybe
Manish, you
40.
turn on this side.
Yeah.
Yes, yes.
So for bipolar shearer, you require a little bit higher setting and depends from cautery to cautery. I think for COVIDian 40 is good enough. If you use Allen, I have brought my Allen cautery also. So that bipolar shearer to use nicely, it's 50 watts. But if you use only bipolar without the cutting, then I think 30 or 35 watts is good enough. Because important thing is you don't want to char the tissues.
Yes.
You want the tissues to look white and pink as far as possible. Because what happens is if you char the tissues, there is only superficial coagulation. And the deep vessel is not coagulated, which starts to bleed after a little bit of time. So do not char the tissues, that is very important. And if you are charring the tissues, which means either your bipolar is not clean, you have to clean it, or your watt setting is too high.
Yes.
So reduce the watt setting, clear the bipolar, and at times putting some liquid there, maybe normal saline, etc. also helps. So what it does is it doesn't allow the tissues to dry up. Charring happens when the tissues dry up.
Yes.
So there is also a theory, a lot of people do that for uterine vessels. When they take uterine vessels in TLH, they would keep on irrigating and then coagulating together. Well, that is also one more thing to remember. So dryness of tissues, avoid too much of cautery settings and avoid a bipolar use which is not clean. So I think you all can have a cup of tea till the time the next case is induced, then we'll join
Yes,
back.
definitely, definitely.
Okay,
Thank you. Thank you so much.
Okay, and this theater one, I thank team anesthesia. We have Uma madam and Leena madam and one resident doctor. So thank you.
And congratulations, the whole team. A very good demonstration. So Dr. Anurag, Dr. Gopalgiri sir, and all the anesthetists.
Good thing was it was done with very simple equipments.
Yes.
Steps were very simplified. We did not allow him to use barb also at the end. I said like we can't afford barb, which will cost us 3,000 rupees.
Yes.
It's good. It was simple and it was good. So we can follow copy. Again, Manish sir wants to say something.
Yes.
Okay, so pertaining to sutures, what sutures we use, very important. We had this discussion with Gopal Gari sir yesterday also. For vault, I think use of barb this is according to me waste of barb. Because with barb suture, the thing is you get a very good uniform tissue tension, which is something which is not required for vault. Vault is just for approximation. I know there are so many surgeons who would just take one or two sutures, maybe figure of eight sutures on the vault and leave the vault heals. Not a problem at all. You don't want to strangulate the vault. So the place where barbed sutures do find a way 100% is myomectomy, where you require uniform tissue tension so that the wound heals properly. So for myomectomy, barbed sutures definitely. Recently, I've started using barbed sutures for ureteroneocystostomy. So when we have a UV fistula or we have a vesicovaginal fistula, if you are closing the bladder or if you are doing an anastomosis, we use barbed suture, but there we use 3-0 barb. For myomectomy, we use 2-0 barb, and even for bowel. So I have found that when we have sigmoid injuries or bowel injuries, even there you can use barbed sutures. So where did I get all these ideas of using barbed sutures on bowel and ureter, bladder, etc.? Ureter and bladder, this idea was given to me by neurosurgeons because they said they are using left, right, and center, which we were a little skeptical to use. And even for bowel injuries, we use barbed sutures because this idea was given to us by GI surgeons, wherein they said they are using barbed sutures left, right, and center every day. So barbed sutures find their application in various places. But according to me, I think using barbed suture on vault is really too much. I mean,
Yeah.
it's like if you are really hungry, you have everything in front of you, still you want butter chicken from some restaurant. That's too much to fetch, I think.
Manish, we understand that for the myoma barb suture, we need that uniform pressure, but how it benefits in bowel and bladder?
So even there, so once you are suturing a bladder or if you are suturing a bowel, what test we do for bowel is a flat tire test. So we fill the pelvis with saline and we inject air and see if the air is coming out from the injury. Even for bladder, if you suture the bladder, we do a methylene blue test or a saline test and see whether
Yes.
the anastomosis or whether the suturing has been airtight. So these are the places where barb will definitely be of benefit.
Yes.
The only issue is now we all have to know that 30 barbs are available for this kind of suturing because 20 the needle really becomes very big. So 30 barbs are available, so they definitely help in these places. But vault, I think, I don't know. I mean, I am really skeptical about vault because vault suturing is something which is just for approximation.
Yes,
And
we agree.
of course, so the difference is when we open the vault in a vaginal hysterectomy or abdominal hysterectomy, we hardly use energy source. We open the vault with scissors. We keep on holding them with, Ellis forceps. But for laparoscopic hysterectomy, the vault is open with one or the other energy sources. So your hemostasis is already done, right? So you only need approximation. And for that, I think barbed suture, I don't know, I have not used and I feel it's too costly for that.
Yes, definitely.
Okay.
Thank you. Thank you for these inputs.
Some people initially may even close vault from below, so it saves CO2, light, camera, everything. You are acclimatized also. You do it with simple sutures. So we take one angle on one side and do it simple vicryl. So that is also idea to save time when you are really tired at end of the surgery.
Thank you, sir.
Give us few minutes for preparing theater
yes,
one,
yes.
where we'll be having a big fibroid, which Manish sir will be. We are hoping like we request Manish sir to demonstrate the myomectomy earlier, and then we'll go with VLH. Let's see how we fare there.
Sir will demonstrate everything. Myomectomy, then TLH, then coring. Can we have the other OT view if the patient is ready there?
So in other OT also, actually the patient being extubated and being shifted. So
Okay. So we'll wait. We'll have a 5 minutes
yeah,
break.
maybe discuss amongst
Yes,
yourself for
yes.
some time or break for a cup of tea or something.
Yes.
But there also they are being extubated.
Yes, sir. We will wait for
Maybe
your
couple of
call now.
minutes We will have patient in theater one.
Sure. Thank you once again, the operating team and the anesthetist and all the supportive staff there. Very nicely demonstrated, and we all are enjoying all the surgeries. Thank you
Yeah.
so much.
Many people here actually from all the companies, they are dealing with their own equipments and our own staff. So enough people are there in the theater actually. And though it is like too many people involved, still it is being well coordinated.
Definitely. Yes,
you,
sir.
madam.
Yes. Thank you. Thank you, sir.
Good afternoon, one and all. Let's get started with another indulging session of these amazing cases. The next case, which is being prepared in Krishna Kumar sir's OT, I'd like to tell the history of that patient. She's a 45-year-old para-4 living 4 tubectomized woman with AUBP with right ovarian cyst. She had complaints of heavy menstrual bleeding since 6 months. Her menstrual cycles were irregular, coming every 20 days with 3 to 4 days and with heavy flow. Her last menstrual period was on 1st of June 2024. In her obstetric history, she's a para-4 living 4 with previous all vaginal deliveries and tubal ligation done. No significant medical or surgical history. On examination, there was nothing significant. The uterus was normal size, anteverted. However, right fornicial fullness was noted.
Priyanka,
Yes, sir.
probably you are presenting the first case which we are already done with. So
No,
you
sir,
talk about this another lady, she has got big uterus, she is diabetic.
So I am talking about the
No,
OT in Krishna Kumar sir's OT.
No, no, no. You are talking for that theater?
Yes, sir. That theater. 6.
Okay, not for her.
No, sir. No.
Okay, fine.
On ultrasonography, the uterus was normal size, endometrial thickness is 10 mm, and a small endometrial polyp of 7 by 7 mm size is seen in endometrium, and there is a 5 centimeter simple cyst in the right ovary. So she is posted for diagnostic hysteroscopy with endometrial sampling with polypectomy. Thank you. The patient being shown here is for diagnostic hysteroscopy with endometrial sampling with polypectomy.
Hello?
Yes, sir, we can see you.
Okay. See and hear both.
Yes, sir.
Thank you.
Thank you.
Yeah, so we are ready. I hope the polyp is big enough to be removed. So because of the gap, are the delegates getting bored? They are waiting or they had food?
So we just took a 5 minutes break and we all are back here in the hall.
Okay, no, because otherwise they will all go to sleep.
No,
Shani
no,
madam, you should take lecture there.
Yes, sir. Yes, our discussion is going on. No one is sleeping,
Okay.
and we all are looking forward to the next presentation.
ये थोड़ा निकालो, tub निकालो. Yeah.
Sir, we also want to know about cannulation, like audience wants to know about cannulation. So once you get free of this polypectomy, we have requested Dr. Vedpatak, can we just demonstrate?
So in this
the
patient only cannulation you want me to show, so I can show.
That will be great, sir.
But only thing, laparoscope you're not going to put, na?
Yeah.
So I'll just show you the technique of getting the
Yes. We can.
catheter close to the corneal cup and how to put it.
Yes, sir. Yes,
ते
sir.
आपला catheter निकाल के रखो tubal cannulation चं.
So we had planned it for the first case, but we got that surprise septum there, and then everything changed.
अच्छा अच्छा. एक catheter ठेवा. Of course, cannulation also, the tubal catheter is a 2 millimeter set. It comes with an external catheter and the Terimo guide wire. So we are ready for the case now. We'll be just starting the inflow. Again, your hand should be first up. Go to the direction of the posterior fornix, and there you can see the cervix. Follow the cervix. Can you see the chocolate? The
We
brown
can't see
color?
the inside view. Please, camera, please
You
show
can't
us.
see. Okay.
No, sir. We are waiting. Please show us the inside view. Yes, now we can see, sir.
Yeah, so you can see, identify the posterior fornix and the
Yes,
smooth
sir.
surface which you see is the cervix always. Follow that, you will get some brown color. That is the betadine, which is absorbed by the mucus of the cervix. Just follow it, go close. And follow the mucosal fold at all times. Keeping it in 6 o'clock, as you can see. Now dilatation of the internal os under vision. You can either use a grasper to dilate or you can use the same sheath to dilate. See some adenomyotic tissues coming out, the chocolate which is there. You can see the tissue breaking. Under vision,
Yes,
we
sir.
are entering. The internal os, as I said, it's an oval shaped structure. Can you appreciate that? At this time, you can rotate the sheath and enter. Bring it at 6 o'clock. See, my hand is so down.
Yes, sir.
There is no polyp. We will see again how to see the normal hysteroscopic anatomy. You saw external os, the mucosal fold, the internal os is oval, and as you stand here, you see the anterior surface, you see the left lateral wall and the left ostia, and the right tubal ostia, and then the posterior wall. You want to come, learn. Dr. Mandrekar. She is
Yes, sir.
pushing me out of the chair. She said, let me do. It's better that they should learn.
Sir, she does that with us regularly.
Yeah, she is. I can see from her size, she is capable of doing that.
Yes, sir.
No, come on. Don't touch it, never touch it. Touch
Yes,
like
let
this.
me see.
Hold
Yeah,
it
yeah.
here. I'll come on that side. Come out. Now keep your left hand here. Left hand. Come out. No. Start from here. Enter now. Enter. I showed you the principle, na? No. Come, bring it in the center of the screen. You move your hand. Now keep it at 6 o'clock. Take your hand down. Down. See, it's so easy, right? And then at this point, you can rotate the cable so that you don't touch the endometrium. So you never allow it to lift. Go like this. Now see the left tubal ostia. My left. That is the right of the patient. So how will you see? Cable to the, no,
Cable.
cable to the right. Then only you'll see the left side. Na? Come, don't go so close to the in the cavity. You remain at internal os. If you go close, you will not be able to see. You have to stand just above the internal os. So now see the right ostia. Very good. See. Can you now see the posterior wall? No, right hand, left hand se pakdo. Use your right hand. No. Like this. Now pass the grasper. No, इसको cover नीचे. Grasper का सीधा भी रहे. ठीक है, ते काढू नंतर. राइट वायर लाने का ना, ट्यूबल कैनुलेशन सेट. या ट्यूबल कैनुलेशन सेट डालेंगे. दिले जा दे. अरे बाप रे. झाड आहे. चलो लेटेस्ट ट्राय. नाही हे दे ना, स्टेलेट टाकावं लागेल ना. बघू. So we are just going to try selective chromoperturbation. We are just putting the no, do one thing. Keep it like this. In the cantilever. No, don't touch the endometrium. क्यों? इसको IVF करना है. IVF करना है ना, तो कुछ नहीं इसका. Just want to evaluate. Yeah, we are not doing anything. Now, तो कुछ नहीं करते हम. What I'll just show. See, tube लाया. Now you want to see the right side. Go close to the ostia को center में रखो. Tubal ostia. Now this is a used tube, so उसका curvature आगे का tip टूट गया. Keep it in the center. Go close. See that.
Yes, sir, we can appreciate. Yes.
No. I'll just show because.
Yeah. Sir, this lady is 45 years. ये IVF वाली नहीं है.
This your push. That's all. It goes there. Then you can put the Terimo guide wire, anything. It goes into the ostia. Can you see?
Yes, sir.
And you can do selective chromoperturbation also. You can just put in a laparoscope, selectively push the dye.
Yes, sir.
And you will see the right tube, patent or not patent. So this is better than your Collins cannula.
Yes.
If you're doing with hysteroscope, always do this way.
Yes,
Teach
sir.
your
Yes, sir.
students with the selective chromoperturbation. Now do it on the left side. You do it on the left side.
So audience wants to know the cannula size of what French the cannula.
This is 5 French.
5 French.
Yeah.
Yes.
अब करो ना मैडम. Oh, do it. There. अभी तुम कैथेटर को लो. कैथेटर को पकड़ो. Right hand sir. You are lefty or righty? Then use the right hand. अभी. See, now she is down. The ostia is up. So how
Yes.
to get that up? You rotate it anti-clockwise. बाहर से. See that it will go up. Can you see? Anti-clockwise. Like this. और अभी ये क्या इसका नॉर्मल कर्वेचर नहीं है इसका. This is a used catheter, so you are finding it little more difficult. See that.
Yes.
Do it. निकालो. Just pull it out. Now do it on the right side if you want to just attempt. पीछे करो. नहीं, pull it back. हाँ, अभी ऑस्टिया दिखो पहले. No, ऑस्टिया के लिए cable should be on the left side. No, don't lift the endometrium. Yes, now
Vaishali
I'll
madam,
hold the camera.
Yes, sir.
for you.
yeah, can Priyanka
Nice
present this case
karo.
to the audience?
Yes,
To
sir.
the
Yes.
Second TLH?
Yes, the other case. Sure.
अभी
Sir has
yeah,
put main
yeah,
trocar,
good.
he'll be putting
गया ना.
telescope now.
Very good. So tomorrow
Yes.
do.
Yes.
Tell your professor Ved Patel can Gopal करे मला करायला जा. सैम्पलिंग करते हैं. चलो.
The case is being started in another OT. I would like to tell her history. She is a 45-year-old para 3 living 3 tubectomized woman
Come here, come
with
here. Caesar
known
काय?
case of diabetes mellitus with AUBL.
सीजर देता है ग्रास्पर देता है काय?
She came with complaint of heavy menstrual bleeding with pain in abdomen since 6 months. She has regular cycles in the past with heavy flow. Last menstrual period was on 27th of June 2024. She has all previous vaginal deliveries with tubal ligation done. She is also a known case of type 2 diabetes on oral hypoglycemic drugs since 5 years, which is under control. No other significant medical or surgical history. Her BMI is 25 kg per meter square. On per abdomen examination, the uterus is of 22-week size palpable. Per vaginally also, uterus is 22-week size anteverted with bilateral pernicious free. Her pap smear is NILM. Previously, DNC was done, and on which the HP report shows endometrial stromal breakdown. On ultrasonography, the uterus is bulky, about 8 by 5 by 4 centimeter sized, anteverted. Endometrial thickness is 11 mm, and a large, well-defined hypoechoic lesion of 13 by 10 centimeter is seen in the pelvis, not separate from the posterior wall of fibroid, with minimal vascularity, extending up to the level of umbilicus, likely suggestive of a subserosal fibroid, FIGO stage 6 or 7. So the plan for her is a total laparoscopic hysterectomy. Thank you.
Bipolar देते हैं. Hi, good afternoon, everyone.
Yes, good afternoon, Dr. Manish. We can
Hi.
hear you and we can see you also.
Yesterday, I was standing between you and lunch. And
Yes.
today also, I am standing between you and lunch.
Yes, the audience is cursing you.
Yeah. So be with me for some time. This is a big uterus. I'll show you the external picture first. I have just put in my primary trocar. The uterus ends here, right?
Yes.
So the 4 finger breadths or little bit above is my primary trocar.
Yes.
So this is my primary trocar here, right?
Yes,
So around
this.
4 finger breadths or 10 centimeters.
Yes, this is very important to see that such a big mass you're going to remove. We all are excited about it. And we want to see how you place your port. Yes, very nicely. 4 fingers above the. 4 finger above is the umbilicus or the mass? Dr. Manish?
Yeah, give me 2 minutes. Just we'll arrange, start everything, and I'll just come back to you.
Sure, sure.
Yeah. CO2 not working. 16 कर प्रेशर 16 कर फ्लो रेट भी 20 रख ओके वरती करायचं बाळ हे तुझ्याकडनं मॅनिप्युलेट होणं थोडा अवघड आहे ओके ऑल राईट लाईट बंद करून टाका सगळे आणि मला वाईट देत आहे हा वाईट बॅलन्स करेल करा और गरम पाणी तयार ठेवा प्लीज काय नाही ठीक आहे ठीक आहे लागलं तर बोलत so now I'll try and put my madam head low करायचा head low करा so first is observe I think this is a transversely elongated uterus.
Yes.
And we will see I am able to reach only this point just now. We can see the cervix. Can you see the cervix there?
Yes.
Yeah, okay. All right. And we can see the round ligament there. दोन्ही हात लावा बाळा खालची बोट. And adnexa on this side. So for such big uterus, there is no rule of thumb what to start, where to do, whatever is there in front of you, you start. Now, important thing is the lateral ports. So my lower lateral port, I think, is going to be the same, which is around 2 finger breadths above the anterior superior iliac spine blade and 5 mm. So it's going to be the same, which is going to be here. Yeah, can you see that?
Yes.
So I have come in with a 5 mm, and the upper one will be 4 finger breadths or 10 centimeter above. Like Anurag said, it has to make a C, so it is a little bit medial to the previous port, or it is also known as the baseball diamond concept. So it is your trocars should make a baseball kind of a pyramid when they are seen from outside or even from inside. Now I have to put one more port from the opposite side. Thoda relax. Now this is between these two ports. So once we are into the surgery, I'll show you all the ports from outside also. Definitely ports change as per the size of the uterus. Ports change as per the indication of surgery and what you are supposed to do with these ports, right? So they will change. So this port, just now I will give my assistant a grasper, but if it is difficult to manipulate from below, then I will ask her to put a myoma screw. So putting a myoma screw is an option, but that option we are going to use last. Why?
Okay.
Because of the simple reason that once you put in a myoma screw, it may bleed from the area where you have put the myoma screw. And then you have to keep on changing the myoma screw direction, which I don't want to.
Yes.
So she can.
Manish,
help me by
before you start, just few things. Can your voice be little more clearer if your mic can be readjusted?
एक grasper आणि एक हे द्या.
And there is
Okay.
little disturbance in the relays sometimes. I think they are working on it.
Okay.
We are using Store's 3D 4K system for
Yes.
this.
Correct. So
And we are going to have,
3D 4K system, store system for this.
yeah,
And I will try and use sharer. I will show you how to use harmonic, and we will try and use different energy sources.
Right.
Sharer चा कुठला आहे?
we are having a 2D image here.
एक वाला ना? All right. So now you
3D
can see.
3D है but वो adjusted चाहिए ना अपने को ऐसा.
Okay. So you can see
आपने
the everybody
ऐसा
can
नहीं
see
दिख
the round
सकता
figure
2D
now.
हमें. हाँ, तो ये 2D में 3D दिख रहा है आपको. इसलिए
कौन सा
ऐसा दिख
कुठला आहे
रहा
रे शेअर चं मला
है.
कळलं.
मैं इसलिए उनको बोल रही हूँ.
एक वाला आहे का दोन वाला आहे? दोन वाला शेअरचं आहे. ठीक आहे. ठीक आहे.
त्यांना चष्मा घातला.
नाही. शेअरचं कुठलं आहे बाळांनो? कन्फ्युजन मत करो यार. एक मिनिट. ज्याला एकाला माहिती आहे त्याने इथे येऊन जा. एक कोणतरी ज्याला माहिती आहे.
गोपाळ खरे सर तुम्ही वॉश झाले का?
ही बायपोलरची केबल आहे का?
मनीष सरांबरोबर त्यांच्या असिस्टंटची टीम आहे.
अच्छा सर आम्हाला ना इथे ती 3D दिसते पण आमच्याकडे गॉगल्स नाहीयेत त्याच्यामुळे
थिएटर मध्ये 4 लोकांकडे गॉगल्स आहेत. आम्ही आमच्या साध्या 2 डोळ्यातच बघतोय.
ओके.
नाही सर आम्हाला 2D व्ह्यू
आणि ते
ऍडजस्ट
blue
करा.
आणि
करायला
yellow वाला
लागेल
आहे.
इकडून. ओके. आय डोंट नो इथे तर नाही
Blue,
करता येणार
yellow.
आम्हाला. रिले वाल्याला करायला लागेल.
तेच रिले वाल्यालाच आम्हाला गॉगल्स नका देऊ.
ओके. ए बाबा काय करतो? चल कर लेते हैं. Okay, the reason, yeah. So the reason why all this is happening is because my RAS is mesh RAS. That is point number one. Everybody has to remember always. So there is always dhakka start, but the end point is always good. So don't worry.
Yes,
There
yes.
is a little dhakka start always because of my RAS, which is mesh
I
RAS.
think it's the Kanantar bulldozer.
Yes, now the view is clear. Meshras is showing its effect. Again, it is gone. It has become 3D now.
भाऊ बघा काय होतंय.
The relay should be in 2D only. Relay cannot be in 3D.
Yeah, unless you are wearing goggles.
No, but have they?
So the output has to be 2D.
The output from the camera system, they must have given 2D only, no? Because with 2D, in 3D, if you see without glasses, you will get irritated because.
Yes, sir. That is what is happening here. We are seeing all two things, like what he is
otherwise
cutting, we are
Manish
cutting
has
two.
to operate in 2D only. Yeah, otherwise you'll have to make Manish operate with regular 2D, no 3D for him.
Friday को Friday night तो तेरे ऐसा रहता है condition पता नहीं था.
Yeah, they are just doing that. Just give them 5 minutes. They are doing that. See,
So
the
there
vessels
would
are
be big
very,
vessels, yeah. They're going to
very
be
large
vessels.
vessels. You
You
don't
have to
see
be
such big
very
vessels.
careful. And so this UV fold of peritoneum came in front of me, so I thought we'd dissect that first. So whatever comes in front of you first, you
No,
dissect.
it is a good practice to actually cut the UV fold and push the bladder down. If you can do that, when we started, we always used to do that because those days we thought the bladder dissection was the most difficult, 25 years back. So every case we will dissect the bladder and first be confident as bladder is gone away. Because
Yes,
those
sir.
days we were not tracing the ureter like today.
No, this case, I actually thought of showing the lateral pelvic wall anatomy, but this is a transversely enlarged uterus, so we will be
Yeah,
wasting
no
time.
space, yeah.
We'll be wasting a lot of time going and, dissecting on the lateral pelvic wall. So that is why I skipped it. And unnecessary manipulation, bleeding, losing time. So that is something which I thought we will avoid. Otherwise, my plan was to show you everything that we discussed yesterday about the retro. Anyways, if the case gets over, we will see. Anurag has shown you from outside. If time permits, I'll open and show you.
He is using the shearer with very, very good effect.
Yes.
All right. So now, since the bladder is there in front of us, we will sort of see whether we can dissect it down, right? CO2 helps. CO2 will help, for us to do this dissection, definitely.
Usually in enlarged uterus, large fibroid uterus, the tissues are a little more friendly.
Yeah, they are a cooperative. See, you can
They
see a
can
big,
be-
big vessel there.
Usually they just get separated faster because of the hyperestrogenic status. Excellent bladder demonstration dissection is showing. Did that become 2D now?
Yes, sir.
Oh, yeah.
मला थोडा
Double because you were quiet, I thought you are getting bored. Now you are appreciating the surgery. That's why you all are quiet.
Now people in the auditorium are more privileged than those who are in the theater without goggles.
Okay, so now I will try and
As well.
big vessels.
ताई माझा हा कॅन्युला थोडा मॅनेज करा तो आत गेला की बाहेर काढा थोडं बाहेर ओढायचं.
Manish, we can see clearly now
Okay,
in 2D.
thank you, that's good.
And we are appreciating your dissection now.
So there are a lot of veins here. Anurag
Yes.
also stressed that point that, there are a lot of veins here. Be very careful. I do not want to, injure or let any vein bleed. So what I'll do, I'll use bipolar and coag all that, okay?
Yes.
Because the shearer, of course, it coags and cuts, but sometimes it cuts and it cuts a tissue which is not coagulated.
Yes.
Whereas this, कुठलं आहे रे bipolarचं एक वाला झालं हो आता कुठलं आता bipolarला blue ना. Okay, all right. So this is what I wanted to do. Coag all this very nicely. So we were discussing, we have to keep the tissues white. Huh?
Yes.
We don't have to make the tissues charred. That is something which we do not want. Charring is not good. If there is charring, which means either your current is more or your bipolar is not clean. Mage. तिच्याकडे ढकल करूया. ठीक. So large uteri, it is good idea to take uteri. Let us see. We may suture the uterine at internal os, okay?
Yes.
Because if the uterine is very big, it is good to suture it at internal os level before, taking it. That would be a good idea. So standard steps, I think whatever comes in front of you, you take, of course, you always coag more than what you cut, and coag at 3 places, cut in between. So all the principles of the surgeries remain same. Of course, if the uterus is big like this, you have to follow all the principles there. In fact, you have to follow all the principles for all the cases, right?
That's better. And coming from you, Manish, it really sounds very good. We have to follow all the principles all the time.
Let us see. Now we'll try and use the shearer. Of course, we have harmonic also. So we'll use alternate. We'll see. I think in conferences, it is very good. In conferences, it is a very good idea. In conferences, it is very good idea to demonstrate different systems. Where you can utilize different systems and discuss its advantages, disadvantages.
Manish, you
Yes,
were
sir.
telling you don't want to use myoma screw
Yes,
because
sir.
it will bleed from the point where you have
Yeah.
inserted and removed.
Yeah, generally.
Do you inject vasopressin diluted and so that on the uterus and then use the myoma screw?
No, sir.
So
I
you
would-
will have a
No,
better
sir.
traction, you can push the fibroid to the other side.
No, sir. I would rather burn that area and put the myoma screw. But let us see. Just now, I think, aren't we happy with the traction that is being given?
No, no, it is definitely better. You are expert, that is why you are able to manage. But will myoma screw will be easier and to see the lateral part when especially transversely bulky uterus where the pelvic space is less.
Let us see,
But
sir.
it
I have
is
ke- I have
better,
kept
of
the-
course,
I-
if you can do it without the screw, you can use this instrument. And of course, he has got his own standard assistant. That is where she knows the exact step and she is using the grasper to good effect.
We've kept that option, sir. All options are always
No,
open.
just for discussion, whether
Yes, sir.
diluted vasopressin you don't use for what
Sir.
medical legal reasons or
Sir,
you don't like it.
Sir, vasopressin I use for myomectomies.
Ah.
My regular assistants are okay with vasopressin, so I don't have a problem with vasopressin per se.
See how beautifully the tissue opens up. It is very tissue friendly.
Such a big fibroid, so these vessels are there and we all are watching how nicely you're tackling these vessels.
So this is the posterior fold of broad ligament, which we are opening. Okay, I need a bipolar now because they are big vessels, right? नाही नाही सर एकत्रच काढू हो सर बस. So now see what assistant has done. She has taken the uterus away from the bowel. Where I was dissecting, bowel was very near. So that is the idea. Now this is the big uterine, right? काय करू? त्या वायकरी. What we'll do is, we'll do a little bit of skeletonization and let us suture this uterine, okay?
Yes, that will be
Because that
same.
would be good. It will
Yes.
give us some sense of relief that
Yes.
Sutured it before cautery or after cautery?
sir, after cautery a little bit better, for a simple reason that, you know, if the needle does go through some part of the vein, etc., we have cauterized it a little. Okay, all right. चल बाळा, दे. हा मगाचा अख्खा आहे. हा, ठीक. ठीक आहे. हलतो दाखव. A thread, see what I have done is, I have actually sutured the cervix to the manipulator. Okay, there's one more trick which we utilize. Why? Because you can use any manipulator, but if your assistant downstairs is sleeping, then the manipulator keeps on moving, dangling. दूसरा दे, needle holder. It keeps on dangling. So that is why what I do is, I suture it. So we will utilize the same suture and try and finish everything with this one vicryl. So I'm not cutting it just now. I know it is a little big, but it is okay, because we want to finish that entire hysterectomy with one vicryl, right? So I have sutured it. I'll once we are trying to remove it, I'll show you. So again, the angle has to be correct, or I'll suture with my left hand. So I think the angle is not coming correct. So what I'll do is utilize my left hand to suture, right? So we'll see. We do not want to go through any vein, right? So
Yes.
be very careful when you are taking this suture. All right, no problem.
It's okay. It's such a big fibroid and such tortuous vessels. We are bound to get few veins.
Now also understand that we are far away from ureter, okay?
Yes,
So
yes.
do not worry. But we will. So as a routine, what we do is, for all hysterectomies, we always check ureter at the end of the section. So this finishes in time. We will discuss the anatomy, and of course, I'm going to check the ureter. Okay, happy now with this suture?
Yes, very happy.
This will ensure us, give us a little security. So now what I do? Will I cut the uterine now? No. Why? Because the other uterine is still there. So what do I do? I'll take the other uterine, we will dissect it, then we will suture it. Sister, हे मेष रास वाली कात्री नका देऊ ना.
Oh, yes, आहे आशीर्वाद आहे. All the very best. Thank you.
I like to remove the needle, etc. when I am not suturing. Because idhar udhar lagna nahi chahiye. So no problem. It just takes 1 minute to put it inside and remove. All right. So now what do we do? Now I will request my assistants to let me see what I can dissect from my side. And then if it is possible to dissect from the other side. ग्रास पर देते हैं इधर so we'll try and go to the other side now. All right, so I'll try and see what I can pedicles I can take from this side, otherwise I'll go to the other side. Always remember that pedicles that you take, they have to be perpendicular to the energy source. Okay.
Yes.
So this is still okay. It's not exactly parallel. So I'll do this from this side, whatever is feasible, and then go on the other side. So this is another thing. If you have big uterines and you have not dissected the lateral pelvic wall and you want to take them together. Don't take one. The problem is if I cut that side uterine just now, and if it starts to bleed, I will waste a lot of time in achieving hemostasis.
Yes.
So that is one trick which kutla tari ugda air kara. All right, so this is possible. Ekda camera clean karunge bala. So now we have to go on the posterior leaf of broad ligament on the other side. Just clean the camera a little bit. Now is the vision good there?
It was little distorted, but now once the camera will be cleaned, it will improve definitely.
Okay.
We have few undergrad students
Yeah,
of
sure.
Priyal's batch. So they are seeing the big fibroid and
So there is a
probably,
bleeder here. Can you see?
yeah, we can see the bleeder.
Okay, so see what is happening now. I am becoming parallel.
Yes.
So I don't like this parallel. So what I'll do, I'll go from the opposite side. Right? So for people who have a shorter height, you can tilt the table on your side. But always be perpendicular, right? See,
Perpendicular.
now I am happy. I am perpendicular. Now I have to open the posterior leaf of broad ligament. आठ ढकल बाय खालची पोरगी. हाँ. गडबड नको करू आठ ढकल. See, so what I'll do more to help myself, Mage. Hold this, right? So I will help myself now. See, now things are still clearer, right?
Yes.
So now we know that this has to go down. You can see a big uterine turn there. Can you see?
Yes.
Nish is a surgeon from the old generation like us. As he said very rightly, be perpendicular. If opposite side, now the younger crop of surgeons, I've seen them, everything they do from one side only. And they say we can manage. But very rightly said, you should go at least at the uterine, you have to be perpendicular, you have to go to the ipsilateral port and you can't start from the contralateral. Because the bipolar will directly go towards the direction of the ureter.
Correct.
So this is very, very important and he's really teaching the correct way of tackling the uterine artery.
So what precautions we should take to save the ureters in such circumstances? Yes.
That first step, the ureter is going to go more laterally. So you just trace the ureter at the beginning of the surgery, see whether it is puckered and whether it is coming closer to the uterosacral in case of endometriosis. And of course, as he's doing the posterior peritoneum, that has to be again cut, incised and pushed down. By that, the ureter will again
See, there is bleeding.
down. So this is the vein which is pretty close to the peritoneum there.
Krishna Kumar sir, your sound needs to be little more clear.
So after pushing the peritoneum posteriorly,
Yes,
then
sir.
take the uterine and definitely from the contralateral, same ipsilateral. See, it is exactly at the level of internal os.
Yes,
The
sir.
direction of the bipolar
Yes.
absolutely perpendicular to the cervix.
Yes.
Doesn't run parallel. If you do it from the contralateral side, from the side where he is standing,
Yes.
it would have got directed towards that. Though cauterization does happen, but in occasional cases, there is a very, very bright chance of damaging or, the cautery going up to the ureter.
Yes, sir.
Suction again. We'll do a suction little bit. There was a vein which was bleeding.
Yes, yes.
As you all can see.
Yes.
And I'm going to suture that. Okay, so I'm going to suture the uterine on that side also.
Yes.
So before that, we'll just do a little bit of suction so that we see everything carefully. Suction tube put in. You can see we have finished the uterosacral clamp also in that. I'll
Yes.
show you. So this is the uterosacral.
Yes, that is that
Okay,
V
finish.
for the undergraduate students. The V is uterosacral ligaments. That is pouch of Douglas, which sir is cleaning.
Yeah, because whatever light source you use, if there is bleeding, it will absorb light. So you have to be sure and reduce the bleeding inside. Of course, you can put 5 bundle gauze, whatever you feel like, but a good suction is always good. All right. Okay, so we'll see, what we will do is we'll coax there a little bit more and then I'll put the suture. Yes, yes. Sure. Camera नको फिरू बाळा. Okay, so time to suture.
Yes.
थांबा इकडचं दाखव मला. थांब टाकून घेऊ त्या हाताने. देता येईल सुचू काढलेलं मी बाहेर. थँक्यू.
So Manish, now you realize why we fed you with those sabudana vadas.
Yeah.
Yes.
But if you are feeding me, I can do 10 such cases. No?
Yeah. Definitely.
Cases, no problem. Gastronomics is all that matters.
Yes.
Actually, आमचं पोट आमच्या हातावर आहे. So, and even yesterday's food, those people who missed yesterday's food really missed something. Huh?
Yes.
Yesterday's food was amazing, out of the world.
Yes,
It always is. I mean, your canteen is superb. Huh?
Thank you. Thank you for that.
तिला ग्लास करतो. त्यांनी काय कर uterus put पोक नको करू. ये मागे दाखव. एवढं धरशील. नाही घेत. Okay, so that side our angle was not correct, so I sutured with my left hand. Now I think this will suffice. So we go from here and we'll come back from above, right? Okay. Okay.
Nice.
Yeah. Little bit of ooze is there, which we will take. I don't want that bleeding to again hamper our field. So you take it out, okay? As I told you, take it out.
Yes.
Take it out. Grasp for that. See, a lot of people will say, why are you wasting time in removing the needle, etc. Please understand that the needle lying here and there is
Very
not a good
dangerous.
idea.
Yes.
Let us waste 2 minutes in removing and putting it again when we need. हे दे ना मला. Grasp कर दे. काढ बा. हो, bipolar करायचं.
Stowe's 4K system is really good. It's giving us very beautiful view and clarity. We would like to thank Stores for providing us the whole system.
Okay, now is the time to take the uterine.
Yes, we are there with you.
Of course, God has to be there with us now.
Yes, yes.
Grasp कर देना मला. Very traumatic. So again, I will help myself by pulling this towards me, see? So I can help get up. Take it. ढकल खालती पोरगी तू ढकलत नाही. ढकलत नाही हो. Okay.
Yes.
So we finished
Looks
one
good.
side.
Yes,
We'll now go to
yes.
the other side.
Yes.
तिला पण grasp करते.
And due to the stitch, we are very safe and secure.
Yeah. Because
Yes.
it really helps. I mean,
Yes.
it takes away few seconds. Some people don't like it.
Yeah, but we are convinced
Always
everyone
feel
here
that,
is.
you know, see, even here, I would not cut directly. I would still want to burn a little.
Yes.
I'm still not happy with how it is looking.
Yes.
The other side was looking nicer than this. So what I do also so many times is with my left hand, now we have sutured, so no problem, but I'll hold the uterine. So if it starts to bleed or if it starts to retract, I have it in my hand. That is also one more trick. So many tricks, no, small tricks, which will help you when you are doing these surgeries.
Hello, can you hear us?
Yes, sir, we can see that
Now,
here.
who is
That
doing the hysteroscopy?
we again saw Nishita, I guess, or who's doing it?
Yes, this is not Krishna Kumar.
Yeah,
She's
we
doing
saw
so
someone.
wonderfully, see there.
Charvi कर रही है?
Yes, enter the telescope and the cervix is seen. Where did you go? Now, ऐसे करो. Enter, no, keep it at 6 o'clock. Keep it at 6. Then only you can enter. I told you from morning, 6 o'clock, 6 o'clock. Now go, 1 minute. Now the os is, hold it like this. Keep it at 6, take it down, take your hand down. Oh. Why is the door closed?
Can we have the details of this patient, Priyanka?
The
In
case
short,
being shown here is a 35-year-old with a history of 3 abortions with secondary infertility. She was
Last abortion
unable.
was when?
Last abortion was 2020, sir, 4 years back.
4 years back.
Yes, sir. And all 3 times she has undergone dilatation evacuation.
Okay, that means there is adhesion at the internal os, if you see. So it will be, take a scissor, there is the opening there.
She is trying to conceive since 10
Scissor.
years. And all 3 times
See,
that she
there is
has.
the opening. Can you see that? Can you see there? See?
Yes, sir.
Internal os is seen.
yes, sir.
So that's why you should do without dilatation. Now you can appreciate that internal os is seen there. Keep your steady, hand steady.
All 3 times that she has conceived on ovulation induction. In the past 4 years, she has undergone more than 10 cycles of ovulation induction with timed intercourse. Also, 1 failed cycle of IUI last year. The husband history is not significant, no medical, surgical, or addiction history. The
Now,
coital
scissor,
history is
go
also
here.
normal.
That septum or adhesion which is seen, you cut it. Okay, like this. Take your hand up. Cut.
On hysterosalpingography, HSG, the bilateral spill was seen. Husband semen analysis is also normal. She has undergone a APLA screen, which is negative. AMH level is 6, which is normal.
Cut all these fibers. The under vision.
And
cut all these
ultrasonography is normal.
fiber, yeah. And now you again 6 o'clock under vision. Still not allowing, so you cut more lateral fibers. And take it a little horizontal. Keep it at 6 o'clock. There you can appreciate it is opening up. Was she getting regular period now or it has become scanty? Because there is definitely some adhesion everywhere.
She is getting regular periods, sir, as
Yes,
per the
sir.
But
history.
there is some adhesion in the lower part of the uterine cavity also.
And sir, she has periods lasting for only 2 to 3 days.
That's
With
why
less
it has
flow.
to be there.
Scanty.
Oligomenorrhea has to be there.
Yes.
This goes without saying that she has oligomenorrhea. Sometimes we have to ask a little probing questions to them.
Yes.
How many pads do they use?
Correct, sir.
see how to go, the cutting has to be done here. So I change it. And then I go gradually, step by step, you see what you can do. Most of the time it may be lower part of the this. It's sort of just in the canal, if you see now. It was more in the lower part, below the internal os, those adhesions. So now you can enter there.
Yes.
So the cavity looks okay.
Yes, sir.
Septum was cut, was told, was it the large septum which we cut last year?
No, sir. This is a new
So
patient,
this
sir.
is not the patient which
Acha,
we
acha.
have
Then,
taken.
no, doctor with Patak told me it is a septum which we have done. So I was wondering whether the
No, sir.
septum.
This is not the one.
Right,
No.
fine. See, now the cavity is fine.
Yes, sir.
But she seems to be having an element of endometriosis. Does she get dysmenorrhea?
Yes,
Right?
she has history.
Because she has
Yes.
got a retroflexed fixed uterus. Why? Because the right ostia is where? It is at almost 5 o'clock position. Right ostia should have been at 9 o'clock position. Uterus, now it is turned. See, there is some fixation. Now you can see that is thing. Fine. Cavity is okay.
Yes,
Now you
sir.
enter from below again. You enter all that. See, these were the adhesion area which we entered after cutting. So adhesion was more in the lower arm of the cavity.
Lower part of it.
So
Yes.
you go lateral metroplasty. You go that side. Vision is otherwise good.
Yes.
Understand? So now, so this is the trick of doing when you don't dilate. It is so simple that you are, otherwise you would have never known there were adhesions.
Yes.
Now do enter. You enter now. Come on. Hold this. Yeah. Hold always at the head. Support the head and the camera, everything together. Cable is here. Hold this cable only now. Come out. Come.
अप एरो ना एक बार प्रेस करके छोड़ दो
ये वाला.
रिकॉर्डिंग इधर कर दे
ये वाला.
हाँ प्रेस करके छोड़ दो इमीडिएट हाँ नहीं सर हाँ बंद कर दो छोड़ दो
Camera, can we have one view of the other OT?
दबा के छोड़ दो
Yes, Manish, we are back with you.
Yeah, we are opening the vault now. So what we are using is a combination of bipolar and harmonic. Why? Because even though we have taken uterine, there are still vessels in the lateral fornix, which are branches of vaginal artery, and they would still bleed. So what I do is we push in the tube, exactly like Anurag did. Very good idea of pushing in the tube. And with the tube, very little of vagina is actually lost. So it is a good idea to do that. On the contrary, when we want to remove some part of the vagina, as in radical hysterectomy, we do not use the tube, so that some part of the vagina can be removed. Right. So
Yes.
here we are using garam pani.
Manish, you are a don, but with this specs, you are really looking like a don.
Yeah.
Yes.
Good. I am going to take a photograph and put it on my DP.
Yes. A little fogging and the
Yeah. Okay.
camera
okay, we'll
needs to
clean
be
it. We-
cleaned.
We want hot water.
Yes.
So everybody is saying everybody is so hot. Why do you need hot water? We want hot water for the camera. Right? So, of course, use of colpotomizer. This is a small tube. There are different types of manipulators available. There is a Dr. Prashant Mangeshikar manipulator. There is a Clermont-Ferrand manipulator.
Yes,
There
the
are so
vision
many
is
different
better
types.
now.
Yeah. So there are so many. So see, these are the vessels I was talking to you about, right?
Yes.
So if I try to cut it directly, this will bleed. And this will soil the field, and I'll again run after hemostasis. So all that we do not want. So although you can see that uterine is nicely taken, but still we do not want bleeding from here. So it is a good idea to, coag before you cut. And whenever, so I'm using here harmonic to cut. So it has to be in very small part. Okay. Don't take a very big chunk of hamara. we cut very small part. Okay, so don't take a very big part, because if it bleeds, something happens, you can again catch it and again take care of it. See these blood vessels. So,
Yes.
and this is not just for this patient because he has a big fibroid. This happens in all AUB patients. So at this point in time, they have these veins, which are dilated veins, all AUB patients, not only fibroids. Of course, in endometriosis also you get. So it is a very good idea to, put bipolar in one hand and then, do this.
Drilling case.
This doesn't want to go. Antibiotic. Antibiotic. You can see the taut uterosacrals.
Yes.
So the idea is to cut above the uterosacral. So let the attachment of the uterosacrals to vagina remain. Only cut the attachment of the uterosacrals to the cervix. Okay, so okay, so now the posterior part, Gopal Gare sir was saying that, sometimes it is really difficult to go posteriorly for big uterus. So we'll try and go from here. This camera, ते उल्टा करना देतो. कॅमेरा वाले घरी गेले. उल्टा करना. याच्यावर आहे का? There's a function of, you can rotate the camera by 360 degrees. Antivert कर खालची पोरगी. So that you can see this part. अच्छा. In front of you, like, ते रोटेट होईल ना कॅमेराचं. गोल फिरो ना. तिथनं फिरो. गोल फिरो ना. इसको त्याला कल्पना नाही, त्याला कुठे बोलतोय रे. Okay, so it rotates. There is a function where it rotates, and you can see the anterior part. You can see this in front of you. So I don't know where he's gone. I told you, Mesh Ras. मागे ये बाळा, instrument नाही दिसलं की मागे. येते गोल फिरो ना बाळा. करू? होतं? नाही होतंय. Okay? आता? कर click. Okay, can you see now? Vision
Yes.
okay?
Yes.
So that is the place where we have to go. See, this is the rectum here, iske niche. So we are not going to go there. We are going to remain here. And try and go above the uterosacral on the other side. So whatever you can finish from my side, we will finish and then go to that other. आज जा बाळा थोडा अजून. क्लिअर दिसत नाही ना का मलाच दिसत नाही.
नाही, थोडं फॉगिंग झालंय.
ओके. काढ बाळा बाहेर. तर clear. So I'll see now again the same principle. If I cannot reach from this side, I will go on the other side and then finish the colpotomy. Under no circumstances, I always feel that your cutting instrument or your coag instrument should be parallel to the pedicle. Should always be as perpendicular as possible to the pedicle. Then it really, makes a lot of sense. And of course, it doesn't damage the structures around. Up होईल. Okay. So now it is rotated or what? Now rotate it again. I don't want that rotation function. याच्यावरनं हिटनं नाही करता येत का? ओके बघू. Okay, right. Hmm. So I have to go from the other side. I don't think I'll be able to. मला instrument दिसत नाही बा. तुझ्याकडनं आहे. हो, काय? माझ्याकडनं टाकता या वरच्या याच्यातनं. सो ते बॉल मागे घेऊन दे. So no ghai, no gadbad, okay? I
Yes.
think ghai gadbad you should not do in any case, but 100% never in these cases. So see, so she will show me like this and push this inside. But and because I'm still not happy with the coag, I will coag it a little bit more.
The audience was asking like which energy sources you prefer at which place, which one is your choice?
See, just now I want only coag, so I am using bipolar. Different energy sources are bipolar, monopolar, which I never use. I have used in the past. Now monopolar is all gone because only indication for me for monopolar was PCOD drilling, which is now more or less gone. So monopolar has gone. Second is bipolar, which you have seen today. Even Anurag showed beautiful use with bipolar and with sharer. So we use bipolar sharer. Next is harmonic. So we are using harmonic on the vault. I thought it is a better preposition to use harmonic on the vault. Then of course you have a combination of bipolar and harmonic also available. And you have vessel sealers in the form of N-seal. It depends on what you like and what you are used to. But for learning purpose, my suggestion is you learn everything. You should know everything. And finally, Gopal Gare sir will be very happy when I say this. Finally, at the end of everything, you have to 100% know, master bipolar and scissors.
Yes.
Because nothing, open also, yeah. Sometimes nothing works. Bipolar and scissor is the only respite that you have. And you can't do anything there. सांभाळा घे पण. हे वापरू तिकडे थोडं. दाखव बघा काय करतो. आठ डझन कविता ताई. All right, so we finished the hysterectomy.
Yes.
We'll remove the tubes now. And the big question, अभी इसको कैसा निकालेंगे?
Yes.
Right, so we are going to do a technique called as lateral vaginal coring. So we are going to remove this from below.
You can see how he ties the manipulator to the cervix. You can see the
very
vaginal
well
knot.
demonstrated by Manish. I just want to add one thing. In such big uteruses, you can just take the tube behind once you open the vault and catch the cervix with any Alice or something, and from there you can dissect the entire vault.
Correct. That is
That
what
is also
yoga-
one technique.
Yes, one technique. That is exactly what I was telling sir. But fortunately, we could see posteriorly. Otherwise, my plan was
Yes,
to do the
if
same.
posterior is not seen, then that becomes an ideal technique.
Lot of people, would do that Anurag for all patients. So they would not go posteriorly at all. They'll hold it and from anteriorly finish off. Lot of our friends do that. I see their videos. But yeah, so when you are learning Odalpai, when you are learning, please learn all different techniques, okay? Any technique can be utilized. It will be useful to you. So when learning, I guess you learn all techniques. So
Yeah, that's a very good statement.
at least see, get used to do it in few cases. Unless you do it, no, you will not know. Darbar. So what we are required to do is we will first correct the head low, so that by the weight of the specimen it will not keep on moving upwards. That is one. Second is we need two sim specula and graspers in the form of Elis or Valsalem, and we need a good blade. So idea of lateral coring is, you have to see the specimen is globular. You have to make it vertical, right? So what we will do is, we will keep on cutting from 11 o'clock to 5 o'clock and we'll keep on rotating the specimen. All right. Okay. So we will now, Madam head लो सीधा कर दो. ये पकड़ लो. All right. So this is all done.
Yes.
Head लो सीधा कर दो.
Wonderfully, only you could do it, Manish. So well, such a big uterus, no myoma screw used. Wonderfully done.
No, everything. It's a team effort. We have fantastic anesthetists,
Yes.
fantastic people assisting, and all of you there for, supporting us. So
Yes.
it's always a team effort. And anesthetists are very good, यार. वो मेरी आपकी anesthetists मेरी सब बात सुनते हैं. So
Now we are looking forward to the coring, how you have this huge tumor, huge fibroid, how you are going to remove from below.
Yep.
It's such a challenging thing, and we all are looking forward to it.
scissor दे दो. टाकलाच नाही लागेल. याच्यामध्ये दोन्ही ट्यूब असतील ते नीट घ्या. मॅडम हेडलो सपाट कर दो. इधर बाळा. आणि वरती घ्या टेबल. हाईट वरती वाढ. Okay, can you see this now? What I have done? I have put two sim specula. हा चांगला नाही काय मला चांगले वाले दे. Okay. So one is light इथे खाली गया. So see, one is एक mop घे. One is protecting the bladder and one is protecting the rectum. All right?
Yes, Manish.
Am I seen now? All
Yes,
right.
yes,
Keep
it's
it
very
here.
clear.
So now I will take a cut from 11 o'clock position to 5 o'clock position. Okay, cut taken. I will hold the specimen. Tenaculum पण चालेल ना time आला. And I will rotate it. So I will hold the specimen and I will rotate it. Now I have rotated it. Again I will cut from 11 o'clock and come down to 5 o'clock. Again I'll hold the specimen. नाही ताई तू माझ्या मध्ये येते. तू काय करते माहिती का? तू माझ्या मध्ये येते. तुला ब्लॅडर बाजूला घ्यायचं नाही. दे.
Manish, I'm remembering our teachers as you're
Yes,
doing this.
Yes. दाखव. काय आहे? दिख रहा नहीं मुझे अंदर का कुछ भी. Madam, that specimen is going up. You need to do a little head up also. That's also good. थांब बाळा, तू माझ्याशी भांडते. हे काढून टाक. Catheter काढून टाक. We'll remove the catheter to make a little bit
It's
of
coming
space
in
there.
the way, the foliage?
Yeah, foliage is coming in. So we'll remove it for some time. हाँ, याच्यापेक्षा छोटा है. हाँ, बस enough. छोटा सिंस असेल तर घ्या. Okay, cervix has come out, see, it's broken. So, okay, we continue. We have to do the same procedure. Procedure doesn't change. Yes, Sims. आहे वरतून बाळा, झोपू नको. नाही बाळा, तुझा बॉवेल घेत नाही. नाही बाळा, बॉवेल येतोय मध्ये. कविता बॉवेल येतो. बॉवेल येतोय ताई. थोड़ा सा हेडलॉक करो मैम, क्योंकि बॉवेल आने लग गया. बॉवेल आ रहा है क्योंकि नहीं तो नहीं करता है. So this is one complication. Okay, the cervix breaks.
Yes,
breaks
it
so
does,
many-
especially when most of the fibroid is in the
big upper segment.
upper
yes.
segment.
Good. आता हे सगळं वरती गेलं, आता ते वरनं आपल्याला धरायला लागेल.
Then it starts floating around.
Yeah, no problem. We'll take care of it. बघू मला वरनं दाखव एक सेकंड. What we will do is we'll push it a little bit down. हे फ्लॅट केलं तरी चालेल. हा. Or we can cut it. There are so many ways. Let us see. हे कर. दे एक ग्रास पर घे.
Like you rightly said, Manish, one should learn all the possible ways. You
Yeah,
never know what you need to use at what
Yeah, you never.
moment.
I am.
So one can't be fixated in learning one method and saying that this is what I will follow.
Yeah. No, there is no one technique is good for all.
Right.
चल इतना एक हेटा मोटा वलसेला.
I think this
We'll
blood
see if
must
we
be
can-
from the snapped specimen, if
Pardon?
I'm not mistaken.
Yeah.
That blood must be from the snapped specimen.
Yeah. This specimen will have lot of blood, so don't worry.
Absolutely.
This is going to have lot of blood inside. All right. So if it is not
You're
coming
putting
like
in a screw?
yeah, I think we will cut it a little bit. चांगला scissor दे. We'll cut it into 2 halves and then pull.
Right. I think it'll be easier to grasp from below then. Now
Yeah,
that the
so,
cervix
yeah,
is
once
not
we put
there.
na, it will be easier to grasp.
Right.
Sir, specimen. Because just now the thing which we were trying to grasp has been cut off, no?
Yes.
It's gone. Okay. Sir.
So we can all appreciate how very vascular this fibroid is.
Yeah.
And how beautifully a bloodless surgery was performed for this kind of a lesion on the uterus.
इथे कोपऱ्याला धर.
It's ready to burst with
Yeah.
blood.
But this is all blood which is not from the vascular system. of
Absolutely,
patient.
absolutely.
So we are okay.
We're just appreciating how vascular the condition is and yet how avascular the surgery was.
That is because of sabudana vada in the moon. धरत नाही बाळा तू. ते ना कुठला पण नाही पण ती धरतच नाही. ठीक.
Oops. Cramp हो गया.
So different ways. We'll try and remove this from vagina. If not, just increase the left-sided
Port.
incision a little bit,
Yeah.
port, and pull it out from. So we always do lateral coring, and lateral coring does not work if this thing happens, if the cervix breaks.
Yes. You need to have a real firm grip on the cervix in to go
Yes.
on coring
No,
laterally.
there's one more reason. The reason is that the cervix
Yes,
was very weak in this case because the entire fibroid had pulled it up.
correct.
So very weak cervix. So that is why it broke off. In one cut only it broke off. हाँ. Clear नहीं दिसत ना. So tissue retrieval, doing surgery is one thing, tissue retrieval is another. Both are important.
So it's good for people who are in this workshop, lots of lessons learned.
Yeah.
Sometimes
Okay.
when things happen very straightforward, there are some lessons which maybe
No,
we
you
don't
should-
get to
In
see.
workshop, actually in workshop, I always believe you should see complications.
Yes.
You should see this happening so you know what is to be done.
Absolutely, because troubleshooting is something which every surgeon must be equipped with.
I think let me increase the
Port
left
size.
side in port side in incision. That would be way better. It will come out really fast. Right?
Yes.
Instead of going down and struggling,
Yes, I agree.
and it will be good for patient too. Okay, चल thanks. मला हे इथलं incision दे. We'll increase one incision and we'll take it out through that. एलिस आणि हे सगळं मगासारखं दे. तर मला ब्लेड दे हे इन्सिजन घ्यायला आतनं दाखवत आहे. ब्लेड हा घे ना. चल इथनं दाखवत आहे. ओके विल इन्क्रीज दॅट इन्सिजन. हे मागे घ्यायचं. मी टेबल तसं होते ग्रासपर कशाला तिला ग्रासपर बॉल मागे घ्यायचं. दाखव मला आतनं ब्लड वेसल दिसतील. दाखव दाखव बघा. दाखव बघा. बॉवेल घ्यायला तर हे दिलं ना. तू घेतच नाही. स्वीटी ऑन झाली. आता स्वीटी ऑन झाली काही. ठीक आहे चल. हाँ लगेगा 1 सेकंड. दाखव अजून ब्लेड दे थोड़ा ब्लेड दे. ठीक है हाँ. ऊपर का लाइट लगाओ 2 मिनट. हे दाखव मला बा. ते काढून घे मला. काढून इकडे ये. दे मला आता ग्रासपर दे. राईट अँगल घे ग्रासपर घे. सोड मला खाली. Okay, so we have increased it a little bit and we will take it out through this. Hey, then Sims घे ना. त्याचा उपयोग नाही होणार बा. हे दे. आणि एलिस ते CO2 बंद. चल पेशेंट पुश करते हैं मैडम. पेशेंट इज पुशिंग. चेक प्लीज. CO2 बंद करना मैडम. चिकट ले मैडम. दे एलिस. लॉंग एलिस ते वल्सलम पण चालेल. टिनाक्युलम पण चालेल. म्हणजे ते धरता येईल त्यांनी. इकड नाही मला काहीच करत नाही ना. हा
हे घ्या ना सेक्शन घ्या ना.
सक्शन नाही होणार. हो त्याच्या पुढे घे चल दे टिनॅक्युलम
खाली गेलो तर सांगा मला
चल ते काढू आपण नाही दे ब्लेड कुठे गेली ताई इथेच थांबताय
इथे वरती ठेव माझ्या हातावर दोन्ही हातावर ठेव उलट ठेव सरांना इकडून घेणार बस नाही पडणार का रिसेप्शन जो करतो तुम्ही हा द्या तुम्ही जा तुम्ही आता काही गरज नाही हा 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 लागलं तर घेते
नाही ताई इन्स्ट्रुमेंट चांगले देत आहे मी तुला टिनॅक्युलम घे मस्त टावेल क्लिप टिनॅक्युलम त्यांनी धरता येत ते एक हात टाकलाय मॉप एक मॉप हात टाकलाय दे ना ताई दुसरा एलिस ते एलिस टिनॅक्युलम बल्सेलम दे दे ना तू काहीच दे ना थांबा नको थांबा तुम्हाला फक्त धरणारे इन्स्ट्रुमेंट आहे बाकी मी करतो
ब्लेड पण घ्या सिस्टर
ब्लेड घेत आहे तुझं
ब्लेड घ्या ब्लेड
So are you excoriating it, Manish, even through that extended port?
दे बघा
जसं ब्लेड घे
खालून फार बोर गेला आता तुम्ही बरं बोलू का हा एकच सेकंड बरं एक मिनिट हे कर ठीक आहे थांब सध्या बरं चाललंय सध्या.
छोटा राईड
नको नको थांब. घेतो. नाही नाही ना. बघू काढ. नाही खूप आहे खूप आहे खूप आहे घे. थांब नको टाकू दाखव ब्लेड. ठीक आहे. वायकरी लागेल हा आतमध्ये क्लिअर करायला. इधर करूँ. हे बघून सगळ्यांना भूक लागली असेल.
Manish, in fact, we are really appreciating your ability to adapt and do your own version of an abdominal lateral correlation, I think, is what you're trying to do.
Yes, but you know.
We also appreciate the difficulty which you're facing in getting a good grip on the specimen.
Yes, it is.
I think
difficult.
that's what is the biggest challenge right now.
Yes, yes. But what is important is, see, we would have really struggled vaginally with this.
Agreed.
After the cervix broke.
Exactly. So that's what I'm appreciating your decision making, the ability to think on your feet as the situation changes. Very important qualities, I would say, in a surgeon.
बहुत बड़ा है सर. इतने से नहीं आ रहा है. बघू दावा. चला चला. इधर. नहीं ये ठीक है डिस्प्ले सब पर.
अब आ जाएगा.
रुक ले नहीं. दे दराला. हाँ. इधर टाके.
अब आ जाएगा. The thing is, it's within the capsule, so it's coming out like myomas.
नाही नाही होईल.
The cameraman had a better view earlier. Can he please go back to that same view?
इकडनं ये माझ्या माझ्या उजव्या खांद्यावर आलास ना तर सगळ्यांना चांगलं दिसेल.
No, we had a very good view. I don't know why he's changed it suddenly.
Okay.
Now we can't see.
फायब्रॉइडच्या आत कट करायचं वरती करत हे दे. इथे अडकतंय ते काढू. थांब. काढतो इथं.
Yes, we have a good view now. Can we please hold that, cameraman? Sulochana sister and back येत मध्ये.
I know we are changing it very frequently.
It's okay, it doesn't matter.
So this is morcellation only. You have to,
Exactly.
wherever it is getting stuck, you have to morcellate that part and remove. हो लागेल मला वॉल्ट सुचर करायचं आहे. थांब थांब घरी नको जाऊ मी सोडतो. अच्छा. थांब थांब नो प्रॉब्लेम. So again, a debate could be why not use morcellator. I'll tell you the problem with morcellator in such cases.
Yes, Manish.
There will be lot of small bits of fibroid
Yes.
which will fall here and there.
Floating around.
So morcellation will take 1 hour and removal of those bits will take another hour.
Yes.
Plus we have to keep on searching where they have fallen.
Right.
So I think for such kind of uteri, morcellation is not very हे चांगलं हे कंटा.
I think what you're doing is the best solution, whether done vaginally or through the
Yeah.
expanded port.
Of course, of course.
त्या आधीचं होतं ना ते काढा आणि त्याला लावून घ्या.
नको टाकू. ये ले, तो डाल दुसरं वापस. हं. वंशलम टिनॅक्युलम असेल ना तर त्याचं रपकन धरतं, आत घुसतं ना. नाही चाल. अरे फिनिश, कुछ नाही.
Manish, we have some very good gripping bulldogs if you can ask the
Yeah, they
sister
have
to.
given.
Yeah.
But I feel no.
Yeah, the tenaculum
tenaculum
definitely
holds the
because
best.
it just digs in.
Yeah, it will hold the best.
Right.
हं. ते परत.
म्हणजे
मारामारी नको करायला. तर येऊ दे ना त्याला, प्रेमाने येत तर.
रिक्वेस्ट करते हैं.
हो थांब. एक सेकंड. बरं. थांब. काढून घे ना. इन्स्ट्रुमेंट मोकळे होते. काय आहे त्याच्यावरून? पेरिटोनियम नाही का? पेरिटोनियम रे. पेरिटोनियम नाही, त्याच फ्लोर नाही. तापवावं लागेल. हे चांगलं जातं.
Oh, I think that does deserve a round of
Okay.
applause for you, Manish.
Thank you, thank you.
And I think you can hear it.
Yeah.
Really, hats off to your patience, calmness,
Right.
and like I said, your ability to change your decision on your feet as the situation demanded.
So we are now going to suture laparoscopically and just take view that there is no bleeding.
Right.
And then we will close all this. So I'm going to close this. We can take subcute, so patient will not feel bad. And this incisions will, it's along the Langer line. See, if you
Right.
can see this,
Yes.
I have not taken it like this.
Right, Manish. We
I have taken it
appreciate
like
that.
this.
Yes.
It is according to the Langer's line. So when she stands up, the fold of her abdomen will fall and this will not be seen at all.
So
that is
concern for your patient's cosmetic end
yes,
result
of course, always.
persists.
Yes, so
We appreciate that.
it will not be seen. Okay, so we will now suture. खालनं vagina clean कर आणि blue टाक. मला तिथनं सुचर टाकायला लागेल. सुचर टाकायला लागेल ना ते. सोडून दे, मी करतो. तू vagina मध्ये. चलो, CO2 चालू करो सर. फालतू. So she is again put the colpotomizer inside.
Right.
This will prevent
The
any
leakage.
pneumo leak.
Right.
We will take a new vicryl. ये छोटा है मुझे थोड़ा एक पैकेट. You can take the table down and head low. थांब बाळा, हे थोडं छोटं करू. हे पूर्ण फुल नवीन घेतलेस ना? हा, तो आपण तो थोडा छोटा. तेवढं हे तर कट करा. यानी ते रेक्टस सुचर करा यानी आपलं वॉल्ट सुचर. तर मला निडल होल्डर्स दे. ते नाही लॅप्रोस्कोपी. निडल होल्डर होता ना. तिला समोर न टाकायला ग्रास्पर द्या. घे बाई ग्रास्पर घे तेवढ. तू खालना एअर प्रिव्हेंट कर. घे बा. काय करते काही देवा. अरे ऑन भूक लागली. स्वीटी ना नको CO2 येणारच नाही बाळा ती खालतं केल्याशिवाय. CO2 चालू केलाय का बघा. CO2 बघा 2 आहे. वाढवा प्रेशर वाढवा. CO2 चं प्रेशर घ्या. तू उपटून बाहेर काढले बाळा. माझ्याकडे लागलं का. चला CO2 बघा. हा हा बघ बघ सगळं ते वरती घे. हा ठीक आहे. लाव. हा हेडलो करता मॅडम अजून तू हे क्लीन करून स्वच्छ कर. हा थोडासा कर दो. खालनं ब्लीडिंग वगैरे नाही ना कुठ. या उसका वेट करो और क्या. महामहिल फोटो निकालेंगे. चल दाखव. व्हेरी गुड व्हेरी नाइस रिजल्ट. हा चल आज जा. हे सेक्शन मध्ये येईल का ठीक. खालनं गाड्या दे सेक्शन. दे सेक्शन. There's some clot there.
Yeah, I think it was from the specimen when you
Yeah, specimen, yeah.
opened
But
it.
everybody is of the opinion that you do suction.
I don't
I
think
was
it will
thinking
come in
push
the
it down.
suction.
I was thinking push it down.
Isn't it too thick for suction?
That's what I'm thinking, but everybody is damn sure that it will come in section. So I am. Kidhar hai section 2? See, Dr. Vaishali, Dr. Sushma, Gopal Ghare sir,
Yes,
Ved
Manish.
Patak sir, everyone, you have a fabulous team here, and everybody, including the sisters, staff, OT staff, anesthetists, you really have a fabulous team. So
Thank you, Manish. We are lucky, really.
yeah, and so my suggestion is, so whenever, I am not a Sadashiv Petty, but Punekar definitely. So whenever I say something good, something is coming.
Yes,
So what
in
is coming is,
exchange.
I request all of you and urge all of you to please buy a 3D system and
Yes.
start fellowship in endoscopy.
Wow.
Because it's such a fabulous place to work. I think catheter ghalwa. Catheter ghala.
Oh, yes, we had
it will
removed
be a
the
very
Foley's.
good idea to start fellowship. Foley's ghala.
Yes, that's
It
a
will-
point very seriously taken, Manish. And we seniors will definitely take it up with the
Because
authorities.
so much of yesterday, I was amazed by one of your students starting fellowships at his hospital. Why not start it here also?
Agreed. Agreed.
So that would be a very good thing to do. Okay, so she has again put the catheter. Urine coming out is absolutely clear.
So there is no
Manish,
problem with the.
just to lighten the mood, there are more Punekars sitting in the audience, so they want a pre-launch before we start the fellowship too.
No, I can, you can, if you are giving such amazing food, I can, you can utilize me for the fellowship program, no problem.
Wonderful.
Right.
Food hospitality always will be here. That's a promise without having to ask anybody in this institute.
No, no. See, you all probably know, and I always remind myself of this, that your Dr. Vaishali madam has been my on-stage Kashibai when we did Bajirao Mastani. And even today, last week's POGS webinar, Dr. Ranjana Khanna was remembering it. It has been, I think, 8 years we did it in 2016.
Right.
And everybody still remembers that. So, of course, Bajirao cannot say no to Kashibai ever. So yesterday when I came and, we
We
were.
shall encash that in this department.
Yes, surely. Uh-huh. Yeah.
Manish, another thing I'm really appreciating at this point is the way you have beautifully restored the pneumo, which can be a big concern when you do a step
Yeah.
like this.
Yes, so one of my assistant has put, he has put.
Yes, I was just going to ask, what are the things which you have done to ensure
One
that?
of my assistants, she has put the vaginal tube that we have used
Right.
for the surgery. She's put it inside.
Right.
And she's going to hold it there. That is one. Second
Yes.
is she will take a small pinch at the vulva.
Okay.
So that no air is, really no pneumo is really lost. But as you will realize, once our first 1 or 2 stitches go in place,
right,
the pneumo automatically settles down.
Correct.
So it is the first stitch, sometimes first or second suture only. कोणतरी पडलं बघ. So this can happen now. Long surgery is going on. Somebody falls down, can happen. So what do? I just take 1 or 2 figure of 8 sutures.
Yeah, like you'd correctly pointed out, we don't want to strangulate the
Absolutely
vault.
not.
We
And
just want
there is
approximation.
one more important reason is this is a open drain for us, na?
Absolutely.
तुझे catheter
Is
टाकलं
the
ना?
Foley's not in?
The urine नाही येते बाळा.
Foley's
कुठे
नाही
टाकलंय?
टाकलंय परत.
Assistant is sure that urine is coming.
Yeah, now it has. Now
But
it
at
has
times we
collapsed.
have also seen that the Foley's is put in the vagina and bulb inflated.
Then hopefully urine should not be coming.
Yeah, that is why. Oh, एक second थांब. मला bowel सोडून दिले राणी. तू bowel सोडलेले आहेत. तुला काय असं होतं रे मध्ये मध्ये तंबाखू कमी कर. हे बघ. किती छान लागतंय. Okay, so this is figure of 8 number 1.
Right.
And of course, you can take uterosacrals which can support the vault. That should also be done. So, lot of ways. Some people will take continuous interlocking. Some people will take continuous non-interlocking. Different ways of suturing. Because as I was discussing, when we open the vault in vaginal or abdominal hysterectomy,
Right.
we never use energy source. So
Right.
there the concern is hemostasis also so many times.
And here that's already achieved.
Here it's already achieved because nobody would open the vault without using any energy source in laparoscopic hysterectomy.
That's true.
Needle down.
Yes, hello.
Yes, sir, we can hear
Good
you.
afternoon, Dr.
Good
Sharma.
afternoon,
How are
sir.
you?
Yes, sir.
I
Fabulous.
thought I didn't hear your voice from morning, whether
No,
you are
sir.
not there. Now I can hear for last 1 hour you have been moderating.
Yes, I
Thank
was.
you. So we are at the end of this last case. This case had few polyps.
Right,
We
sir.
just cut one to show you all how to cut it with scissor, and it was done by your own resident.
Wonderful, sir. Thank you
So
for
here
giving
you
the
can see
opportunity.
few more polyps. And this polyps, they have grown and there is some amount of endometritis, and that's where they are almost adherent to the opposite side of the wall. So
And they
we will-
appear sessile, are they?
Pardon?
Are they sessile types, sir? That don't
Yeah,
mature?
sessile type, yes.
Yes.
There were some small polyps are here again. These are smaller polyps. So we will just, she is planned anyway for TCRE.
Yes, sir.
So just to show again, you go up to the fundus, start the current, raise your hand, and bring the whole system out in one go and come out of the tissues. So you cut a long strip, see
Yes,
from
sir.
there to here.
And we can nicely see that circular fibers which you had pointed as the landmark.
Yes, yes.
And here are the glands.
Yeah, these are the endometrial glands.
Now you go for the lateral wall.
No, posterior only, posterior but towards the left. Now this is the lateral wall. So we'll finish few more strips of this posterior wall on the right side.
Looking at your hand movements.
Yeah, so we start here. Now, up, I pull the electrode off. Now I'll put the whole resectoscope, I'll lift it, salute him.
The resectoscope view is being blocked by someone's head.
See, I'm moving this.
Yes,
Can you
sir.
see now?
Charvi's head.
Again, I'll
Yes.
just show
Thank
you
you,
how.
Charvi.
Here, start the loop, cutting. Now I don't bring it like this. The tissue will obstruct the telescope.
Right,
After I come here, I move this. See this.
Yes.
Then cutting the tissue. Now how to come out of it? At that night you'll keep on cutting. Once you're reaching almost there, so you raise your hand.
Okay. Okay.
Now you have cut it.
Yes. Deep back.
Then you have to come out, escape from the tissue. So
Any specific difficulties in the presence of such polyps when performing the TCRE?
sometimes they just obscure your vision, but then with resectoscope, you can do anything. It's like a Goliath inside. It can. This is the right lateral wall. Now push the tissue on the other side because we want to push it on the other side.
Would there be some time need to, sir, clear the debris in between and then proceed, or most of the
That
time
was
we
there in the initial days of our practice.
Right, sir.
Now then we learned that it is useless to remove the debris because by the time you go in, you have more disturbance, more blood.
Uh-huh.
So we don't do that.
Right.
Now the trick is
Push them down.
don't look at the debris, throw them away, the outside, other side. So learn that takes a little learning curve, but then you save on lot of time and lot of fluid also.
Yes, and think like Kedar, one of our speakers yesterday rightly pointed out that this is one surgery where time and speed does matter, where
See that?
patient safety is
Now when I'm
concerned.
in the anterior wall, I told you, my hand has to go down.
Yes.
If I'm in the posterior wall, my hand goes up. Now this bubble will be there in bipolar surgeries. That tissue. This is some polyp cell, so we'll just cut it off.
Looks like a real bunched up group of polyps
Yeah, yeah.
here.
Suction ka. Very close to the bubble you should go. Bas, very good. Will come anyway. See, my hand has to go down.
So now on the anterior wall.
Yeah, I'm on the anterior wall.
So the hand goes down as you had shown us earlier.
Beautiful the way you come out at the internal walls.
Yeah.
Suddenly decreases the depth.
Yes, yes. Now see, we have cut the left lateral wall also.
Yeah.
So these are some islands of endometrium which is left. We'll cut them.
Yes.
This cautery is working well. This is a key nose, no? कोणाचा आहे? अर्वे. Stores आहे का? 18 mm. Very good. This is stores 18 mm. So हे कसं चालतं? Endomat. So after you have cut the first layer, you
Yes,
just
sir.
be slow then. Don't be in a hurry to cut. You can visualize every area. See how to push the endometrium, the debris. You see, there is that endometrium here. Can you see?
Yes, sir. So one
Sometime you
more
can
question is, how does one prevent this overdo in
How much
TCRE?
prevent?
Overdo means when,
Overdoing. Yeah, you remain, as I said, you identify the muscle fiber.
yes, sir.
See, I will see here. Now I am going close to the thing. Can you see? So that is myometrium there. So now I don't need to, but in a patient with TCRE or for menorrhagia you are doing,
Yes, sir.
of course, you shouldn't perforate, but even if you overdo a little, it is okay. You should not perforate.
That precisely was the question, sir.
No, you won't perforate, no. The muscle thickness is almost 1.5 centimeter.
It's the good
You
thing
are
about
cutting at a time 4 millimeter. You will have to do it at least 4 times in that same area to perforate. Understand?
Right,
So
sir.
our hand is not going to move 4 times. See, here the understanding of the anatomy is important in hysteroscopy.
Yes, sir.
Yeah, see, to come out of it, I depress it. I go to the opposite direction. Now, when I was doing this, up and so I will now get it down. So this is almost over now. This area.
So the polyp is loosened out and just
everything, the whole endometrium is now come out, no?
right, sir.
Whole endometrium is over now. And this you have to do this way only. When you're doing on the side wall, your hand has to come from up. Don't do like this. It is more uncomfortable. Come from here. Kitna fluid gaya batao, haan? This is gland. Can you see superficial
Right,
gland?
sir.
You
Right,
can
sir.
identify the pink.
Yes.
1 liter भी नहीं गया. अरे पानी नहीं डाल रहे हो कि क्या मस्करी ऐसा कैसा होगा?
यहाँ पे सडनली आप तब कर ले.
हाँ. तो इसका पहले केस में we didn't do that vigorous TCRE, but yes, here I can show you, no? But once you are in the second time when you're doing, don't go deep.
Right, sir.
You have to be very superficial. First time I'll dig like this. Now, as you saw, I just did a very superficial and I've already reached the muscle.
Right, sir.
So as you go to the second time, you have to be very thinner slices. Yes.
So like you correctly said, knowledge of the anatomy and tissue identification probably is the
That
key.
is important. That's more relevant in hysteroscopy. See, most of us don't know what is the normal volume of uterine cavity. Most of us don't bother to find out the size of the uterine cavity. Everybody says 8 centimeter, 6 centimeter. They all what sonography has measured.
Right.
So these anatomy knowledge you have to pass on. It is only 3 centimeter from internal os to fundus. And this depth of this pushing, it is a 2.5 centimeter push from here to here, 2.5 centimeter at
So
the
we'll
internal os.
So
Yeah,
safe
maximum,
from
yes.
the fundus.
The muscle thickness at fundus is 1.5 centimeter. The muscle thickness at ostium is how much? No, at ostia is the thinnest part of the uterine cavity.
Right.
4 millimeter.
4 millimeters.
So never use resection there. Lateral wall is about a centimeter. That's all. So
तो ये हमने किया हुआ नहीं है या वैसे दिखने लगता है बाद में?
नहीं, ये किया नहीं है.
पैच रहे.
ये किया नहीं है. Can you see
ये
that?
ग्लैंड दिख रहे हैं.
So when you were doing, we thought that the
Completed. No. This is closer to the upper part of the cavity. I was showing you this.
Right.
Near the fundus, it is always a little difficult. with this loop. Monopolar loop you can bend it, whereas this you cannot bend, bipolar loop.
That's rigid.
Fair enough, I think.
So do we systematically go like say, sir, from 12 o'clock to 12 o'clock, or
Yeah,
you have a preference of posterior wall first,
yes,
something
yes.
like that?
Posterior, right lateral, then left lateral and anterior, or posterior, right lateral, anterior and left lateral. That's how I move around.
Right, sir.
Yeah. Papu. This is internal os. Can you see these are the
Yes,
fiber?
sir.
Hai na?
Yes, sir.
You have to identify between this muscular. See the anatomy. These are the mucosal folds here.
Very clearly
This is the
seen.
element. Okay, thank you.
Thank you, sir. That was again like a then that applause comes for you, sir, from the audience.
Thank you.
We are waiting to see you and hear from you in the hall now. Can
Yeah,
we?
this was the last year.
Yes, sir.
Manish also must have finished.
Can we quickly go to Manish's OT?
Yeah, please.
OT का input देंगे? Hi, Manish. We are back seeing you.
Hi. So I was just cleaning.
Right.
Jhadu Pocha Vibhag.
Has done an excellent job.
Okay, so ureter now.
Yes.
Yeah, पहले ओवम से निकालता हूँ. पकड़ लो. Of course, the teaching is even this should not be done blindly. You can perforate now with the ovum first. So this also you remove it under vision with the loop every time coming out. पकड़ो उसको लेके आओ. पकड़ो लेके आओ. But we all are little lazy. थोड़ा time लगता है ना.
Done. Just.
Yes, Manish, I think.
This is one. Can you
We
see? I can see.
Yes, of course, we all can see.
See the peristalsis now?
Yes, lovely.
Yeah. Okay. So this side we are good. No problem at all. Maybe next time when we operate, I'll actually show you lateral pelvic wall dissection. So that would be good.
Yes.
This case we didn't do because there was no place only. We would have really wasted a lot of time unnecessarily.
One should not do things just for the sake
Yeah,
of doing.
I also believe in that.
I think I can already see the
Yeah,
peristalsis.
you can see the ureter here.
Yes.
So
Very
that's
nice.
Mari. Okay, ball. Doesn't seem to be any active bleeding here. Ma'am, एक pause दे दो. 1 gram pause दे दो. I forgot to tell, we generally take pause 1 gram. It prevents.
Is it routine for you also?
All right.
Manish, do you routinely do that for all your TLH?
Yes. We do it for all our cases. So that little, what we call in Marathi, bhus, that bhus is not there. But we are good. See, our both uterines are good. Your returning fluid is good here. Nothing is filling from any side.
पाणी स्वच्छ आहे असं कमेंट आलंय तुझ्यासाठी.
चला चूळ भरून जेवायला बसू. Chalo, thank you so much. I'll just close that.
Wonderful, Manish. Great job. Wonderful surgery. Lots of learning.
All of you.
We are waiting to see you here.
You have been here with me for such a long time on empty stomach. So let us eat now. हे हेडलो सरळ करून टाकला. इथे मला हे लागेल. वायक्रीन लागेल. वरचे हो काढून वरचा लाईट लाव आणि एलिस दे. एक मला मॉप पण दे. So thank you, anesthetist madam, everybody. Thank you everybody from OT. Fantastic, too good. Only because of your cooperation we could finish this case. Huh?
Yes, team anesthesia really needs to be appreciated.
Yes.
With so much of manipulation.
इनका anesthesia का डब्बा खा के तो हम बड़े हुए.
Agreed.
इनका डब्बा चोरी होता था तो हम लोग खाते थे, मेरे को बोलने में कुछ शर्म नहीं आती. हम एडिस लागेल बा. हाँ, ये लो. घर वा. ये लो. त्याच वापर कशाला खराब कर. एक फोरसेप पण नाही. असं वरती ओढणे. हा ठीक आहे. बस झाली. इथे 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 बघा. ते सोडून दे ना, त्याच्याकडे देऊन टाक ना मला. सोडून दे ना, थोड्या वेळाने काढेल. यप.
Sir has left from the OT, will be with us shortly in 5 minutes now. Let's welcome sir with a big round of applause for his commendable job. We really enjoyed all the OTs, sir, because of you today.
Hello. Yeah, yeah. So, yeah, everything.
Everyone, please settle down. Please join me in welcoming Dr. Vaishali Kode, ma'am, Professor and Head of Department Obstetrics and Gynecology, and Dr. Sushma Sharma, ma'am, Professor and Unit Head Obstetrics and Gynecology. Can we have a huge round of applause, please?
So even though it's end of our session, but we are coming to the most interesting part of our this 2 days conference, and that is to hear from our beloved S. Krishna Kumar sir. We are all eager to hear to sir, even though he is talking to us since morning. And I request Sushma madam to please introduce our sir. He's known to every one of us, but still he needs a formal introduction.
Okay, good evening, all. Very warm welcome, sir, to this hall, if I may say so. Now, I think it would take the rest of the evening to introduce you, but I'll just introduce you very briefly for everybody to know. So,
They've already read it, he says. Well, I would summarize it to say that he is a person who is known for his hysteroscopy skills, and moreover, the way he teaches the hysteroscopy skills, not just in the city of Bombay, not just in the state of Maharashtra, but not just in this country, but I would want to say for most of Asia and to many other countries beyond Asia also. I think that is how I would look upon sir, and there is lots and lots of life lessons to learn from him as well. So I think since you say people must have read you, this mic is all yours, sir. We're all eager to hear from you.
Thank you for having me here. As I said, it's like an annual pilgrimage for me here. For the last 4 years, continuously I've been coming, and I enjoy always coming here because definitely the hospitality, the love inside it, and the learning of hysteroscopy, I see that they are definitely interested in learning, and that's where it makes me keep coming here. And of course, you have seen the morning only I said about hysteroscopy, no gynecologist can avoid. And today we cannot call ourselves gynecologists if we don't know hysteroscopy. It is as simple as it is, because that is the only surgery gynecologists can do. Rest, anybody can do. I don't elaborate on that. So it is totally in the domain. So any woman comes to you, you can't tell that I can't enter your uterus and create it or clear it. I'll have to do a blind procedure. No, those days are gone. But the innovation and the improvements have happened so much that everybody will wonder how can we buy every instrument and where to use what is the topic about today. Choosing the right tool in operative hysteroscopy, because we have some great armamentarium in our hand, but if you don't use it rightly, but there is no financial conflict, it is all my purely personal opinion, and in a country with low resources, we have to modify. Now, as I said in the morning itself, hysteroscopic surgery is something unique. It is within a very small cavity, and you can have only one hand. No other field of medicine, people operate with one hand. They always have two hands. At least even if you're operating single, you have something to retract, something to cut, something to catch. In laparoscopy, it has now become multiple hand. Previously, it was only 2 or 4 hands. Now it can have 6 hands inside. So that is where the fundamental principle of surgery is different. So that is where limitations come, complications occur, and that's where we have to master it and overcome it. Now, that's all my talk is about today. When we started hysteroscopic surgery more than 2 decades back, this wonderful instrument was for everything. The resectoscope was for everything. We had septum, polyp, everything we would dilate and go into the uterus and do with that 9mm resectoscope. Those days it was monopolar. But the same problem continued. D&C, the blind procedure, we would land up with false passage, perforation, blood, debris, poor vision, and women today are living longer. We get women at 75, 80 with their own gynecological problem. They feel that menopause ho gaya, so I won't have any gynec issues, but they'll end up with different problems. And a menopausal uterus is absolutely a nightmare to enter. Because of the atrophy, because of the changes, you can't hold the cervix. So you have to have answer for that. So you didn't want to continue with that 9mm telescope or resectoscope. And this paper published in 2018 reported a high incidence of Asherman after hysteroscopic surgery. A blind D&C procedure which has been told that almost 19% chance of adhesions. Today we thought under vision we will have less, but then myomectomy, you can see 45% incidence of adhesions. So why it is? Is it because of not choosing the right tool? Choosing the wrong things? Asherman is increasing. Why should it increase? Well, cold surgery was electrosurgery. Now there are enough papers. As I said, initially we were using resectoscope, but this publication published by the Chinese group clearly said that patients who were using mechanical morcellators where energy was not used did better. There are less adhesions, less complications. And for Ashermans, where the endometrium is totally gone. Like today morning, we did see Asherman. We were lucky that we could see some anatomy, but you saw the endometrium was so poorly damaged. And there, if you use energy, you're going to further cause more thermal damage. So this particular paper clearly states that hysteroscopic seizures, the return to menstruation and the flow of menstruation was much better when you use only Caesar. And also you can see that I showed you in the morning, you can enter under vision, you can cut everything under vision. You don't damage anything with the 2 millimeter Caesars. Even if you perforate, you're not going to do anything, you're just going to abandon the procedure. But with that resectoscope, if I perforate and I put my energy, I'll have to open up the patient would land up with bowel problems and so many other things. And of course, the rise of ambulatory hysteroscopy is something which has come great way. In our country, it is slow to catch up, but it has been proved by enough study for the last 2 decades. The satisfaction rate of hysteroscopy without anesthesia, everybody is happy. In European country, American country, they all do that because of various reasons. In India, it is a little difficult, but still many of us have started doing ambulatory hysteroscopy. And again, ambulatory hysteroscopy is possible only if you have learned the mastering the newer technique like what you saw. If a patient is under without anesthesia, if you try to put in a speculum, that itself the patient say, Valsalam, she will say shout. So you can't have all that. So here, how to enter, you have to learn. So how to use that miniaturized hysteroscopic instrument, you have to learn. And myomectomy, there was no case of myomectomy, but traditionally, you all must have seen open myomectomy. Nobody slices the myoma. Everybody enucleates it, whether you by laparotomy or by laparoscopy, we enucleate. There is hardly any bleeding, but hysteroscopy, that enucleation was not possible. Everybody had to use the resectoscope and we started slicing it. So the myomectomy hysteroscopy is not myomectomy, it is hysteroscopic slicing. So now people have realized that that may be the reason for adhesion. So you have to change the way you do myomectomy hysteroscopically, which is such a common problem in young women, in patients who have heavy menstrual bleeding, patients who are for reproductive age group. You can't have adhesions in them. So you definitely need to do some other technique where you will do the same step which you would have done by open or by laparoscopy. So the concept, the pseudo capsule, is something which we know that the surrounding vessels, nerves are important for the healing of the tissue and for definitely better implantation at a later age. So, but then suddenly resectoscope, whether one should stop using. There were very many publications about 3 years back where end of resectoscopic surgery because newer devices have come up like the HTRS or the hysteroscopic tissue retrieval system. But yes, why the reason? There were nobody to teach resectoscopic surgery. Today, everybody was wondering how to take out those nice strips. It is just a simple learning. But then if you don't use that energy properly, you're landing up with problem, perforation, damage. So long learning curve, chances of intravasation is much more, perforation, lack of visualization because of the debris floating, and more dilatation is required. Whereas all these HTRS, no current, less chances of perforation, may be faster because it sucks the tissue. At the same time, it resects. And where you could see the debris floating inside, and only those who are mastered it can. But still, resectoscope is going to remain a mighty tool. That's where I'll tell you why. Now, small has always been beautiful. So this resectoscope has made a big difference. You could see today we were using some of the smaller resectoscope. The smallest one is 5.5 millimeter. So today we were using 6.5, 18 French. We could enter any uterus much more easily. Now this 15 French, even in these women postmenopausal at 75, where the os is so tight, patients, young girls come with gynecological problems. They have polyps, fibroids, so many other things, and we don't want their hymen also to be touched. So these miniaturized resectoscope are wonders in those. And you can see this in a postmenopausal lady. If you have to enter after dilatation, see without dilatation how beautiful you can see. You can see the pathology very clear. You can identify it very clear. Just by the gross identification, you can say that this is definitely not malignancy. These are all mucoidal polyps. Though hypervascularity is there, But then these broad polyps, again, very difficult to cut with scissors only because the base is so broad and you need a resectoscope, but you don't want to dilate. So you don't use the 9 millimeter, but you have the 5.5 millimeter going in beautifully and the same energy, the same power, and you finish the job absolutely to satisfaction within that limited time. So this is the beauty of these innovations which have come. Well, newer problems are coming up. Today we know that cesarean scar pregnancies are seen 10 years back, 15 years back. I don't think I have ever operated, but these days we are getting it at least once in a month or 2 months. Isthmocele, something which we never thought what is isthmocele. So we have cesarean scar niche, some new terminology, some very disease of the modern, problems which women are still facing. We thought endometriosis is the only sticky disease which keeps on sticking with them, but niche is going to create problems. So this is again something. I wouldn't go into the reasons why cesarean scar niche is coming now, which was not there 20 years back, but we as gynecologists have to give them remedy. But remember, go totally visual. Whether you want to do a termination of pregnancy, you don't have to do blind MTP today. You give misoprostol, mifepristone, misoprostol. If there are RPOCs, you do it under vision, and there you can see a patient with a septate uterus coming for the fourth time missed abortion. And you can see how beautifully you can enter exactly to the horn where the pregnancy is. Otherwise, blind DNC, we would, it is here or it is here. And then you would curate both the uterus and you will cause more damage. But here, you can use that HTRSC on that left side, how beautifully you can see the blighted ovum sac and remove under vision. You suck out the contents and no need of curettage. You don't have to put in the sharp curette at all. So not only does that cavity remain healthy, the other cavity is not touched. Even women with hyperplasia, today the concept is not teleciphy, under vision, visualization, under vision. So this is the beauty of hysteroscopy. So why we gynecologists continue to do that blind procedure for everything and anything even today. So this is how these tissues can be all collected and sent for histopathology. Here you have the STRS working. You have seen that the whole cavity is now empty. So this is the right tool. Of course, in maybe women who are of reproductive age group who was interested in conception further, we need to use under hysteroscopic guidance everything and not do anything blindly. Well, which to choose? So many innovations. How can I afford or what to buy? So deciding factors are whether you're doing it in operation theater or you're doing it in ambulatory, whether you're doing it in a patient who is interested in fertility or a patient who is not interested or just coming for severe menorrhagia or abnormal uterine bleeding. You should know the anatomical changes. Young girls, elderly, very elderly women, beyond 70, parity, congenital uterine anomalies, and of course, availability of what you have. Definitely that will. But the principle is always one, which I've been hammering from morning: no dilatation of cervix. Avoid blind dilatation at any stage. Dilate under vision with your grasper, with the telescope. Minimize damage to the endometrium or avoid absolutely no damage. And of course, we have to be very sure that in one sitting, we will try and finish off. But we are lucky in some way. Hysteroscopic surgery is one surgery where you may not do it in one way. It is not possible in one sitting. You have always another day. So maybe God has thought that this is a very difficult surgery. You have only one and let them give a chance twice. So you can do a surgery today, half of the fibroid I remove. I'll say you're gone into fluid overload. I can't push you into ICU. I'll do it after 1 week. So that option is there. And of course, that's where minimize the fluid overload and avoid adhesions, because adhesions is caused totally by gynecologists accepting tuberculosis. My philosophy that I already said, hysteroscopic surgery is restricted by space. Duration of surgery is always within 20 and 30 minutes, and reduce the reproductive plans of the patient will have to be kept in mind. And one technique does not provide solution for all pathologies. That's why you need to have 2 or 3 gadgets with you, and you must be ready to adapt to all those and use it, and then reason it out why you're using it. So this is what Now, if you look at the intrauterine pathologies which we get, tissues which are just to be cut, there is no retrieval, adhesions, septum, T-shaped uterus, you just have to incise, you don't have to bring out anything. So there, try to use scissors. If at all you want, you saw that small needle also, which I showed you today morning, and adhesions, always scissors only. If you're doing a septum or a dysmorphic uterus, you use scissors. If not possible, use a very thin needle or miniature resectoscope. Again, don't dilate. You can use that mini resectoscope or you can do it with that needle also. So you can see, start off with the scissors always. Any large septum can be started off with scissors. If at all you need energy, you go to these needles which are available. You can cut it with the scissor knife if you want to. And this is a Robert's uterus, a complete septum where it is from the external os to the internal os. You can't see. You enter from one side of the cavity. Here you will have to use a Collins knife because you can't do it with scissors. Perforate the uterus septum on the other side and enter the cavity. So you just perforate it, and then of course it's a very child's play. Once you have done it, the end point, I won't think I need to explain to you. Morning we were speaking, the tubal ostia has to be always a little above the septum, but this is how a lesion or a pathology where you don't have to remove, you will do it. Well, T-shaped uterus, I showed you lateral metroplasty, how to do with scissors. Fix the arm, the fixed arm into the lateral wall and then move the scissors. You should have a very thin pointed sharp scissors. If at all you want to use a mini resectoscope, not a bigger resectoscope, because if you dilate, the lateral wall again goes out. So you need to do without dilatation. There are definite classification and identification of T-shaped uterus. All those 3 QM criteria has to be met before you think the patient needs lateral metroplasty. A 3D sonography is advised if you think you're doing a lateral metroplasty, not any cavity which is looking narrow, because the lateral wall muscle, as I was telling in the morning, afternoon, it's just about 1.2 centimeter. So if you incise more, you may see the uterine artery from the hysteroscope. So be sure what is the exact thickness and then cut. See, with the scissors also you can cut it so beautifully. You can see the upper video there. We have cut so much of the myometrium, and these myometrium are stronger. They are concentrically hypertrophied. That's why there is T-shaped repeat. If you can't, then you can use this Collins knife. Again, use it only at the tip. Don't dig the whole length of the tip, which is 4 millimeter, into the myometrium and try to cut. It may cut more than what you see. So you will make it thinner. So you definitely have to be very sure that you just cut by strip with the tip and gradually progress. So this is the lateral metroplasty still being done with the scissors as far as you are, till you start to seeing the ostia standing at the internal os and the lateral wall is just inside the tubal ostia. Pathologies which require lysis at the endometrium or resection into the endometrium only. Polyps, retained products of conception, type 0 myomas, and cesarean scar pregnancy, because here you are not going to touch the myometrium. We are just at the level of endometrium. So what are the things? So here, scissors, graspers, tenaculum. These are the basic instruments you should have. You will have bipolar without dilatation, that is the mini, and of course, tissue reshavers are very useful for RPOC, cesarean scar pregnancy, or type O myomas. One of the two, if it is available, it will make your job easier in difficult situation. Every myoma may not be able to be enucleated or cut with the scissors, but if you have a type 0 myoma, you can cut the pedicle and leave it. You don't have to sit and resect it. The myoma will automatically shrink, fall off in a couple of weeks. So you don't have to sit and resect. You just have to cut the scissors with the scissors. Now this is how a polyp is cut. If single polyp where you can see the pedicle is very narrow, pedunculated polyp. So this can be cut with scissors very easily. Whereas the polyp, which is much more broader, much more bigger, is very difficult to work with scissors. So you need to have either a tissue retrieval system or you need to have a resectoscope. So I would prefer a mini resectoscope if the patient is not for reproductive age group, but if it would be there, if it is HTRS is there in a patient with reproductive age group, try to use that. Otherwise, see, with that polyp, again, you try to remove with the grasper, but putting the blind grasper is also not good. So under vision, if you can put in a pan-shaped grasper and then put all the polyp, pull out the polyp, it is better. And these are again needles which you saw if you have in patients with patient who require reproductive, you may avoid, but you can use the needle. But for others, these resectoscopes, so such large polyps are very difficult to remove with scissors. And multiple polyps may be there. And as I said, the working time should be not more than 20 minutes. Whereas type O myomas, HTRS works wonderful. It doesn't allow the debris to come into your vision and spoil your vision, and that's why it's supposed to be faster, because the debris are sucked at the same time. But it has its own limitation. It very hard, dense fibroid, it is difficult to cut. And if it's a type 2 myoma, it is impossible to do with this. Again, you require a resectoscope. But type O myomas, HTRS is wonderful. Sometimes in ambulatory, what they do is just cut the base and leave it. They don't waste time. And there are enough papers to tell us that you can leave it and it falls off. Only you have to monitor. But maybe our Indian patients may not pay you. They said, you didn't remove my tissue, so why should I pay you? So we will end up doing everything just for the particular purpose, because they are very difficult to explain to them. Whereas there are no choices. It is all managed by the insurance. So they have to agree to go to a particular center. They can't sit and fight for everything there. Well, cesarean scar pregnancy, again, there are enough papers to tell that if cesarean scar pregnancy are of 3 grades, 1 and 2, which are picked up much earlier before the serosa is perforated. You pick up late, it comes superficial. Then you have to do it by laparoscopy. Otherwise, HTRS works wonder. You can just go in under vision, and with that HTRS, you can just suck it under vision, and results have been good. So cesarean scar pregnancy these days, all these ectopic we pick up early. We don't get patients at in shock with hemorrhage and hemoglobin of 4 and 5, because we do sonography. Patient comes to us early and we pick up early, and you can see how HTRS works. You can just put it under vision, suck it. If at all you're not confident and you want to make sure, you can put in a laparoscope and at least see in your initial days. But later on, we would say that it is not required. But most of us, initially, even I was doing, but today we don't use laparoscope at all for these cases. We do it under hysteroscope, and we are very happy. So here, a blind curettage, again, one is not sure whether you're going to perforate the membrane or the thin out area. So definitely under vision, maybe HTRS is wonderful. You can see the laparoscope view. You can see the light of the hysteroscope. It is a thin area, but if the patient is not interested in future pregnancy, this is the right way to do. Well, pathology is where you have to enter into the myometrium. Type 1, 2, 3 myomas, adenomyomas, isthmocele, where the myoma has to be cut. Endometrium doesn't have nerve supply. So all those other pathology we show can be still managed in ambulatory setting if the patient is ready and you have all the gadgets and you are mentally prepared. Otherwise, these cases require usually OR and anesthesia, because you are going to touch most of the myometrium. And there are, of course, various other methods available to reduce the pain even in ambulatory setting. So you require a combination of all these hand instruments, and definitely bipolar energy, the loop is the best. STRS has much less role in these conditions. So these large fibroids, LASMAR 8, will never be possible to be managed by HTRS. Such large fibroid in the lateral wall, which is very difficult, you need a resectoscope. And even to cut this with scissors and enucleate them will be difficult. Either you go by laparoscopy and cut the whole myometrium and remove it from above. If you want to do by hysteroscope, definitely the 9 millimeter resectoscope is the best, because it is faster, quicker, the time spent is less. There you can see how beautifully you can visualize the fibroid which is cut and the circular normal fibers which are seen there, and that is part of the fibroid capsule still left. So for these cases, you definitely need a resectoscope, preferably 9 millimeter for such large fibroids. Otherwise, the use of this 9 millimeter resectoscope is much less. Today, we didn't use even once, but if a fibroid of this size is there, I would prefer 9 millimeter. You can see the normal musculature in the lower half, and you keep cutting it. Use the resectoscope. It is a versatile instrument, but always remember, keep a watch on the fluid overload. And if there is difficulty, always do a second sitting. And today, no monopolar, no glycine. It has to be bipolar and saline. I wouldn't go into the details of why no monopolar, but definitely today, hysteroscopic surgery, if energy is used, it is bipolar and saline. Well, type 3 myomas are something which is again becoming a challenge here. Type 3 myomas mean which is not even projecting into the submucous element. And there are papers which tell that infertile patient type 3 myomas, we all thought that it may not be removed. They say implantation is poor. They also behave like type 2 myomas. So you need to identify the fibroid. Your, of course, sonography mapping will tell you exactly where the fibroid is. And here you can't use the resectoscope to search the myoma. You're going to damage so much of the endometrium. So you need to learn to do with the scissors, identify the fibroid and separate it from the surrounding capsule with that thinner scissor itself. Now, of course, the HTRS systems allows 3 and 4 millimeter graspers and scissors to be allowed. So you need to buy that if you want, because the 3-4 millimeter will make it much easier than this small 2 millimeter scissor. Here you can see we have identified the fibroid and we are trying to go around the fibroid, cutting the fibers, separating it. Either you use a scissor or use a grasper to break those fibers. They're easy to break, but then it's just a matter of learning. So we are now learning how to do these type 3 myomas with those smaller, thinner grasper. You can see a type 2 myoma can be converted into a type O by cutting around the endometrium with the scissors. So this is how you learn. Cut in those simple cases. Push the fibroid. You can see the pseudocapsule there. Vascularity is well maintained. So definitely the argument that this will cause less adhesion stands where you don't use energy. So then you move on to type 3 myomas, and that's how you progress. And you can see how we push the fibroid totally down. Either you can leave it or you can do it with STRS and cut it. If it is possible, you may hold it with a grasper, but you need to have less than 1 centimeter fibroid for it to come out through the internal os, even if you have a very stout grasper. This is how type 2, type 3 myomas, which are now a challenge, is being managed. You can see the fibroid there, which was not seen at all. We have almost brought it to the cavity. Well, myoma enucleation is also possible with that mini resectoscope. There are different electrodes available where no energy is used. They are very tough. After incising the endometrium, this mini resectoscope goes into the plane between the capsule and the fibroid, and see how it is pushing the capsule, and the fibers are being broken and the fibroid is being pushed into the uterine cavity. So this is how the inventor of the mini resectoscope, Dr. Gubini, showed me, trained me. I am trying to learn it with this. We have bought this new, but it takes time. It's not very simple to learn. It's within one hand we are trying to do. These are all hardly 3 millimeter instruments, and you're trying to, we can't afford if there is a lot of breakages. We are all working in limited resources. So if one instrument breaks, we will think for another 1 year to buy it or not. Not that every instrument we get it disposable, because insurance doesn't pay all these instruments here. Well, isthmocele is something which you'll have to see more and more to really know what is isthmocele. Isthmocele is nothing but a defect which is there. This is the uterine cavity and this is the pouch where the previous scar is. So this has got 2 edges, the cephalic and the caudal, and the blood gets accumulated here and causes postmenstrual spotting, and that causes even infertility problems. So here you can see the mini resectoscope has to be used. You can't use the conventional resectoscope. You cut this caudal edge and make it flat and in line with the upper part of the cavity. But of course, the residual myometrial thickness is important. It has to be greater than 3 millimeter. Otherwise, you will look into the bladder mucosa very soon. So you need to be very sure that you've taken the measurement properly, and you see how small slices. Here you can't dig that 4 millimeter, which I was trying to tell you the trick. Push it inside and pull it at one side. No, just millimeter by millimeter. See, the movement is so superficial, and you need to do at least 180 degree from one side to the other side But there are cases where even the posterior wall seems to be fibrotic, maybe because of the chronic inflammation, and you need to do a 360-degree correction. So this is how the caudal edge you cut, and if you think it is flat, no, otherwise you cut the cephalic ridge also. So those fibrotic layers have to be just cut very, very superficially. Here you can see the upper part of the cavity is now coming in line with the lower part of the cavity. So under vision, without dilatation, the mini resectoscope is the answer, and not dilatation and the 26 French resectoscope. Adolescents preserving the hymenal integrity. Many of young girls come with leukorrhea. 18-year-old, 20-year-old, the mummy comes back. Medicine says rukta hi nahi hai, but definitely they have ectropion. So you convince them to undergo this procedure in OPD in presence of a mother, and you can see that ectropion, and in the OPD you can cauterize that. So this is another girl, hardly 24, having heavy menstrual bleeding. There was a cervical polyp. A polyp in the canal, again a mini resectoscope, absolutely smoothly entering without disturbing the vaginal hymen. You enter and you can see the fibroid polyp there. That is where these mini HRIT instruments have come to our use, and you don't have to put in a speculum, don't have to dilate, because even you would feel guilty if you have to dilate in that young girl. But then we had no answer a couple of years back, but today we have answers for all these pathologies, all these problems. You can see the fibroid polyp, how cleanly it can be seen, and then the resectoscope will do the same job of just slicing as you saw today morning. So this is where preserving the integrity is important. And last, I'll come almost to the close of my thing. We have to change our attitude. D and C is dangerous and contraindicated. It is no more dilatation and curettage. Even if you don't have this HTRS, you have hysteroscope. So from tomorrow, Weimar College will not allow blind DNC for a RPOC. We'll see where the RPOC is. Usually it will be in one corner. It will not be occupying the whole of the cavity. It may be in one corner, right ostia, left ostia. You locate that and then put your ovum forceps and remove it. Otherwise, take this grasper or take with scissor, they will be cut easily and let it fall, and then remove it the way we are removing if you don't have HTRS. So DNC is contraindicated in patients who are for reproductive or not, or interested in future conception. So we as gynecologists should not be using D and C at all in our day-to-day practice. So hysteroscopic surgery the world over has moved over. As we started with the resectoscope, the gray which you are seeing, but today the resectoscope usage is hardly minimal. The miniature resectoscope, the HTRS are being used more because of so many advantages. Of course, they all do ambulatory hysteroscopy a lot. In our country, we are not, but then at least apply those principles, even if you're doing it in OR. That should be the message. So to be a part of true evolution, we must not only accomplish new things, we must foresee, but also act to be, and we must not only plan, but must believe that we can do it. If you believe it, you will plan and you will act upon it. Thank you for your patience. This is how endoscopy, hysteroscopy has progressed from absolute this. Now you're marching ahead like a true man. Thank you.
Thank you so much, sir. And I think we all have to give standing ovation to sir for the excellent surgeries which sir has shown since morning, and for this deliberation. So your passion about hysteroscopy is amazing. You have made it a specialty, sir. Hysteroscopy, you have really made it a separate.
It is there. It is
Yes.
for us to adapt.
Yes, for us to adopt. And even like place like Weimar is learning bit by bit with your encouragement every time. And we are so grateful to you. So you have not just simplified the hysteroscopy, but you are standardizing it. And your small messages, like from holding the instrument, the water has to come from above, the sun rises from below. All these small tips, they echo in our ears till you come next year. And we are so grateful for such such beautiful deliberation and such beautiful demonstration of surgeries. And you are a guide to us, and we really thank you. And we look forward to have you again and again.
Thank you for all that appreciation. But as you said today, that your residents no more use the dilator for hysteroscopy. That itself said me that yes, something
Yes,
is
sir. We
at
are
least
not
being done by me.
Yes.
Yeah, thank
Sir,
you.
by this year, we are not using dilators. Next year, we will not have blind DNCs, and we will also only have a look, and then we will take out the RPOCs. And this is how. Histromat is also going to come, sir. This man. So Histeroman is a good, what to say, sir's nickname now. Sir is a Histeroman, and a big round of applause for sir.
May I request Dr. Vaishali to please do the honor of felicitating Dr. Krishna Kumar, sir?
If delegates have any questions, sir is there. Please don't miss this chance of having it from the stalwart. So if you have, yeah, smallest of question, you can please go ahead. Dr. Manish.
Yeah, Dr. Vaishali has not had food. That is my concern.
Good afternoon, sir. So I'm a resident over here. So, like after seeing such workshops, we are very interested into going ahead with fellowships in this branch. What tips, like how do we start into this field of what to, like where to go, where to do fellowship, how to go about and how to train ourselves? Because you made it look so easy, but we couldn't even handle, we couldn't even like hold to like coordinate the two hands. Yesterday we tried it on Histro trainer and it was very difficult to even coordinate the two hands. So how do you like reach this level?
First, you have to get motivated. If I can do it, you should be able to do it. Because nobody has taught us intrauterine. That is, I didn't learn hysteroscopy when I was born. So when I saw Professor Betoki or somebody, when we saw Professor Betoki doing without dilator, I called him, he's a fool. He's wasting so much saline because the whole OT was flooded. Because the fluid was coming out. I said, but then I could see that there is some meaning into it. So you have to understand that that's definitely not get motivated, believe that that is the right way. And then now today we don't waste hardly more than 10 ml saline into the vagina or outside. We can do it. So first is believe it, then act on it. If you say, I can't do it and you sit on it, it is not possible. You pick up the scope, you learn the right steps, you learn the right technique of doing hysteroscopy or laparoscopy, learn the right way of putting the trocar, then the job is simple. After going inside, it is just a regular surgery. It is not different surgery, the same steps, but you are using different ergonomics. So of course, practice. You have to practice. And then where to go? As you said today, the teaching and learning has become very, very simple. We have so many way of social this and that, but attend to conferences, write the learn way, and select where you want to go. And what you, after 10 years, where you want to be today, if I can fix that, no, I have to be like this and I have to go here. So you will start that step. So you will go to tomorrow, you want to become a great laparoscopic surgeon, Manish is just next door. So you will take his advice and you will observe him, first observe them, right steps, get the best gadgets. Don't waste money in gadgets which are not going to help you. So you have to buy the best instrument because ultimately you are going to enjoy it. It's for you, it's not for somebody. Then you will be on the right track.
So you are definitely an inspiration for all of us.
Okay, so good you asked this question. Today I remember one of my teachers, Dr. Bhalerao sir, Anand Bhalerao from BJ. And he used to tell us something which is useful for you, useful for me, everybody. And we used to ask him, and we used to be mesmerized by his surgery, bloodless surgeries, sir, he kasa jamna. So he used to say there are various steps of learning a surgery. Step number one is observe. That is something where residents are lacking. Something is going on in the OT, somebody is operating, what you all do? You sit outside and you play in the mobile, or you have a cup of coffee, you chit chat. Don't do that. Observe. If you observe correctly, that's step number one. Step number two is assist. So when you assist, you learn. Step number three is you do it yourself. Step number four is assist a junior. That is also learning. When you assist somebody else who's making mistakes, you know how to manage those mistakes. Step number five is learn to manage your complications. And step number six is learn to manage complications of others. So these are various steps of learning. Learning never stops. It just never stops. So I'll just give you one example how learning never stops. When I was a lecturer in Sassoon, I was assisting a very famous gynecologist now from Pune and into the government service, vaginal hysterectomy, right? Third degree prolapse, vaginal hysterectomy, not difficult. I said, okay, you do. And what she did was exactly what I did today in OT. She cut the cervix. Now there is nothing to push the bladder on. Cervix hath mein. I have never heard of this complication. I was lecturer in Sassoon. I had never heard, never, understood if cervix comes in your hand and you have to do a vaginal, how to push the bladder up now. So then I learned. So as a JR, she taught a lecturer how to manage it. So I learned something new. Moral of the story, learning never stops. Right?
Thank you, sir. Thank you so much.
Thank you so much. So
victory. Okay, so this seems to never end. And just a small formal glitch. Let's start with our valedictory function. And I request all the dignitaries to please proceed on the dais. Our chief guest, Dr. Krishna Kumar, sir. I welcome sir on stage. Please welcome him with a huge round of applause. It's now also time to call upon Dr. Manish Machwe, our real favorite Puneite endoscopic surgeon. I welcome him on stage. Our dear principal ma'am, Dr. Sandhya Kulkarni, please welcome with a huge round of applause. Head of Department of Obstetrics and Gynecology, Dr. Vaishali Korde ma'am. Our medical superintendent, Dr. Darpan Mahesh Gauri sir, please welcome on stage. Audience, please give a huge round of applause. Let's tell everyone that we are not sleeping. Okay, I welcome on stage Vaishali ma'am, our head of department, organizing chairperson, Dr. Sushma Sharma ma'am, and our very own organizing secretary, Dr. Jaya Barla. Please welcome on stage. Embarking on this journey of skill enhancement in the field of endoscopy. Okay, and so we have one more member in the team, organizing chairperson, Dr. Dattatreya Gopal Ghere sir. Please welcome on stage with a huge round of applause. So this journey, you can see the whole team, lot of backside team. So I welcome all on stage, and alone we couldn't do this. We had to go together, and making each day count. A great masterclass has come up. As sir rightly said, that if you want to embark on something really new, you have to walk on that path first and believe in it. So we all believe in it. And it's now time to call our organizing chairperson, Dr. Sushma Sharma ma'am, to give the welcome address.
Thank you, Priya. It's more like a due time rather than welcome. So with a sense of deep satisfaction. I stand here in front of you, dear dais, so respected dignitaries on the dais. People, thank you for waiting. And that speaks of volumes about the workshop in itself, that people wait beyond the stipulated time and even for something like a valedictory function. Such is the eagerness to listen to people like you, Manish. And it has been a treat, these 2 days of workshop. Like Priya rightly said, months, not just weeks of planning has gone behind this. And it's the whole huge team behind it which has made it successful. And yesterday we had a lot of informative and high quality talks by great stalwarts. We had Dr. Mahendra Borse sir, who was here to give us insights into myomectomy. We had Dr. Kundan Ingle, we had Dr. Manish Machwe, we had Dr. Ashish Kare, and very proud, sir. And I really appreciate the thought of Team OBGY led by Dr. Vaishali Kode to make our own alumnus part of this workshop. Since a couple of years, we had very proudly called Dr. Rohan Krishna Kumar last year. And so this year, I'm sure you met Dr. Swapnil in the OT. So he was part of the workshop. He did present a small talk yesterday, and we are all very proud in this department to see our own PGs grow. So I think the whole team will be very satisfied, and not just satisfied, satisfaction makes you complacent. We will not rest on what we see as little bit of laurels, but we also stand here motivated to do more and better from next year and a little bit better the year after, thanks to people like you who motivate us, who are kind of our heroes, if I may say so. So we really look forward to having you and people like you and learning more and more and organizing more such. I think, and my talk over here saying that we promise more and better year after year after year from Team OBGY at Mahindra Medical College. Thank you.
So this workshop has also given us some credits. We got 4 MMC credit points, and our MMC observer, Dr. Dada. Because of stalwarts, we are very lucky to get all the training, all the skill enhancement. A stalwart, a surgeon par excellence, I would say, and an amazing teacher as well, with very beautiful oratory skills. Our dear chief guest, Dr. Krishna Kumar sir, I welcome you here on the podium to give us a few more words before you leave. It will always be less, sir.
No, first of all, respected principal and all of the dignitaries from Mahindra Medical College, it's been a real pleasure always for me. And as I said, this is like an annual pilgrimage. This is the 4th time I'm coming. And for that, the simple reason for coming is, of course, I love teaching. And just as Manish said, you learn if you teach. If you don't teach, you remain dormant. Because you need to correct the complication, you need to answer few things which you might be put into. So unless you teach, you're not going to learn. So if you have to teach, you will come educated and learn. So that is where we have learned that last 2 decades that teaching has made me where I am. And when I find an institute like this, where they want to teach not only their postgraduates, the undergraduates, and their own teaching staff, the passion grows. Because those who are in practice, they all refuse to change because they are used to it and they say, "Ki chal raha hai to chalne do, abhi kidhar, why will I sit?" But when I see youngsters, they can be molded, they can be motivated. So that makes me more motivated that definitely this is the target audience who will listen to you and come into the right pathway. So that keeps me motivating and keeping me coming here. So I must thank you all for calling me every time. And of course, I'll keep coming here. If you don't call also, maybe I'll come as a delegate and learn something. So this year, of course, you have added a flyer of laparoscopy also with some stalwarts, and definitely it was, I think, definitely more needed, and we have benefited from it. And I once again congratulate every one of you who were in the team to organize this event, because organizing a masterclass or organizing workshops, live surgery workshop is difficult. You need to have look into so many aspects, and everything has to go smooth. But then if the organization is fantastic, the whole workshop runs smooth without complication, right from selection of patient, the instrumentation, the companies participating, all that is being taken care, and you are progressing much better than what you were last year. So, and I'm happy to learn that you are also progressing in the field of hysteroscopy. You're learning the right way and teaching them the right way and doing the right way. So thank you and congratulations once again. Thank you.
With heart full of gratitude, we take all your compliments, sir. We are truly obliged for those compliments. And it's really motivating when you say that you teach, you learn, and then finally one day we will become like you. So we have another surgeon par excellence. See, all surgeons have beautiful different qualities. So I will call one more surgeon par excellence, Dr. Manish Machwe, sir, to add that his tinge of Dr. Manish Machwe to the valedictory function.
खूप उशीर झालाय मला माहिती आहे. दोनच शब्द बोलतो. एक नंबर कडक. थँक यू व्हेरी मच.
सर मला वाटतं आज तुम्ही दमले. So a huge myoma which he removed. So I think sir needs a little bit of coffee. Coffee पे चर्चा करेंगे. So we are really coming towards the end, and all this is not possible without the administrative support. Arrangements were done fine, but the permissions, the support, the guidance, and we are truly blessed to have such a good administration. I thank our executive director, Dr. Suchitra Nagre ma'am, for giving us all these permissions and always being by our side. And our dear principal ma'am, Dr. Sandhya Kulkarni, who is always there, whatever you ask for. Ma'am, I please call you on the dais to say a few words.
As Dr. Manish has said, it's too late. So truly it is too late. Good evening all. I'm just going to congratulate the team OBGY, and I'm looking forward the promise what Dr. Sushma has made. I think I had mentioned yesterday many more to come, and based on probably they have come up with this. And good, this year they have added some more teams to this laparoscopy. So I congratulate all of them. And sitting in this hall, many students are there. So I just want to, PG especially, I want to remind them what you have learned in medical education workshop and what Dr. Machwe has said. Learn, 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 because learning is never-ending process. I see some of the undergraduate students also, they must have taken up so many things from this particular class. So only word, learn, 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 keep learning. Thank you so much. Thank you.
Ma'am, we promise you that we'll keep learning, and our PG is also on behalf of all the postgraduates. I really promise you that we'll keep learning, and the undergraduates also. I think some of them must have taken some inspiration from the hysteroscopy workshop. And before we come towards the end, it is time to thank everyone who has given their immense support to us. For the vote of thanks, I call on Dais, Dr. Jaya Barla, our organizing secretary. Over to you, ma'am.
Thank you, Priya. As we draw close to this informative workshop, it is my great honor to deliver the vote of thanks. I express my sincere gratitude to our Executive Director, Dr. Sujitra Nagre ma'am and Dr. Virendra Kaisa sir for their unwavering support and encouragement. Their efforts in fostering a conducive environment for learning and collaboration is greatly appreciated. I thank our dear Principal Ma'am, Dr. Sadhya Kulkarni, for her support and guidance in organizing this workshop. Our medical superintendent, Dr. Darpan Mahesh Gauri sir, who has always granted permission for whatever we have asked for, and I thank you very much, sir, for that. Special thanks to our surgeons, Dr. S. Krishnan Kumar sir, Dr. Anurag Bhate, and Dr. Manish Machwe, and Dr. Swapnil as well, who have traveled all the way for this endoscopy workshop. And they have shared their invaluable experience and demonstrated various techniques of endoscopy. I also thank all the speakers whose contribution has been instrumental in making this workshop a resounding success. I thank the Maharashtra Medical Council for granting us 4 MMC credit points, and to the MMC observer, our very own Dr. Gopal Giri sir, who has supervised this workshop. I thank the anesthesia team for their support, and the staff of the wards and the OT for their organization, which ensured that everything ran smoothly. Their dedication and hard work behind the scene is truly commendable. I thank the support team, the audiovisual team, the IT team, the electrician, the canteen staff, and everyone who have been on their toes for these 2 days. I would like to thank all the delegates whose engagement and curiosity has made this workshop a dynamic platform for knowledge exchange. I thank my team, OBGY, for their active participation and enthusiasm in making this masterclass a great success. We are deeply grateful for our generous sponsors. We appreciate their commitment in advancing medical education. And I would like to call upon our head of the department, Dr. Vaishali Kode ma'am, to felicitate the sponsors that is there. From Aquino, we have Dr. Umesh Sarote and from Aquino, we have Dr. Umesh Sarote and Dr. Abhijit Ranade. Stores, Dr. Manish Sandeep. Sorry. Thank you, sir. From stores, we have Mr. Sandeep Kedekar. We have Spectra Vision Meditech, Dr. Nilesh Hutane. PRD, Mr. Abhay Chavan. From Pranav Medicare, we have Mr. Shailesh Surushti. Weber Histomat, Dr. Pankaj Mishra. From EVPR, we have Mr. Nilesh. Sambric Mediscience, Mr. Vivek Desai. From Suvidara Healthcare, Mr. Rajendra Singh. ASM, Mr. Vinay Dubey. From Merit, we have Mr. Yogesh Gausar. And from the audiovisual, we have Mr. Arvind. Thank you all once again. I wish you success in all your endeavors. I conclude the Endoscopy Masterclass 2024 and I request all to rise for Pasada.
माता विश्वात्मकी देवी वाग्यज्ञे सोषावे सूक्ष्मवदत्यामि पसाय दानहे देखणान्ति जगति परस्परे परो मैत्रदेवांते दुरिता विश्वस्वरं जो देवांते ततो देवा प्राणिजा वर्षत सकळ मंगळी ईश्वर निष्ठांची मांदियाई अनवरत भूमंत भेट तू भूता चला कल्पतम बोलते जे अर्णव पीयूषावे चंद्रमिंदे सदा सज्जन सोयरे हो तू किं बहुना सर्वसुखी पूर्ण लोकी भजिदो आदिपुरुषी अखंडित आणि ग्रंथोपदी विशेषी लोकीये दृष्टा दृष्ट विजये होवावे एक म्हणे श्री विश्वेश्वरा आहोरी दान पसाओ येणेवरे ज्ञान
Thank you. Please join us next year and tea and coffee will be served outside. Please give us the feedback forms.